check 1 2 1 2. हार्दिक Good morning, everyone. May I request everyone to settle down? Can I request everyone to please settle down? Sir? Good morning, everyone, and a very, very warm welcome on this Sunday morning to the 10th International Symposium in Diabetes, being organized by CMRE. On behalf of my co-director, Dr. Rajiv Chawla, I welcome all of you to this scientific feast. This is a symposium which is being jointly organized with AASD, the Arabic Association for Study in Diabetes, and DIPSI, Diabetes in Pregnancy Study Group. Just to go into the history, CMRE was conceived about 10 years back by Dr. Rajiv Chawla and me, and the whole idea was to propagate science. And I think for the last 10 years, we've been delivering a scientific feast every year, even during the COVID times when we had to go virtual, and I'm sure the success of the scientific program talks about the sustainability and the popularity of this event. This time we had 2 days of virtual deliberations, which was yesterday and day before. And I'm happy to share that we had a large number of logins, not only from India, but delegates from Southeast Asia and the Middle East, including Egypt, Cairo, and the Emirates. So to kickstart for today's proceedings, may I now welcome Dr. Girish Khurana to invite the chairpersons for the first symposium.
Good morning, everyone. So we are going to start our first symposium, which is on redefining pathophysiologies. May I call upon our esteemed chairperson, Dr. Vinod Kumar and Dr. Vipul Gupta. I think everyone knows Dr. Vinod Kumar. He has been a professor at AIIMS, Department of Endocrinology, and he was professor head at PGI Chandigarh. And Dr. Vipul Gupta is a practicing physician at Paschim Vihar, and I'll ask them to start the proceedings.
Thank you, Dr. Khurana, and thank you, Dr. Chawla and Dr. Jaggi, for having invited me. I would be chairing this session with help and encouragement from my co-chair, Dr. Vipul Gupta. Without much ado, there are 4 topics to be covered. Excellent program has been designed, and without any further, I would just request every speaker to stick to time, and we invite and welcome Dr. Wangnu to present his topic on ectopic fat in pancreas and heart. Dr. Wangnu, please.
Good morning, everybody. Thank you, sir, both the chairpersons. Well, ectopic fat, all of you know, is the deposition of fat in areas of the body where fat is not physiologically stored. Liver, kidney, brain, skeletal muscles, heart, and pancreas. So my focus today will be on the ectopic fat in heart and pancreas. Everybody know about the importance of fat deposition in the liver, kidney, brain, and skeletal muscle. The first, ectopic fat in the pancreas. Pancreatic fat, as we call the liver fat, and Dr. Chawla is going to deal with the MASLD, the new nomenclature of the fatty liver disease. Pancreatic fat, same, we call it pancreatic steatosis, like we call hepatic steatosis, and like we call NAFLD, now is MASLD. We call it non-alcoholic fatty pancreas disease, NAFPD. What does it mean? It means interlobular or intralobular infiltration of the adipocyte. You can see on the right hand upper histopathological slide, pancreatic intralobular steatosis. It also includes the accumulation of the intracellular lipid droplets of the pancreatic endocrine or the exocrine cells. So what are the risk factors? As we call about the cardiovascular risk factor, what is the risk factor for the NAFPD? Age, gender, central adiposity, metabolic syndrome, MASLD, hypertension, high triglyceride, hyperglycemia, and the ethnicity. आगे नहीं जा रही है स्लाइड, सर नहीं देखो आगे जा नहीं रही, आगे आ गया. Sorry, got it. Now coming to the pathogenesis and the progression. You know, like we have the stages of the MASLD, the fatty liver disease. We start with the fatty infiltration and the pancreatic steatosis and the underlying the risk factor which include, which I already mentioned, obesity, metabolic syndrome, insulin resistant, diabetes, age. To start with, we have the fatty infiltration. Then comes a stage of inflammation. What we call the steatopancreatitis, and we have the inflammation, what we call the lipogenic inflammation or the glucogenic inflammation, which increases the oxidative stress and which is an important underlying pathophysiological mechanism of the steatopancreatitis. Then ultimately when it progresses, steatopancreatitis, which may convert into the acute pancreatitis or may lead to the chronic pancreatitis, what we call the like chronic liver disease, leads to the associated exocrine and endocrine dysfunction, fibrosis, pancreatic cancer, acute to the same liver fibrosis, the hepatocellular carcinoma, and it's all because of the cell death and the neoplasia. The underlying cellular mechanism involve the endoplasmic reticulum stress, increase in the oxidative stress, mitochondrial dysfunction, islet inflammation, and the beta cell apoptosis. What are the clinical association? Now it is a new entity, NAFPD, the new entity in the metabolic syndrome. So the NAFPD include the metabolic syndrome, which is now also included in the definition of metabolic syndrome. Type 2 diabetes, it is associated with the severe risk, acute and chronic pancreatitis, pancreatic fibrosis, and the pancreatic cancer, which I already alluded to. Pancreatic fat as such increases the risk of metabolic comorbidities, which is like diabetes, metabolic syndrome, and the hypertension. And you can see the relative risk of developing diabetes 2.08, for metabolic syndrome is 2.37, and for the hypertension is 1.67. So the maximum increase in the risk of development of the diabetes. Now how the pancreatic fat is associated with the diabetes? The underlying risk factor like obesity, aging, alcohol intake, or any environmental factor with the viral infections, it causes pancreatic fat inflammation. Like in diabetes, we call the ileitis, initially the inflammatory response. And there is the intralobular and interlobular infiltration of adipocyte. There is the inflammatory cycle followed by the macrophage infiltration. It ultimately leads to the beta cell apoptosis and ultimately the glucose intolerance. And this glucose intolerance is a vicious cycle which continues to involve pancreatic beta cell with inflammation. And also the impaired lipolysis, what I call the lipogenic and glucogenic inflammation. There is an inhibition of adipocyte triglyceride, increased lipid droplets in beta cells, and impaired autophagy of the beta cells. Now coming to the, we talked about the diabetes, the obesity, effect of obesity on the pancreatic fat. If you see the two cartoons on the left and right, the left is the fat volume and the fat volume and the fat oblique parenchymal ratio, which was basically measured on the basis of the CT scan images in the both lean, overweight and the obese subjects. All components of the pancreatic volume, whether it is the fat volume, was significantly increased in overweight and obese individuals as compared to the lean patients. Now, a big question, like we talked about how to measure the liver fat, and Rajiv is going to basically explaining that. The pancreatic fat can be measured by simply by the ultrasonic, but the CT scan is having a good reproducibility, high specificity and high accuracy, while MRI and MR spectroscopy are the best spatial resolution and body mass composition differentiation, non-invasive, no exposure to radiation and with a high accuracy. The only problem, it is expensive and time consuming. What are the possible therapeutic approaches to reduce the pancreatic fat? Of course, the lifestyle modification, diet, weight loss, even the bariatric surgeries are shown to reduce the intrapancreatic triglyceride in type 2 diabetes. GLP-1 receptor agonist has been in use, more commonly with the liver fat, but also the liraglutide, dulaglutide also studied whether it really has an impact on the pancreatic fat, but there was no significant difference found in reducing pancreatic fat as compared to the liver fat. Pioglitazone is the possible target, which is also important in the liver, and further studies are needed whether it really impacts on the pancreatic fat. Now, let's start with the second talk, the second component of my talk, the ectopic fat in heart. What is ectopic fat in heart? If you see the upper right hand cartoon, they define as a visceral fat that deposits within the heart. And it develops from the brown adipose tissue and located between the myocardium and the visceral layer of the pericardium. You can see on the picture, commonly exists in the atrioventricular and the intraventricular grooves. And it also shares the same microcirculation as in the myocardium. And the fat deposition, they are the small adipocyte and mixed cellularity and metabolically very active as source of several adipokines, which really creates havoc in the patient of diabetes. Now there are two functions of the epicardial fat. What is the normal epicardial fat and abnormal epicardial fat we deposit in the because of obesity, hyperglycemia. The normal epicardial fat has got some physiological function, mechanical, metabolic, thermogenic, and also some protective secreting factors. Normally the nature has given that this epicardial fat has the compressibility and elasticity that can mechanically protect the coronary artery against excessive distortion caused by the artery pulse and the myocardial contraction. Because you can see around the coronary artery the ectopic fat. And metabolic, highly active free fatty acid oxidation you can see on the left hand cartoon and supplies energy to the myocardium in terms of the free fatty acids. Thermogenic, increased expression of the uncoupling protein 1 and related genes. Thermogenesis is similar to the brown adipose tissue because brown adipose tissue has lot of the increase in the UCP1 and UCP2 ratio and it protects the myocardium and coronary from the hypothermic damage. And it also produces certain cytokines involved in the regulation of endothelial function like coagulation, inflammation. Adiponectin and adenomedullin are the cardioprotective adipokine which are secreted from the epicardial fat. And also some of the epicardial fat I told you, it is not basically in the epicardium, also pericoronary adipose tissue which is an extension of the epicardial fat, and intramyocardial fat which is the infiltration of the adipocyte from epicardial adipose tissue to the myocardium. The non-adipocyte and the cardiomyocytes have a very limited capacity to store excess fat if they are exposed to the high levels of plasma levels, as typically seen in obesity. They can undergo steatosis and loss of function, ultimately resulting in cardiac lipotoxicity. How you can measure the epicardial fat? if you have the basically experienced echocardiography, he can measure the epicardial fat by simply doing the 2D echo. And he can measure the thickness of the epicardial fat in at least two locations RV free wall. You can see the upper cartoon. MRI, the fat generates a strong MRI signal, and both thickness and the volume of the epicardial fat can be easily measured with the MRI. Non-contrast CT scan measures both thickness and the volume, more sensitive and accurate, but is a cumbersome but has got a longer radiation exposure. Now I told you the epicardial fat is the basically harbor the stems, the seeds of the various diseases like obesity and the heart disease. Because epicardial adipose tissue may turn into an adverse lipotoxic, prothrombotic and the pro-inflammatory organ, which I am going to explain you. And in fact, this is a marker. If you measure the epicardial fat, this is a marker of the visceral adiposity and significantly independently lead to the metabolic syndrome. It independently correlates with the various cardiac risk factors, insulin resistance, fasting plasma glucose, creatinine intimal media thickness, liver enzymes, and the inflammatory markers. Associated with presence and severity of the coronary artery disease in the left and right ventricular mass and diastolic function, and also associated with the atrial fibrillation. And epicardial fat correlates very well with the visceral adipose tissue. Depending on the BMI, you can see the very good correlation between the epicardial adipose tissue and the visceral adipose tissue. Not only the obesity and the sugars, it also correlates with the multiple cardiac risk factors. Important one being the diastolic blood pressure and the insulin resistance, apart from LDL, adiponectin, sugar, HDL, CRP, leptin, and fibrinogen. And I told you that the abnormal epicardial fat is the source of inflammatory mediators, which has a good role in the atherosclerosis and coronary artery disease. There are many articles in the literature to show that the correlation between the epicardial adipose tissue and the coronary artery plaque characteristics. And it was seen the epicardial adipose tissue is increased in the presence of obstructive coronary artery disease and is an independent predictor of the presence of plaques and with the non-calcified component. It also predicts, I told you, diastolic dysfunction, and you can see in healthy subjects and the patient, the myocardial and hepatic triglyceride content in patient are controlled, and it is highly increased in patients with the myocardial and the hepatic triglyceride content, and is directly correlated with the diastolic blood pressure. Now some of the mechanistic explanation why this abnormal pathophysiological action of the epicardial fat apart from the physiological, which I already mentioned you, because excessive free fatty acid synthesis and release, it causes modulation intramyocardial fat content, intrinsic inflammatory status, and it is the biggest source of secretion of pro-atherogenic and pro-inflammatory adipokines, and directly correlates with the coronary artery disease and mechanical relation with the impaired biventricular diastolic relaxation and correlation with the atrial fibrillation. Now, if you see, I told you there are two cardioprotective, the cytokine, one is adiponectin and adrenomedulin, which they are down-regulated, and that is why they protect the person from the developing coronary artery disease. But others like leptin, resistant, TNF-alpha, IL-1, IL-6, MCP-1, they are upregulated in the patients of the diabetes with the excess of epicardial fat, and you can see the cartoon depicting very simply diagrammatic presentation of the various function of the inflammatory cytokines, how it leads to the development of the atherosclerosis and coronary artery disease. A word about the arrhythmia. Like in patient with obesity, when we have increased epicardial adipose tissue, it leads to the anatomical obstacle to the cardiac excitation. It also causes increase in the oxidative stress and reactive oxygen species, and also has a paracrine crosstalk with the myocardium, and all of them lead to the cascade of metabolic abnormality like increased activation delay, decrease in action potential, increase in resting membrane potential, and increase in the fibrosis, and they are all atherogenic, arrhythmogenic, and it may lead to the atrial fibrillation. So last but not the least, my 2 slides, because I am just closing on my time schedule, that epicardial fat extension, whether it has a role in heart failure with the preserved ejection fraction. You can see the lifestyle modifications are very important for any problem. In the patients with the epicardial fat expansion, I told the underlying pathogenetic mechanism which may lead to the excess of cardiomyocyte stiffness, fibrosis and inflammation, which may be one of the important cause of the heart failure with preserved ejection fraction. And also some of the drugs which might be useful in cutting down the various abnormality for diabetes, in myocardial stiffness and the epicardial fat extension are the various drugs which were used in the diabetes management. Now coming to these strategies, what I talked about the pancreatic fat, incretin stimulation, PPAR gamma, the pioglitazone, statins, SGLT2 inhibitor, lifestyle changes and genetic modification to increase the visceral adipose tissue to the brown adipose tissue. Weight loss has an important impact to reduce the epicardial fat, and we have seen the role of statins can reduce the epicardial fat. There was a very good article in 2010 where they have seen the atorvastatin was better as compared to the combination of simvastatin, ezetimibe in reducing the epicardial fat. The one thing that type of statin matters in reducing the epicardial fat. Third, the metformin also significantly decreases the epicardial adipose tissue thickness, and there was a statistical significant decrease in epicardial adipose tissue thickness and after 3 months of the metformin therapy in patients of type 2 diabetes. GLP-1 receptor agonist, they also know they could not do much with the pancreatic fat, but it has been seen that weekly administration of semaglutide and daily administration of liraglutide causes large and rapid epicardial fat reduction, as they have seen in the liver. SGLT2 inhibitor, which has been commonly used for the MASLD, it also seen that SGLT2 inhibitor dapagliflozin causes reduction in the epicardial fat thickness in patients with type 2 diabetes and obesity. So ladies and gentlemen, to summarize, the non-alcoholic fatty pancreatic disease or the ectopic fat in pancreas is associated with the pathophysiology of the diabetes and pancreatic diseases. Ectopic fat in heart can be epicardial fat, pericoronary adipose tissue or the intramyocardial fat. Epicardial fat is a multiple function to support a healthy heart, but when it becomes abnormal, it has an abnormal pathophysiological phenomena which leads to a lot of problem in the myocardial stiffness, atrial fibrillation and coronary artery disease. I told you the ectopic fat is associated with coronary artery disease, cardiac hypertrophy, cardiac dysfunction, also atrial fibrillation. Drugs targeting the lipids and the glucose control, what I enumerated right now, can reduce the epicardial fat. So it opens a new vista that most of the drugs we are using for diabetes management not only reduces the liver fat, it also reduces the epicardial fat, but very less action on the pancreatic fat. Thank you very much.
Thank you, Dr. Wangnu, for such a nice talk on ectopic fat in pancreas and heart. We'll take up the questions at the end of this symposium.
Actually, I have another talk on the other hall.
Okay.
Okay.
So you come and join us on the dais, sir.
Okay.
For the next talk in this symposium, I invite Dr. Rajiv Chawla, Diabetes, Cardiovascular Disease and MASLD. What is the link? Dr. Chawla, please.
May I have my slides? Good morning, everyone. Once again, it is my pleasant duty to welcome you all on behalf of CMRE-ASD Diabetes in Pregnancy Study Group India to extend warm welcome to all the delegates, those who have made it early morning. The first session we kept it very, very conceptual, and let's revise our basics from physiology days, and that is what I requested Dr. Wangnu when we allocated him this topic, that let's talk about ectopic fat, you do pancreas and heart, and let me talk about an ectopic fat in the liver. Early days we have been talking about NAFLD in non-alcoholic fatty liver disease, but of late, since 2020, we are now saying it's a metabolic dysfunction associated fatty liver disease, MASLD. And just to share with you, March 23, this name has been further changed to MASLD, that is steatotic liver disease. So earlier days we have been talking of a spectrum, starting from non-alcoholic fatty liver disease, going into steatohepatitis, liver fibrosis, cirrhosis, and hepatocellular carcinoma. And it is estimated that about 25% of the global population suffers at any given time from MASLD or MASLD. And NASH is 2 to 3 times higher in persons with obesity or type 2 diabetes. And MASLD is again very, very common. Almost 50% of the world population, those who are obese, they do have MASLD. Slide is not moving. Yeah. So it's a spectrum of disease, and it has certain set diagnostic criteria. When we define NAFLD, there has to be an evidence of hepatic steatosis, either by imaging or by histopathology. And again, when we talk about NAFLD versus MASLD, I'll be alluding to that fact. For NAFLD, we need to have lack of secondary causes of hepatic fat accumulation. So we know during the course of the disease, when you are obese or pre-diabetic, and then you gradually go into type 2 diabetes, this is how a normal liver looks, and then it goes into NAFLD, NASH, fibrosis, and cirrhosis, further going into a higher risk for developing HCC also. So NAFLD encompasses a wide range of liver damage, starting from a normal liver, going into NAFLD, going into NASH, where there has to be a ballooning. So moment you have more than 5% fatty infiltration into the liver, it is labeled as NAFLD. But then you have to have ballooning of the hepatocytes, some amount of degeneration, Mallory bodies getting formed before we can say it is in NASH. And of course, cirrhosis, which tends to be the end stage, it has to be with advanced fibrosis, and it is here the risk of developing HCC is very, very high. So it follows a rule of 25. 25% amongst the entire population, you tend to have NAFLD, more so in type 2 diabetes, pre-diabetes, or obese people. Out of that, 25% will go into NASH, and out of that, another 25% unfortunately will develop cirrhosis. And again, over 10 years, all those who have already developed cirrhosis, 25% are at a much higher risk for developing HCC. So it is very, very important to identify this dynamic bidirectional association between NASH and metabolic dysfunction. It is all about insulin resistance, which might set in much before the onset of type 2 diabetes, at the stage of pre-diabetes or obesity. And it is insulin resistance with dysregulated metabolism, which is common to development of both NAFLD, NASH, and also may predispose those patients, those who are pre-diabetic, to development of type 2 diabetes. So this is how it is bidirectional. It is not that obese and pre-diabetes is predisposing to NAFLD and NASH. NAFLD or NASH is also probably increasing the risk of developing type 2 diabetes in pre-diabetes or obese patient by almost 2.2-fold, which is almost double the risk. So this is a truly bidirectional relationship, which is there starting from insulin resistance as a core defect. On one hand, you have those patients, those who are already pre-diabetic or established type 2 diabetes. On another hand, you have all those patients, those who have already into a stage of NAFLD or NASH, and it is hyperinsulinemia, which is a common soil hypothesis, which not only increases overall systematic insulin resistance, leads on to de novo lipogenesis, worsening, and then leading on to progression towards NASH, while NASH itself also further induces insulin resistance, leads on to compensatory hyperglycemia. There is a beta cell dysfunction which sets in. There is a relative insulin deficiency which happens and then predisposes all those patients, those who are yet pre-diabetic or simply obese, to a greater risk, what I said, almost double the risk of developing type 2 diabetes. So let me allude to what is the difference between NAFLD and MASLD or MASLD. Metabolic dysfunction associated fatty liver disease, the term I told you recently coined in 2020, which refers to fatty liver disease which is related to systemic metabolic dysregulation, and this is having a simple set of criteria to make a diagnosis. This is not a diagnosis by exclusion, what we have in earlier days talking about NAFLD. So that is why it has a superiority in terms of not only diagnostic criteria, but also in terms of prognostic criteria over the years, because if you follow these patients, they are at a much greater risk of developing terminal liver failure, and they carry not only that, much higher cardiovascular mortality. And this is what I am saying, that it is diabetes, insulin resistance, type 2 diabetes, MASLD or MASLD, and then there is a much higher risk of developing CVD. So hepatic stenosis at any given time with more than 5% with type 2 diabetes, with couple of metabolic risk abnormalities, of course, overweight or obesity will lead on to MASLD. But then you have set criteria, 2 out of 7 criteria, which could be in the form of raised BMI, it could be in the form of waist ratio, different for Caucasian and Asians, blood pressure simply more than 130/85, plasma triglycerides simply more than 150, which every pre-diabetes or obese patient will have, and HDL, which is typically low in Asians or in Indian patient less than 40, a stage of pre-diabetes or a homeostasis model suggesting that there is an insulin resistance more than 2.5, with plasma high sensitivity C-reactive protein, which is again a very, very sensitive marker for developing CAD. So a diagnosis of NAFLD, MASLD or MASLD is, I told you, NAFLD is primarily by exclusion of secondary causes of liver disease, but when you are saying it is MASLD, it probably is much more comprehensive. It gives you a holistic approach that these patients could have comorbidities like thyroid dysfunction. Obviously, most of them are obese. They tend to have obstructive sleep apnea. There are extrahepatic malignancies which are much more common in MASLD. And of course, a systematic disorder like type 2 diabetes, metabolic syndrome, obesity, maybe certain cognitive disorders or cardiovascular disorder, they are also part of this MASLD syndrome with CKD and osteoporosis also. So here is a positive diagnostic criteria versus a negative diagnostic criteria, what we have been talking earlier as NAFLD. Here we are making a diagnosis based on certain set criteria, not by simply exclusion, but because NAFLD used to be a very, very nebulous diagnosis. I told you it used to be based on primarily that there is exclusion of harmful alcohol intake. But are you sure, or do you know that in alcohol intake, even 30 ml could many a time could be noxious to the liver. So simply by saying that someone is not consuming enough alcohol, because you are trying to exclude a alcoholic fatty liver disease versus NAFLD, and then there is always, this carries a stigma, so there is a underreporting by the patients, and you are never sure that even a mild alcohol intake could also do more harm than anticipated. So there are overall benefits of MASLD. Patients who met MASLD criteria, they tend to have much higher enzymes. Their alanine transferase are much higher as compared to the NAFLD. They tend to have much poorer liver prognosis in the long run, and of course that stigma is not there because many Hindu Brahmins, maybe females and Jain, you cannot even ask, cannot even dare whether you are taking enough alcohol or no. So there is always an underreporting. So this bidirectional risk, type 2 diabetes or pre-diabetes, not only increases the risk for MASLD by 2 to 6 fold, which is a very, very high risk. Presence of MASLD even before the onset of type 2 diabetes also predisposes to diabetes by almost 2.2 times higher risk. And unfortunately, both gone together, they carry a much cardiovascular risk. So it is seen that MASLD with CVD is a much greater risk. MASLD diagnosis assists in identifying these patients, those who should undergo a further cardiac evaluation, even if they are asymptomatic for presence of CVD or coronary artery disease, and they tend to have much lower EGFR versus MASLD, and it has shown in many studies and evidences that it tends to have a much stronger association with many chronic lung conditions, also with breast lesion and malignancy. So probably a MASLD diagnosis is much more meaningful than simply putting it as NAFLD or NASH in presence of type 2 diabetes. I told you NAFLD is when there is a pure steatohepatitis, steatosis more than 5%. Moment you have an element of fibrosis added to that, it is already NASH, it is going to progress towards cirrhosis, and of course the risk I told you 25% is over 10 years time for developing that HCC, which carries a very, very high mortality. So if you have a histopathological look, a normal liver versus a fatty liver, which is not only bulky, you could see there is already a ballooning of the hepatocytes, some amount of perihepatocytic infiltration. So when we talk about MASLD in setting of type 2 diabetes, it honestly seems to be an inter-organ crosstalk between what Dr. Wangnu very rightly said, between adipose tissue and ectopic adipose tissue, pancreas, gut and liver, not to put this complicated slide, but this is a bidirectional and it is an ongoing phenomena. This could be the spectrum of MASLD starting from steatosis towards earlier days what we said at NASH or MASLD today, and then towards cirrhosis and end-stage liver disease. So first hit could be that I told you it is insulin resistance, which is the core defect. Insulin resistance into the adipose tissue, into the muscles, also unfortunately into the liver. Moment there is a insulin resistance into the adipose tissue, it increases lipolysis. It leads on to reduction in adiponectin. So there is going to be increased triglyceride influx synthesis, which is going to induce lipotoxicity. Those triglyceride-derived metabolites are going to do a lot of harm to mitochondrial dysfunction, going to induce ER stress. There is going to be a Kupffer cell hyperplasia, that stage of inflammation going on with fibrosis and terminal cirrhosis, and HCC risk goes up. So let's see why it is all happening, why it is all starting with insulin resistance. Probably it is, we keep blaming Western people. There are already people sitting here from UK. I'll not say that it is Western lifestyle. We are probably equally bad. We tend to have NAFLD. I'll be showing you one study of ours. Even in non-obese type 2 diabetes, NAFLD is very, very high. The way you pick it up, that is important. But of course, a high calorie intake, excessive saturated fat intake, high fructose intake and sedentary lifestyle, which induces the cycle, and this nexus goes on. So this is a poor nutrition, and over-nutrition in the form of high fat, high carbohydrate and high fructose, which coupled with certain genetic predisposition, PNPLA3 genotype, which puts it at a very, very greater risk for having large chain fatty acid, DAGs, ceramides, and of course a visceral ectopic fat, what Dr. Wangnu very nicely alluded to, induces inflammation. I told you there is going to be lipotoxicity, and subsequently it evolves into fibrosis and HCC. So here is a schematic representation of putative mechanism underlying the contribution of NAFLD to increase risk of not only CKD but also CVD, because an expanded dysfunctional adipose tissue will lead on to myocardial steatosis and increase pericardial fat on one end. So not only it induces dysglycemia, it also leads on to atherogenic dyslipidemia. There is an increased inflammatory oxidative stress, a stage of hypercoagulable stage which is there, or a procoagulant stage which is there in setting of type 2 diabetes, which induces arterial hypertension also. So one end you not only have increased cardiovascular risk, another end you also have a high risk for CKD and arrhythmias. So this is how a liver heart nexus or misconnection goes on moment you have insulin resistance and a stage of further evolution. So all these patients need to be screened ideally by non-invasive techniques, and all those patients, those who have been screened maybe clinically by an ultrasound, and they have evidence of early grade 1 or grade 2 fatty liver, what a typical ultrasound reflects every time. They must be screened for enzymes, and moment enzymes are found to be on the higher side, their risk for NAFLD should be evaluated. Of course, an ideal way is to do a liver biopsy, but then, well, that is not possible most of the time. That is why we need to depend on non-invasive markers to look for presence of NAFLD and NASH. And of course, it can always be, the first investigation can be in the form of ultrasound, but then certain biomarkers. Fibrosis risk score FIB4 is a typical one which can take you to the diagnosis, with transient elastography, which are now acceptable and non-invasive procedure for getting to the diagnosis of NAFLD. So a metabolic workup must be done in every patient, every pre-diabetic, obese or type 2 diabetes patient, starting with an ultrasound, looking for liver enzymes, these biomarkers. If steatosis is absent, you leave them alone and follow them after 3 to 5 years. If you have normal enzyme, but you do a fibrosis marker or a FIB4 score, and risk is low, you can follow them every 2 to 3 years. But if there are enzymes which are already on the higher side and you do a risk scoring, it is already 2 to 3 FIB4 score, then obviously these patients need to be screened and risk stratified every 1 year. A NAFLD fibrosis score could be incorporating age, BMI, hypoglycemia, platelet count, albumin, AST and ALT. So in NAFLD fibrosis score, anything more than 0.65 is a sort of predictor of presence of significant fibrosis, while anything less than 1.45, it almost rules out presence of fibrosis. RFE is again very good non-invasive technique, and acoustic radiation force impulse elastography, short of getting an MR elastography, and this is what we did in one of my own DNB students project. We looked into non-invasive technique by doing an RFE score in all those patients, those who were established type 2 diabetes, but they were lean. They were lean by Indian criteria and their BMI was less than 23, and we were surprised in this cohort of about 100 patients, there was a much higher prevalence of NAFLD, which was already established in these patients. So coming on to the management, very shortly I'll touch upon, this is not the topic I should discuss in detail. Anyone who has pre-diabetes or type 2 diabetes with obesity with at least 2 out of 7 metabolic criteria, as I told you, must be screened for presence of ALT or AST. Rule out other causes of, if it was NAFLD, of course we need to rule out all other causes of hepatic dysfunction, but for NAFLD, we need to do a positive screening, and most important thing will be here to identify risk factor, talk about reduction in weight, better glycemic management, control their blood pressure, and try to address their atherogenic dyslipidemia, because if you do their scoring, if it is low, probably you can leave them alone for 2 to 3 years. If score is very, very high, then obviously we need to be on a very, very invasive or very, very fast way. And treatment, I'll not go into the details, but primarily drugs are not much to do. It is probably with the lifestyle modification we may do. So it has to be a holistic approach. That is what is the advantage of having a diagnosis of MAFLD versus NAFLD. Not only energy restriction is important, reduction in fructose intake, daily alcohol intake has to be absolutely very, very less. A physical activity of more than 150-200 minutes on every weekly basis, and macronutrient composition has to be addressed. It has to be low to moderate fat, moderate to high complex carbohydrate intake, and low carbohydrate ketogenic diets. And of course, if we can ensure a weight loss of more than 3%, probably we may reverse steatosis in 1/3 to 100% of patients. If we can somehow ensure a weight loss more than 5%, probably we can also to some extent check the ballooning and inflammation. Anything more than 7% weight loss could actually resolve NASH, but if you can ensure maybe by pharmacotherapy, lifestyle modification, there are drugs like GLP-1 receptor agonist oral versus injectable, and you can ensure a weight loss more than 10%, probably even fibrosis can be reversed. Drugs don't have too much role, PPAR gamma or dual PPAR alpha gamma like seraglutazar, antioxidant vitamin E, PVN trial said that non-diabetics you could use vitamin E 800 milligram, but then the risk of hemorrhagic strokes is very, very high. Pioglitazone is still a wonderful drug for all those patients, those who are diabetic. In that cohort, it was seen that it made some difference. But I think promising drugs based on management, when we talk about atherogenic dyslipidemia, because these patients are at a much greater risk, we need to stratify. If they have a very high risk, statin have to be in very high dose. We must ensure LDL less than 55. And when coming to diabetes management, if risk is low, they can be simply on metformin, pio and other drugs. If risk is very, very high, we must ensure that these patients should be on GLP-1 receptor agonist, because that is the only drug proven to reduce fibrosis or reverse fibrosis. Short of that, those who cannot afford GLP-1 receptor agonist, they can be on SGLT2 inhibitors. So to sum it up, a non-invasive screening for early diagnosis is very, very promising. It could be in the form of RFE, starting from ultrasound, MR spectrography or elastography. Lifestyle modification still remains extremely important. Role of exercise and weight reduction is paramount. Drugs like pio, vitamin E, statin still require probably much more prospective evidence, and bariatric surgery is still promising, but still the final word is not out that this could be the treatment for MASLD. Thank you very much for your patience listening, and welcome Professor Mohan. Thank you.
Thank you, Dr. Chawla, for a wonderful presentation and having convincingly proved the point that the recent terminology of MASLD is a better terminology. We'll discuss it at the end. Now I invite the next speaker, Dr. Sunil Gupta. His topic is effect of weight loss on cardiovascular risk factors in diabetes. Welcome, Dr. Gupta.
Good morning, everyone. Thank you very much, Chairperson, for this invitation. My today's talk is on the effect of weight loss or weight gain on the cardiovascular diseases. And I should congratulate Dr. Rajiv, Dr. Shalini, and the whole team of CMRE for this wonderful event. And it was nice evening yesterday to be there with the international faculties. There's no conflict of interest for this particular session, and I'm going to speak on some slides on introduction, obesity and glucose intolerance in cardiovascular disease. We have some data showing you that how the weight loss can benefit the cardiovascular risk factors and cardiovascular disease outcomes, and the carry home messages. I feel everyone knows that global obesity epidemic is very well established. Now we call it as a diabesity, or it's a diabetes, and obesity itself is very much there across the globe, with increasing obesity prevalence almost since 3 decades. Obesity contributes directly to the cardiovascular risk factors, including dyslipidemia, hypertension, diabetes, obstructive sleep apneas, and others. Obesity also leads to the development of cardiovascular disease and CVD mortality independent of the other risk factors. More recent data highlights the abdominal obesity as a central obesity as an independent risk factor for cardiovascular disease. Cardiovascular disease, when we say it's a leading cause of death across the globe, and it is even higher, it's a top leading causes of the premature death globally. And cardiovascular disease actually is, the death rate mortality is much higher than even cancers. Now there are some cardiovascular risk factors, which could be environmental, metabolic, and behavioral. If I just focus on the metabolic and some of the behavioral, it's blood pressure, LDL, so we say A, B, C, A for A1C, B for blood pressure, C for LDL cholesterol, kidney dysfunction, and obesity as a whole. And of course we have diet and smoking. They are the other risk factors which are focused. When you talk about obesity and cardiovascular risk, it's the insulin resistant, dyslipidemia, hypertension, neurohormonal disturbances, ectopic fat, we just heard, endothelial dysfunction, and pre-thrombotic state, which is responsible for various complications of obesity that includes your coronary artery disease, heart failure, various kind of arrhythmias, peripheral artery disease, and ischemic strokes. Oh, it's not moving? Yeah, okay. I'm not going too much in detail of the pathogenesis of morbid obesity and the overweight and the various pathophysiological mechanisms, but various hormones they play a different role, which includes your leptin, GLP-1, insulin, peptide, YY, CKK, ghrelin, and these various hormones interplay, responsible for various mechanisms in your body, which includes your appetite, your eating behavior, energy expenditures. And if it goes haywire, then you'll end up with inflammation, insulin resistance. It's the hyperinsulinemia, which is the most important culprit in obesity, which is responsible for endothelial dysfunction, coronary calcification, coagulation activation, RAS activation, and sympathetic overdrive. And this leads to a complication as an outcome, and that comes to diabetes, atherosclerosis, hypertension, and dyslipidemia. Now, when we talk about the population attributable risk, that means the proportional reduction in the population disease that would occur if the exposure to the risk factor were reduced to an alternative ideal exposure scenario. That means if you really address here, I'll just use the pointer if I can. Yes, I am able to do that. So if you just address abdominal obesity, it is likely that the cardiovascular disease will be reduced by around 20%. If you address lipid, around 50%, smoking, psychological, around 33%. So obesity plays a major role in reduction of the cardiovascular diseases, and it's one of the very important modifiable risk factor. Now, if you just have the reduction of your weight by 5%, it may lead to the adiposity related complication improvement. Cardiometabolic risk profile may improve. If it is around 10%, may have the benefit on the diabetes related endpoints as well as cardiovascular events. And if you lose around 15%, more than 15%, then the possibility of having diabetes remission. Now, even apart from the weight reduction, if you have an enhancing metabolic rate, which is because of the exercise and good dietary habits, so any healthy dietary habits of healthy diet, exercise, and metabolic boosters if you use, and if you reduce your obesity, this is also going to have a healthy outcomes. Now let me take you to some of the data we have. The association of weight fluctuation, like you have glycemic variability, here they have seen the weight variability, where they have compared those with the no weight change as a reference point, and they have extremes have been compared: continuous weight gain, weight maintenance after weight gain, weight loss after weight gain after weight maintenance, weight loss after weight maintenance, weight cycling, so ups and downs, and weight maintenance after weight loss, and continuous weight loss. And I tried to compare most of the cardiovascular outcome here is a total event, percent years, the hazard ratios, and the p-value. If you see that compared to no weight change group, the continuous weight gain revealed to be deteriorating the cardiovascular disease free survival with the odds ratio of around 2.36 here, which was statistically significant. So the deterioration in the cardiovascular disease is more common. I'll have a disclosure here. The number seems to be little smaller versus all others where you have higher numbers. But on the right side, if you see the weight maintenance after the weight loss, so you lose some amount of weight, and if you maintain it well, it is again giving you statistically significant benefit when it comes to survival versus if you go on gaining the weight. Similarly, the coronary artery disease, if you see the weight maintenance after weight gain have significantly reduced the coronary artery disease. So you have to again see that weight loss, whatever you have achieved, should have a weight maintenance here, and the weight maintenance after the weight gain may have little benefit. What about the stroke risk? Only continuous weight gain was significantly affecting in increasing the chances of stroke. Rest of them have not shown to be significant. Cardiovascular disease related death rate, there is no significant impact of the BMI maintenance status in the cardiovascular related death rate, probably due to very small number of CV deaths. Now we have deliberate weight loss, and we have the drug related, it's a programmed or whatever the trials we have as on weight reduction, they are deliberate weight loss. So we talk about first bariatric surgery, can they reduce cardiovascular event? So this bariatric surgery has clearly shown to have long-term benefits, and it has shown almost in 70% of the patients have shown remission. So in a review, one of the randomized control trial and 9 cohort followed for more than 5 years, almost 48% reduction in the macrovascular event, around 80% reduction in the mortality with the bariatric surgery. What about the weight loss because of the drug? So you have rimonabant, which is now not available in the market because of its psychiatric issue, but you have a data of 18 months treatment. It has reduced the weight loss around 3.8 kg and reduced the normalized atheroma volume in the coronary ultrasound, which was statistically significant. Now you have, I feel intermittent fasting is everyone knows about it. So alternate day fasting versus continuous energy restriction, and the data from 12 months study compared with the so almost similar diet on both the arms. There is no difference in the blood pressure, LDL cholesterol increase in alternate day at 12 months, but there is no difference in the triglyceride and cholesterol concentration. So both of them are comparable. Now this is the look ahead trial, benefit of the modest weight loss in cardiovascular risk outcomes. So here around 5,000 patients, and they examined the association of magnitude of the weight loss and changes in the cardiovascular risk factors at 1 year, with the odds meeting to the various predefined criteria and the risk factors in type 2 diabetes. So HbA1c reduction was significantly reduced as with the increasing weight loss. So less than 2%, 2 to 5%, 5 to 10%, 10 to 15%, more than 15% weight loss. So higher is the weight loss, better is the HbA1c reduction. Higher is the weight loss, more increase in the HDL concentration and reduction in LDL was borderline. What about the blood pressure? Systolic blood pressure as well as diastolic blood pressure was significantly reduced with the p-value of less than 0.001, and even triglyceride has found to be significantly reduced in the more you lose weight, more amount of triglyceride reduction. So look ahead trial have achieving more of a meaningful changes. If you just see systolic blood pressure, diastolic blood pressure, HbA1c, HDL increase, LDL reduction, triglyceride reduction, more amount of weight loss from 2 to 5, 5 to 10, 10 to 15, and more than 15%, the odds ratio is in favor of all the risk factors of cardiovascular disease. Let's go to some of the drugs like semaglutide, step 1 and step 4 data analysis. And they had around 68 weeks trial, randomized control trial, 2.4 milligram of drug, and 20 weeks semaglutide run over for 48 weeks, more than 30 or more than 27 BMI, and they have seen all the risk factors of blood glucose, blood pressure, lipids, and insulin levels. And what they come out with is there's the leading to superior weight loss, may improve numerous cardiometabolic risk factors like overweight without those who don't have diabetes. So waist circumference, systolic blood pressure, fasting blood glucose, fasting insulin level, HOMA-IR, lipids, every parameter got improved. There are also reduction in the use of antihypertensive and lipid lowering drugs with semaglutide. We have now twin creatine, that is tirzepatide. Around 2,500 odd patients have been randomized to 5, 10 and 15 milligram, and 72 weeks trial have been shown. And they have again shown that there is increasing weight loss from 15% to almost 21%, and also the weight loss started very early in the study and going up to 72 weeks. Higher is the dose, higher is the weight reduction. Now, do we have some meta-analysis on the weight loss versus cardiovascular risk reduction? So this was a meta-analysis and of 7 studies, including around 18,600 patients. Of them, 8,600 were on the intervention group, around 9,900 in the control group. And they have shown most of the studies have shown beneficial effects of the intervention on the weight loss as per of the weight loss studies on cardiovascular risk reduction. So you have all-cause mortality as well as cardiovascular mortality found to be beneficial in the intervention group versus control group. And this is the weight loss with different drugs available from very early days of the orally state still available to tirzepatide. Weight reduction is important. So this is a suggested algorithm we have for the selection of the anti-obesity medication. So those who are having obesity, maybe Asian, we say more than 27 years, Of course, 23 onwards we have overweight, up to 25 onwards we have obesity. So we have we consider age and comorbidities, more than 65, less than 65, all medication. I'll just take you to this particular panel here. So if you want to have the benefit of cardiovascular and diabetes or glucose intolerance, liraglutide, orlistate and semaglutide. Depression, possibly most of them. But I'll take you to those who have pancreatitis. Here we have limitation of using the GLP-1 analog or the incretin-based therapy, and you have other drugs to be used. Rest, most of the drugs, most of the fields of complications associated with diabetes and obesity, like cardiovascular disease, depression, NAFLD, obstructive sleep apnea, and hypertension, and others, they are quite beneficial. And this is the future of the drugs which are in research when it comes to obesity, as GLP-1 and glucagon dual agonist, which is phase 2 and phase 1 trial. We have GLP-1 receptor agonists, few more. Leptin sensitizers, still not there in the market. Amylin analog like caglinitide, now it's written here phase 2, but I feel we have even phase 3 trials going on with the caglinitide along with semaglutide, and we have some other appetite suppressors which are going to be in the trial in future. We have some procedures, different procedures have different benefits, some limitations, but I'll just take you to the gastric bypass sleeves and some, if you just go for the sleeve bypass, achieving around 49% of the excess weight loss in 5 years, that's what they say. And if it is gastric ballooning, 7 to 15%. There's some aspiration therapy, which is 14 to 18%, and gastroplasty is 12 to 19%. So to summarize, we have medical nutrition therapy, which includes the diet, exercise, and the behavioral changes. You have anti-obesity drug, you have bariatric surgery, and you have some of these drugs which I already alluded to you. They all can be used, and most of the drugs, when they are giving you weight loss, also having associated risk reduction in the cardiovascular risk factors and the benefit. To conclude, weight maintenance is important. It's not only the weight loss. After the weight loss, you should be focusing more on to the weight maintenance, which is more favorable to BMI maintenance status, and as far as cardiovascular health is concerned. And weight cycling was also significantly protective. Weight loss attempts should be included in the prescriptions. And now we should start writing obesity as a disease and weight reduction, exercise, and MNT in your prescription apart from the drug. I would like to give my humble thanks to the team of Diabetes Care and Research Center, Nagpur. We all invite you for the National AeroCon, All India Association of Advancing Research in Obesity. The conference name is Obesity India 2023 on 2nd and 3rd December. It is to be held for the first time in Central India at Nagpur. So I invite you all. Before I conclude, I wish you all a very happy Ganesh festival, forthcoming Eid, Gandhi Jayanti, Navaratra, Dashera, Deepotsav, World Diabetes Day, Merry Christmas and Happy New Year in advance 2024. Stay safe, stay healthy, keep smiling. Always, 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 whenever you celebrate any occasion, whether it's birthday or anniversary or inauguration or anniversary of the center itself, instead of cutting a cake, if you cut the fruit, that will be a very positive message to the population to prevent them from atherosclerotic heart disease. Thank you very much for patience listening.
Thank you, Dr. Sunil, for making us aware that reducing obesity will help us reducing all the risk factor for cardiovascular disease. You can join us on the dais. We'll take up the questions later on. Moving on to the next in the symposium, diabetes and CKD, we have Dr. Mohammad Hasnain. He is not there physically. He'll join us on the video. He's already there.
Thank you for the warm words and kind invitation, and it's great to be with you again in this very impressive agenda and meeting. Again, I reiterate what I mentioned in my lecture on Friday, that Unfortunately, I'm not with you in person. I look forward to be with all of you in person in the future. And indeed, I'm very thankful for the organizing committee, the very good friends, Dr. Rajiv Shaula and Dr. Shalini and all other colleagues who have made this important event a huge success. I look forward to be with you in the future. And the topic that I have to cover now is about diabetes and chronic kidney disease. Are we achieving the treatment targets? I'm conscious, obviously, that my very good friend, Dr. Wasim Hanif, have covered some of the aspects of this. What I will try to address is the issues that are related to whether we are addressing and getting targets or not. Obviously, just as a simple introduction, we have seen a huge rise in problems related to renal problems, cardiac problems, and stroke, and indeed microvascular disease in people with diabetes. And we know that we need to address the 4 pillars of the problem, including the cardiorenal protection of specific agents, glycemic management, and the risk factors, as well as weight management. And I want you to remember these 4 parameters, because this is what we will look into in our assessment of whether we're achieving the targets or not. In my previous presentation on Friday, I have highlighted to the guidelines that we have recently published, joint cardiometabolic guidelines, which include how should we screen people for cardiometabolic, and of course, the renal function is a very important aspect of the screening. Any person with type 2 diabetes, they would need their serum creatinine, eGFR, as well as albumin-creatinine ratio being checked. And of course, those who would be screened positive would include those who are with an abnormal renal parameters. To focus on what should we do in this sort of simple cartoon, a person with diabetic renal problem would need an SGLT2 inhibitor with evidence. They might need a GLP-1 as well, an ACE inhibitor or an angiotensin II antagonist, finerenone, and high-intensity lipid-lowering therapy would all be recommended for a person with renal problems. But obviously, we need to address with this the lifestyle modification of the person with chronic kidney disease, who would also be a person with cardiometabolic disease, with their diet, with the weight loss, with the smoking, with the exercise, with the sleep, with the stress. The lifestyle really is crucial. And here we focus on this particular person with renal impairment would be among the high cardiometabolic, the very high cardiometabolic problems. And here we'd say that they would need an SGLT2 inhibitor or a GLP-1 with evidence, regardless of their glycemic control, according obviously to what is their renal function and what is allowed to be initiated or intensified if necessary, if the glycemic control is not good. And of course, the blood pressure needs to be less than 130/80 using an ACE or an ERB, and getting an LDL of below 55 milligrams per DL using a high-intensity statin, plus or minus other lipid-lowering agents to get the target, and antiplatelet therapy would be indicated here. Now, the reality is maybe different than what we recommend. And it's an important point to look into this. During the process of looking into a survey of people who are fasting Ramadan, we looked into the characteristics of a large cohort of patients, including people with chronic kidney disease from the cohort of the 2020 that we published. And in this cohort, there was nearly 600 persons, where their mean age is 60 years, and as you can see, obviously they will have a long duration of diabetes. So focusing on those with green, in comparison with those with the total cohort, you can see that the person with CKD is older, as well as with longer duration of diabetes. And the overall prevalence of cardiovascular problems is in a quarter of them, in comparison to just 11% in the total. And the vast majority of them will be on insulin. of nearly 70% of this cohort. To go a bit into details, there will be more proportion of males, regardless of the type of problem. So focusing on orange here, which is the CKD, 55% of them will be males, 45% will be females. HbA1c, unfortunately, is not well controlled with a mean HbA1c of 8.7. Hypertension is in the vast majority of them, of 82%. And indeed, hyperlipidemia is in two-thirds of them. Nearly 50% of them will have retinopathy. Neuropathy is in 38%, and foot problems in 7.6%. So clearly, this person with CKD is a person with lots of comorbidities, with long duration of diabetes, and with an average age that is a bit high. When you look into what are we doing in this problem, are we prescribing the right drugs? And again, the survey was going from Morocco until Malaysia and Singapore East. So unfortunately, again, concentrate on CKD patients. So treatment with SGL2 with cardiovascular evidence was only in 14%. Treatment with the GLP-1 with cardiovascular evidence was only in 4% in people of CKD. Treatment with both was 1.2%, and treatment with either was only 15%. So this is obviously a serious problem. Now, is it related to wealth? Well, I don't think that's the case, because when we look into the subgroup from Saudi Arabia and from UAE, the level is a bit higher. Here CKD is in blue. The level is a bit higher, but it's not achieving targets at all. The maximum we have for CKD is 23%. Clearly, there is a lot more that needs to be done. Now, it's very important to understand that this is an important class of drugs that we know the evidence and we are not addressing. Now, is it funding? Perhaps it is, because when you look into GLP-1s, the vast majority of GLP-1 prescribed is in green, which is Saudi Arabia and UAE. When you look into SGL2 inhibitors, and here, thanks to generics, the highest proportion of prescribing was from Pakistan, particularly, as well as India and Bangladesh. And when I asked the colleagues there, they said it is because of the availability of generics. So it's very important to utilize the drugs with evidence. And I'd like to reflect on our hospital in Dubai. We have a fantastic new building and we have lots of new facilities. And we try to do our best. Here, 2 years ago, we looked into data from our center on patients with an eGFR of less than 60. The vast majority of them are stage 3A, which is obviously eGFR above 45 or above. Another 25% is stage 3B, and stage 4 and 5 are only 16%. The split of gender is there is higher proportion of males, as we saw from the other data as well, which matches what's going on globally. Now, again, very matching data. Nearly 80% of the group of people with eGFR of below 60 are above the age of 60, similar to the data that we saw in the global survey, and are still, unfortunately, that 8%, HbA1c above 8%. Here, the situation is a bit better, where only a quarter of the patients have an HbA1c of 8%, another quarter are between 7 to 9. So if we want to be idealistic and say, let's get them all to below 7, then we need to address nearly 50%. Obviously, the target change according to age and comorbidities. So probably you would say between 25 to 50% needs improvement in the glycemic control according to their health status. LDL is a lot easier, and you should be trying to achieve this in a far much better proportion than the current situation. 95% of our patients are not putting LDL above 5, above 50, sorry. Now, if we could go to relax it a bit and to say, let's try to get it below 70, then we are talking about nearly 33% are within the target, and the rest are above the target. Systolic blood pressure is another cause of concern. Some people for CKD advocated systolic blood pressure below 120, that's only 14%. Some would be happy to be below 130, and that's 16%. So basically, if you're optimistic, 30% are within target, and probably more need to be, a lot more need to be within the target. Diastolic blood pressure problem is a bit easier. Below 70 is 41, below 80 is another 32%, so nearly 73% are below the diastolic of 80. So that's a lot better. Obesity in this group of people is high, 50%, or to be precise, is 49% of a BMI of 30 or more, so certainly this needs to be addressed. So clearly, my friends, again, we need to modify guidelines to the local needs, identify the barriers and the challenges, and think of interventions to promote the implementation of guidelines. Having excellent buildings is great, having excellent guidelines is great, but what we need is the implementation. But to do so, we need to monitor and evaluate and look into outcomes, because we know from the Swedish data that from this fantastic data that was published 5 years ago, even in people with type 2 diabetes, if we address the big 5 risk factors, we will be able to save so many comorbidities and so many mortalities. And finally, I leave you again with my beautiful city of Alexandria and look forward to any questions for my presentation. Thank you.
Thank you very much. I think you would agree with me that we had an academic feast provided to us by the 4 learned speakers, and now the all these 4 papers are open for discussion. Any comment or question, please?
Sir, we have seen basic causes insulin resistance. Until now, it is evident that pioglitazone is the best drug for long term to ameliorate insulin resistance. But on the other hand, pioglitazone also increases weight. So then, what will you advise? Whether we should give even in pre-diabetic, or we say insulin for insulin resistance, still pioglitazone holds the good, and how much dose it should be?
Your question is, I think, directed to Dr. Bangno.
Dr. Wango or Dr. Chawla? I am saying that in insulin resistance, still the best drug is pioglitazone. On the other hand, it increases weight. Then do you think that pioglitazone should be the first drug for insulin resistance in all the cases which you have described? Or then if it is, what should be the dose?
See, in terms of pharmacotherapy, I didn't go into the detail because that was not the topic. But it is very, very clear in terms of hierarchy. We only data in NAFLD or NASH we have is the PVN study, where they enrolled around 98 or 99 patients, 3 groups, placebo, vitamin E, high dose 800 milligram, and pioglitazone. But their pioglitazone use was 30 to 45. So that data is also not very relevant to pioglitazone. That finally concluded that versus placebo, of course, lifestyle modification is the crux. Nothing goes better than lifestyle modification in NAFLD or reversal. It said that if patient is non-diabetic, then vitamin E is a good option versus placebo, but the risk of continuing 800 milligram of vitamin E in the long run carries the risk of hemorrhagic strokes and few malignancies. In the diabetic group, it was seen that if you're using pioglitazone till 45, they have used 30 to 45, to some extent, not only there is a enzyme reversal, and to some extent inflammation also settles, but fibrosis does not change. But of late we have now data with semaglutide, injectable and oral, and very few studies still on with saroglitazar. Saroglitazar is good molecule for all those patients, those who have very high triglyceride with NAFLD, because that influx gets changed and free fatty acid will go down. But SEMA is the only drug which has shown benefits in terms of reversal of even at the stage of steatohepatitis to fibrosis. But that still is not a very large data, but it is encouraging data. So in view of starting pharmacotherapy after metformin, maybe pioglitazone, those patients, those who are diabetic, it is worth putting them on GLP-1 receptor agonist, that, or if they cannot take, they don't tolerate, or they cannot afford, then SGLT2 has shown reversal in steatosis, but not reversal in fibrosis. But it is, as I've shown in my slide, lifestyle modification, weight reduction from 3 to 5 to 7 to 10%, which can ensure almost total reversal from NASH stage.
Any other question or comment, please? We have overshoot the time by 10 minutes. So if there is one more question, it can be asked. Yes,
Sir,
please. Can you please tell your name?
I'm T.M. Agrawal.
Thank you.
Sir, Dr. Chawla, you have mentioned about the coffee in MASLD. Can you elaborate more backed by some scientific data? Coffee, role of coffee in MASLD.
I've shown in one slide, again it is not significantly substantiated that coffee will have a positive role. Very few studies are there where it is mentioned that it could be of some use.
We can have coffee in the coffee break.
Yeah, sure. Go ahead.
For liver benefits, you require at least 30 milligrams. So if patient is already having good glycemic control, you may cut down on secretagogue or DPP, for which may not serve any purpose. Make a space for pioglitazone there, but then at 30 milligram, side effects of pioglitazone are also going to be more apparent.
All said and done, I think lifestyle modification would be the key. Reduction of weight rather than the medication should be the key, and we should focus more on weight reduction. With this, we close this session, and I congratulate all the speakers for such a nice deliberation.
Thank you, thank you.
Now I'll request Dr. Vinod to present a memento.
So now I request our eminent chairpersons to honor our speakers with a memento. May I request Dr. Vinod Kumar to present a memento to Dr. Rajiv Chawla, sir. Dr. Sunil Gupta, Dr. Vipul. So with this we come to end of this symposium. Coming to the second symposium, may I request our eminent chairpersons. Yeah, okay, yes. Now I'll request our speakers, Dr. Rajiv sir, to present a memento to Dr. Vinod Kumar sir, and Dr. Sunil Gupta to present a memento to Dr. Vipul. So now coming to the second symposium on concept and practice, may I request our chairpersons, Dr. Surjadip Sen Gupta, to come over the dais, and Dr. Rucha Mehta. Dr. Rucha will join a little bit late. May I request Dr. Surjadip to start the session and to invite our speakers.
Good morning, everyone. At the outset, let me thank Dr. Rajiv Chawla and Dr. Shalini Jaggi and team CMRE for inviting me and Dr. Rucha to chair this important session of concepts and practice in medicine. The first talk would be on pleiotropic effects of glucagon by Professor Devjit Tripathi from the US. Glucagon has generated a lot of interest in present-day diabetology in terms of, both the concept as well as the possible and potential benefits in terms of management. So, Professor Devjit Tripathi is a endocrinologist in San Antonio, Texas. He is a professor of medicine in the University of Texas Health at San Antonio. He is a staff physician at the ALM VA Hospital at San Antonio, and research focuses on pathogenesis of diabetes and mechanism of action of novel medications. Over to you, sir, for the presentation.
Okay, so I would like to thank the organizers, particularly Dr. Rajiv Chawla, for the invitation, and it's great to be here again. And this is, I think, my second or third time I'm speaking on Dr. Chawla's symposiums. So this is I don't think any other topic in this symposium on glucagon. So the reason I picked this was because from now on you'll be hearing a lot about certain anti-diabetic medication using glucagon agonists. So as a practicing endocrinologist or internist, you all know that role of glucagon treatment of diabetes is treatment of hypoglycemia. As till now, that's the only indication or use of glucagon. However, I'm going to show you some novel effects of glucagon which can be used for treatment of type 2 diabetes. So is glucagon a friend or foe? So you guys decide after I show you some data. So the first I'll show you the role of glucagon in normal physiology, and then glucagon in the pathogenesis of type 2 diabetes, and some recent studies showing effect of glucagon agonists. So this is the historical perspective. It was discovered a long time back. The name glucagon comes from the fact that when early pancreatic extracts were injected, they used to raise glucagon. So the glucose agonist, that's what the name came from, glucagon, glucose agonist. And so the glucagon is actually derived from a prohormone. It's called proglucagon. And because of there's a differential processing of proglucagon in the alpha cells of the pancreas and also in the in the intestines and the brain. So in the pancreas, it is processed, cleaved by this enzyme called PCSK2 to give rise to glucagon and other intervening peptide. Whereas in the small intestines and in the central nervous system, this is cleaved to gives rise to GLP-1 and GLP-2. So now glucagon has effects on many organs. I can show you the effects of glucagon and GLP-1. They are complementary at certain sites and antagonize each other at certain sites. For example, in brain, both GLP-1 and glucagon lead to suppression of appetite, decreased food intake. And whereas in pancreas, although both glucagon and GLP-1 actually increase insulin production, they both are insulin secretagogues. However, glucagon in the liver, glucagon leads to increase in hepatic glucose production. However, the GLP-1 reduces hepatic glucose output. And then stomach, they have complementary, both reduce gastric emptying time, delay the gastric emptying. That's why it leads to better effects on glycemic control. And in the adipose tissue, glucagon causes lipolysis, whereas GLP-1 do not have any direct effect on adipose tissue, but glucagon causes lipolysis. So just to show the normal physiology, the glucagon is actually, secretion is inhibited in high glucose conditions. Is the beta cells cause insulin secretion, whereas the glucagon secretion is inhibited at high glucose. Whereas in the low glucose condition, insulin secretion is inhibited and the glucagon secretion is increased. Now, the regulation, how the glucagon secretion is regulated. The most important regulator of glucagon is glucose and insulin. So glucose actually has a direct and indirect effect on the direct effect. It can directly act on the alpha cells to inhibit glucagon secretion. And the indirect effect is through insulin. The high glucose leads to high insulin, that will lead to inhibition of alpha cell or glucagon secretion. And amylin is also another peptide co-secreted with the insulin that also inhibits glucagon secretion. And then glucagon in turn will act on the liver, leads to increased liver glucose. Those delta cells in the pancreas secrete something called somatostatin, also inhibit the glucagon secretion. So the primary regulators of glucagon secretion, endogenous regulator, are glucose and insulin and somatostatin. And GLP-1 actually inhibits glucagon secretion and increases insulin secretion. GIP, or the glucose-dependent insulinotropic polypeptide, that also increases insulin secretion, but it actually increases glucagon secretion. So the GLP and GIP has opposite effects on glucagon secretion. Okay, so the glucagon receptors are present in many sites. We know the primary effect is on the liver, but there are also receptors in adipose tissue, brain, and adrenal gland, and also the myocardium. The primary role of glucagon is to maintain plasma glucose between the two meals. Like after overnight period of fasting, the hepatic glucose production is maintained by glucagon levels. And it plays also a role in lipid metabolism, in food intake, and satiety, as well as amino acid metabolism and energy expenditure. And this is the main effect of glucagon in glucose metabolism, that it causes increase in glycogenolysis and gluconeogenesis and decreases the glycolysis. That's how it increases the hepatic glucose production. So it was as early as 1971, actually 1974, Unger et al. From Dallas, they shown that the diabetes is a result of hyperglucagonemia or is insulin deficiency. They both coexist, low insulin, high glucagon pathogens type 2 diabetes. And this is showing some data from our own studies. It's well known that glucagon levels are high in diabetes and type 2. However, the earlier studies were compounded with the fact that type 2 diabetes and IGT were usually mostly obese or higher BMI than NGT subject. So here we collected data from about 300 patients with who are obese, both NGT and IGT and type 2, they are all obese, then compared the glucose and insulin and glucagon levels during OGTT. There's not much difference between IGT and NGT, whereas type 2 diabetics had a higher glucagon levels during the OGTT. Now, if you measure the fasting glucagon level, you don't see much difference between the three groups. However, the fasting insulin levels are higher in type 2 diabetes and IGT. So if you take the ratio of glucagon to insulin, you'll see a clear difference between the NGT and IGT and obese subjects. So then we also looked at the relationship with insulin sensitivity and beta cell function, and the three categories of subject NGT, IGT, and type across different tertiles of insulin sensitivity. So the one on the left is the lowest insulin sensitivity, and they have the highest glucagon level here. The one on the extreme right, they have a higher insulin sensitivity, more insulin sensitive, and they have the lowest glucagon levels. So the glucagon not only depends on the levels of plasma glucose and insulin, also related to ambient insulin sensitivity. And on the right panel is the beta cell function on the x-axis, and the y-axis the fasting plasma glucagon. Although there is those who have very high, good beta cell function have a low glucagon, the relationship is not as linear as you'll see in case of insulin sensitivity in plasma glucagon levels. And next we looked at the effect of mild glucotoxicity on glucagon levels. This was one of the DeFranco studies. He was looking at effect of glucotoxicity of insulin sensitivity, and I looked at the effect of mild glucotoxicity on plasma glucagon levels. So there are two protocols in which healthy subjects came in and we infused glucose for 2 days. In another, we infused glucose for 3 days to make them slightly hyperglycemic. And then after end of 2 days, they underwent 3-step insulin clamps. The other protocol, after 3 days of mild hyperglycemia, they underwent a 2-step hyperglycemic clamp. Once glucose went to 225, then up to 400. And here are the data from the glucagon levels after 2 days of hyperglycemia. These are all healthy subjects, but after 2 days, you can see the plasma glucagon levels, insulin levels were higher after that suggests that they kind of induced some kind of mild insulin resistance after 2 days of glucose input. Although the glucose levels are same, the plasma insulin levels are really higher. And after 72 hours hyperglycemia in healthy subjects, again you see the post-glucose infusion, the insulin levels are also higher. And the glucagon levels, if the insulin levels are high, the glucagon levels actually should be suppressed. But here you see that even the glucose levels are high, the insulin levels are higher, the glucagon levels are also high, suggesting there is a resistance to the suppressive effect of insulin on glucagon. So if you measure something called glucagon sensitivity, that's the product of fasting insulin and glucagon. So after mild hyperglycemia, you induce something called glucagon resistance. And again, the same thing we show here, that after 72 hours of glucose infusion, you induce something called glucagon resistance. And here the first 10 minutes, then 30 minutes. This is amplified percent. You can see a clear difference after 30 minutes that the glucagon to insulin ratio is higher after mild hyperglycemia. To summarize, so there's mild physiologic hyperglycemia can induce something called glucagon resistance or resistance to the suppressive effect of insulin on plasma glucagon. So now coming to the other effects of glucagon. So we know that glucagon is the important hormone which measures lipolysis, particularly in the liver and also main adipose tissue, and increases ketogenesis and also decreases plasma cholesterol and decreases liver triglyceride content. So that's why this has been also proposed to as a treatment for MASLD or NASH. And now Dr. Chawla discussed it. So glucagon may play a role in treatment of NASH. So this is a study, this is not published, but we presented this as oral presentation AD and ESD, looking at effect of hyperglucagonemia. So we infused glucagon for about 12 hours in healthy subjects and measured their insulin sensitivity. So after infusing glucagon for 12 hours, you see the glucagon levels are much higher. And this is the control arm who got saline. And you see there's an increased level of palmitic acid and total free fatty acid, suggesting that there is increased lipolysis when you infuse glucagon to healthy subjects. And then also, although it's well known that it causes increased hepatic glucose, how it causes hepatic glucose production is not known. To show here that is increased gluconeogenesis following short-term hyperglucagonemia. So to summarize, that short-term hyperglucagonemia actually induces lipolysis and reduces de novo lipogenesis and increases hepatic glucose production by promoting gluconeogenesis. So again, so now I showed you all the data that glucagon is bad. Actually, it causes lipolysis, it causes increased glucose. Then how can it be a friend? So the other effects, the primary effect, as I told, increases the glucose production, but is the other effects of glucagon which can be utilized for treatment of type 2 diabetes. For example, its effective insulin secretion, effects on appetite, and the gastric motility. So combined with GLP and GIP, these novel effects of glucagon can be used for treatment of type 2 diabetes and obesity. However, is both glucagon antagonists and glucagon agonists, both are being tried for treatment of type 2 diabetes. Like GIP, both antagonists and agonists are being tried for treatment of type 2 diabetes and obesity. So it's been shown that if you, in animal models, if you knock out glucagon receptors, you lower the glucose levels. So there have been initially a few years back, there have been a lot of glucagon antagonists being tried for treatment of type 2 diabetes. However, those clinical trials are aborted because all these glucagon antagonists led to increase in liver enzymes, and there's increase in LDL cholesterol level, and then also led to beta alpha cell hyperplasia. Then subsequently, the role of glucagon in energy expenditure, satiety was examined. Is a study in which subjects received placebo, GLP-1, glucagon, GLP plus glucagon. You can see that when you give the glucagon, you raise the glucose level. When you combine GLP with glucagon, the glucose is slightly elevated, but not as much as when you infuse only glucagon. And the insulin secretion, actually you see much greater insulin secretion when you combine GLP-1 and glucagon. And here the effect on glucagon energy expenditure. So when you combine GLP and glucagon, you see much higher energy expenditure compared to glucagon, GLP-1 alone. And also the carbohydrate oxidation is increased when you combine GLP and glucagon, and the fat oxidation is decreased when you combine GLP and glucagon. So to summarize the glucagon effect on energy expenditure, it increases resting metabolic rate and increases the effects are mediated by activation. Some studies have shown maybe activated brown adipose tissue. However, in humans, those are animal models shown that it is activated activation brown adipose. In humans, the data is not clear. This is one study in which they looked at the energy expenditure of glucagon. And as you can see, glucagon, exposure to cold temperature actually increases energy expenditure. And also similarly, you see the same effect with exposure to glucagon. And this is showing some PET scan looking at the energy expenditure. In adults, humans, the brown adipose tissue is very limited, only located in certain regions around the sternum and on the upper part of the body. And you can see with cold exposure, there's increased activation of the brown adipose tissue, although there is no such activation seen with glucagon or patients who do not have BAT negative. So in humans, the glucagon causes increased energy expenditure, but it's not through the activation of brown adipose tissue. So in the cardiovascular system, the data is not clear. I'm not going to go over this. But in earlier days, glucagon was proposed as treatment for heart failure because it has some chronic, it has a positive kind of chronotropic and inotropic effect. But there's a review of literature showing that the data of those studies were really of poor quality and short duration. So one cannot really comment on the effect of glucagon on cardiovascular system. So for the new method therapeutic approach for treating metabolic disease, that you combine several different molecules, or you can have something called unimolecular multi-agonism. I'll talk about later when we talk about the incretins. Just for an example, where you combine GLP and GIP, you can combine GLP, GIP, and glucagon. The different molecules being now currently tried. And this was the study in which animal models showing that very Matthias Schaub's group show that there's very promising results. And this is the first study tried in a couple of years back, an animal study showing that glucagon, GLP, and GIP actually showed very promising results in animal models. Subsequently, there are several trials and different GLP and glucagon agonists. This drug which actually the AstraZeneca had developed and Novo had developed glucagon and GLP-1, but they were aborted because lack of efficacy. So again, I'm just showing you these are the complementary effect of glucagon GLP-1. So now we have a new drug which has been developed by Eli Lilly and showing promising results. I'm showing you what they do is they combine GIP, GLP-1, and glucagon. And as you can show, the GIP has the effect of improves insulin sensitivity. GLP-1, glucagon have no effect of insulin sensitivity. And GIP increases insulin secretion, and GLP-1 also increases insulin secretion, and glucagon also increases insulin. So there's a complementary effect of insulin secretion. And then satiety, both decrease in satiety and increase appetite, and both glucagon, GIP, and GLP-1. And in addition, they also glucagon causes decrease in gastric emptying. So if you combine GIP, GLP, and glucagon, you see a synergistic effect on weight control, weight management, as well as insulin secretion. Again, this is just to show you the mechanism of action of all when you combine GLP, GIP, and glucagon. And this is the first trial of the triagonist showing promising result. This is a phase 1 trial, phase 1b trial, showing the triagonist showing about the reduction in A1C about 2% and remarkable in weight loss. So this is the early study showing that this particular compound developed by Eli Lilly, GLP, GIP, and glucagon agonist showed comparable safety profile to other incretin agonists, marked improvement in glycemic control and body weight, and also had improvement in lipid profile. Then this compound is developed called retatrutide, which is the data I'm going to show you. It's been published last year. I just submitted some concept data. And this is novel triagonist derived from GIP backbone, and it has the GIP activates both GIP, GLP, and glucagon. And it's mainly activates the GIP receptor, which is about 9 times more potent than native GIP. The GLP-1 glucagon receptor activates actually 2.5 for less than native GIP and GLP. And it has a half-life of 6 days, so that you can give once a week. And I'll show you the data. So this is just published in New England Journal of Medicine recently. And last month, the triple hormone, that's GLP, GIP, and glucagon data. And shown, this is a study about slightly more than 6 months data, actually almost close to 1 year. And you can see that the body weight loss, this is in patients with non-diabetic obese subjects, you see 24% up to the highest dose, more than 20% weight loss. Again, this degree of weight loss is not seen in any other compound, even though it's better than tirzepatide, which can see 15%. So, and this weight loss has not yet reached the plateau. That means if you increase it for maybe 2 years or more, maybe it will go more further. So it is only 1 year data. And so the effect on, so the percent of subject achieving weight loss, see about 20% had 30% more than 30% weight loss. And this meant 25, more than 25 weight, usually this kind of weight loss you see only in bariatric surgery. You don't see them with the medication. And here, this particular compound, you see up to 25% have, 30% have more than 25%. And so this is in terms of weight loss and glycemic control, this is remarkable efficacy, even superior to, I would say, the other incretin mimetic, the tirzepatide. So in the non-diabetic obese subject, it shows both weight loss as well as I'll show the data on the glycemic control. Actually, almost 70% of subjects who are IGT became NGT when you this at the end of this trial. And the safety profile was similar to other incretin, like comparable to that of semaglutide versus tirzepatide. So, and about 15% weight loss was seen more than 60% of patients and 72%. As we know that the DPP study has shown that even if there's a transient normoglycemia, that is long-term or memory effect, that is that the risk of developing diabetes is lower to those who develop transient and NGT. So in this case, this particular compound, 72% of obese subjects IGT reverted to NGT within 6 months. And the efficacy, I would say, comparable, superior to other GLP-1 receptor agonists. And the GI adverse effects were mild to moderate comparisons like that you've seen in other. And then this is the retro. This is patient with type 2 diabetes, just published in Lancet in August. And the active comparator here was dulaglutide. And the randomized to receive several doses of retatrutide versus dulaglutide. And again, the results here is the hemoglobin A1C decreased by 2.16 per 2%, and much superior than that of dulaglutide. And the weight loss, you don't see, and the number of patients achieving, remember, these are all diabetics, and almost 80% had A1C less than 6.5%. And about 30% became normal glucose tolerance after 48 weeks of this particular drug. And the body weight loss, you don't see that much weight loss in diabetics compared to non-diabetic obese subject, but still you see almost 15% weight loss with this compound in a period of 36 weeks. So the number of subjects achieving, and this is on the effect on lipids. You see there's not a dose response curve, but the triglycerides significantly decrease and non-HDL cholesterol levels are significantly decreased with this compound. And other cardiovascular risk factors such as the systolic blood pressure decrease, the diastolic blood pressure also decreased significantly with the higher doses of this retatrutide. And overall, the adverse events, everybody, almost 70% will have some adverse effect like nausea, vomiting, and diarrhea, but the number of serious adverse events were actually low. And here you will not get an idea what the percentage. I would say about 30% will have some kind of nausea and vomiting, like other GLP-1 agonist incretin mimetics. And again, the overview of the adverse events. So it's not very clear, but I would say about 30% will have mild to moderate adverse events. So to summarize, this GLP, GIP, and glucagon co-agonist has significant and meaningful improvement in glycemic control, which appears to be superior to other GLP-1 agonists. And the weight reduction that you see is greater than that with seen in other incretin mimetics. And participants, and as I showed, the weight loss has not yet reached plateau. That means if you extend the trials for more than a year or 2 years, you may observe greater weight loss. And it also improved the cardiovascular risk factors such as the systolic and diastolic blood pressure, and also the tolerability of the adverse event was similar to other GLP-1 agonists. And so the findings of this study suggest that this could play an important role in treatment of type 2 diabetes and obesity, and possibly with non-alcoholic liver, fatty liver disease that Dr. Chawla was talking about earlier, or NASH. There are no studies yet, but glucagon has been being considered for treatment because glucagon, what it does, it increases fatty acid oxidation, particularly in the liver, so it decreases liver fat also. So I think that is the last slide about just an overview about glucagon and type 2 diabetes. Thank you.
So thank you very much, sir, for elaborating on the pleiotropic effects of glucagon. Can I ask you to join me out here on the dais? I'll just hand it to my co-chair.
Good morning, everybody, and it gives me great pleasure now to call on stage Professor Wasim Hanif. Professor Hanif, as we all know, he has been with us several times. He's a professor of diabetes and endocrinology and head of services in diabetes at University Hospital Birmingham. He's also honorary professor of medicine at University of Warwick. He's a board member of Center for Diabetes, Endocrinology and Metabolism, University of Birmingham, and the director of the Advanced Diabetes course, and on the board of governors of trustee of Diabetes UK, and also on the non-executive director of BMJ on its board. He's an eminent authority with several publications on diabetes, obesity, and ethnic health. His research interests include diabetic kidney disease prevention, as well as cardiovascular disease and diabetes. He has been a chief and principal investigator in several international trials, and of note, he has also been in the UK ADS, the Asian Diabetes Study. So who will be better than him to talk to us today about diabetes prevention and remission, translating evidence into clinical practice, lessons learned. Over to you, Dr. Hamid.
Thank you very much, Chair, for your kind introduction. And first of all, I would really like to thank the co-chairs for this event, Dr. Chawla and Dr. Shalini, for their kind invitation. It's an absolute pleasure. I think this has been in the making for a few years, but it's great to be here at this thing, at your conference, which is, I'm really enjoying it, really high quality scientific work, and to meet my colleagues right from Dr. Mohan to Inas, from both from India and abroad. Now, diabetes prevention has been something that's been working on it for about nearly 2.5 to 3 decades. And if you want to understand diabetes prevention and remission, the concept is very simple. Let me put a kind of a proposal to you. So, in 1971, the prevalence rates of diabetes in India, can anybody guess how much were there? Less than 2%, 1.7% in urban India and 1.5% in rural India. And now we are in 23, and a few of us, I can see Colin here, so we were probably alive in 1972. We were born in 1972 or before that. And in this our lifetime, we are now currently seeing the prevalence rates of India in 20%. I was reading a report somewhere in Delhi, the prevalence rates in above 40 or above 50 is about 60%. So what has happened? Now, a lot of my colleagues have been talking about a lot of novel things around genetics, epigenetics. I don't think so by any stretch of imagination of natural selection, the genes would have changed so much. So what has changed? Very simple, lifestyle. So type 2 diabetes is a disease of lifestyle. So if you want to prevent the lifestyle, just reverse it. Just change your lifestyle. Go back to what you were doing in 1970s or 80s, and diabetes will go away. Now, to prove that point, we have to do a lot of evidence, and I'm going to be present that, work with lots of governments to change policy, work with a lot of people to put in public health measures. But the only way the tide of type 2 diabetes can be turned is through lifestyle management. No amount of drugs, no amount of GLP-1s or GIP-1s are going to save us. So this is the 4 great men who discovered insulin and transformed the lives of people of type 1 diabetes. And what they were doing was tackling a condition in which the beta cells of the pancreas are destroyed either by autoimmune process or by genetics, and you require insulin. Insulin per se is probably not the medication for people with type 2 diabetes, but that's a debate for another day. We all know diabetes is a global emergency and the numbers are rising. So along with the rise in the numbers of people with diabetes, what is very important is to look at this as to what the numbers are. And this is a beautiful modeling that was done by Bevan and colleagues from UCL. And what they actually looked at is not the current prevalence rates, but they look at the various models in the UK which were dependent on a number of factors. Factors like whether the people are changing the lifestyle, whether there are enough cycle lanes for people to drive their cycles, whether there are public health measures in place to reduce sugar, fat, salt in the blood, salt in the food, whether there were any prevention programs going. And what they found was that if everything was going fine in the UK, you see the curve in orange, the prevalences of diabetes will not rise. But if these are not in place in the UK, then by 2035 we are going to have nearly 15 million people, and then you can understand the population of UK is about 65, 69 million. So what you are really seeing is that how effective public health measures will be in turning the tide of diabetes. So why preventing diabetes or remission diabetes is important? The principal reason is important is going to cost us a lot of money. A lot of money, especially if people are going to develop diabetes under 40, which we are seeing in India, even in the UK, in the Asian populations. And also it's going to cause a lot of morbidity and ill health and death in these people. So therefore, and that is going to affect populations, because once if you're 20% of your population is unhealthy by any means, it is going to have a huge impact. So what is happening? So as the rise in people with diabetes, what is rising is the treatments that are available for diabetes. So this is, if you look at the hypertension class of drugs, there has been a kind of a steady rise, that after every 4 or 5 years a new antihypertensive medication comes into the market. But with diabetes the story had been different. So we had insulin in the 1950s, we had the insulin in the 1950s, and then nothing came up till 1960s when you had sulfonylureas, which came from an antibiotic, followed by the bigonides. But since then, and then there was a big halt till mid of 90s, and then this happened, that almost there is a compound coming in every 3 months or 4 months that is more effective for type 2 diabetes. And the main reason or the main driver for this is the increasing population of diabetes. So more and more diabetes or type 2 diabetes, from being a lifestyle disease, is now becoming over-medicalized, where we start treating people from the moment they are obese. Now we have got medications that we are using for people with a BMI of 27 for them to lose weight. So we are over-medicalizing this condition. So what's new in diabetes? So what's new in diabetes is the same thing: patient-centered approach, patient-centered approach, and patient-centered approach. Now let's look at prevention and remission. I'll probably examine the evidence and some of the public health measures. Now this is an old Chinese saying you must have seen a number of times. It says that superior doctors prevent disease, mediocre doctors treat the disease before evident, and inferior doctors treat full-blown disease. So I'm an inferior doctor because I treat people with kidney disease, with NAFLD, with all kinds of things. So if I want to be a superior doctor, I have to start preventing diabetes. So what causes type 2 excellent talks, one by Dr. Chawla, an early speaker who talked about this. I'm not going to go into more detail, but it is a very simple thing. As we all get fatter, the fat starts depositing in the wrong places, and especially if you don't have subcutaneous envelope, which is true in an Indian population, then the fat goes and sits in the liver and in the pancreas. And these are the worst places for the fat to sit. And if you can make people lose weight, and especially for a huge amount of weight, then we can reverse diabetes. Now this was an excellent paper by K.M. Narayan, and Dr. Mohan is here. He has done an amazing work, which is basically trying to look at 2 different concepts of diabetes. One is around metabolic capacity and one is around metabolic load. Now most of the Western models of type 2 diabetes that have been studied by Alberti and the others on Pima Indians are based on the metabolic load, on the insulin resistance. Now because a lot of work did not happen in early years, it's happening now, the same concepts have been used in Indian population, which is a disease of metabolic capacity or less insulin secretions. So one of the things we have to be careful is when we are talking about prevention and remission, especially in an Indian context, we have to keep these considerations in mind. So my journey in terms of prevention of diabetes actually started when I was asked to be a part of the NICE guidelines to look at the prevention of diabetes in the communities, which went beyond what we did. And this basically what we find was, first of all, if you had any interventions in the community setting, it was possible to prevent diabetes. It would not cost us much, but it was not the job of the healthcare professionals. It was the job of politicians and social scientists to change behavior, to change housing, to make people eat the right kind of food, to make the kids actually exercise in the school and stuff like that. And it is very tough, and it requires generational changes, but it can be done. Countries like Finland have demonstrated that it can be done. So this is the upstream prevention. Then you have the downstream prevention, where you identify the people with diabetes or pre-diabetes, and then you actually put in measures. Now these are individual based and not community or societal based, so they are expensive, but they have got more evidence, and it is much easier to convince the governments to actually do it. Now, when it comes to prevention of diabetes, one of the questions that is always asked by people people without diabetes or common people, that is it possible to prevent diabetes? The answer is absolutely yes. And this has been this is probably one of the best studies, because right from every population, Chinese, Hispanics, blacks, Indians, in almost all population, it has been shown that by lifestyle measures, by making people lose 5% body weight, by making them eat 600 to 800 kilocalories less food, do 150 minutes of exercise a week, in 50 to 60%, depending upon the population and the study, it is possible to prevent, or what you would call, reverse diabetes. And this is from the DPP study and the Finnish diabetes prevention study, again showing lifestyle to be superior to metformin. Then we have got the Indian diabetes prevention program from Ramu Ramchandran in Chennai, which actually showed that lifestyle in an Indian population, because as I said to you, the Indian population, the story is more of metabolic capacity, and again it showed that metformin is probably as effective as lifestyle, and this is slightly different from a Western perspective. Now, in one of my roles, I was involved in the NHS Diabetes Prevention Program from Diabetes UK. This is probably one of the largest global health intervention program in type 2 diabetes to try and prevent diabetes. Now, what are the lessons from NHS TPP, and what are the early results showing? Now, the care pathway that has been developed by the NHS actually looks at 2 or 3 things. One is looking at doubling the NHS prevention program, along with NHS remissions, along with a lot of things around type 1 diabetes. So the basic model of this is the NHS health check, in which everyone who reaches the age of 40 years actually receives a letter asking them to have a kind of an MOT, where they go to the general practitioners, have got a number of things done, include lipid, blood pressure, to identify people with early diabetes. And once people have been diagnosed with pre-diabetes, which is HbA1c to 48 or 6.5%, they're put in a living well control program, which is a 9-month journey, 13 sessions. Most of it is done digitally. The aim is to make people lose 5% body weight and exercise for 150 minutes. And this is the recruitment rate. So the program started in 2016. During the COVID years, there was a bit of a lull, but it's well within the targets of reaching nearly 100,000 people. During the COVID years, it was actually changed from face-to-face to remote, and now we have got both the programs running simultaneously. So in terms of the completion of these programs, nearly 250,000 people have completed, and 60% of them, and there have been broadly similar completions in face-to-face and remote. So in the intention to treat to weight loss, what you are actually seeing is that patients are actually achieving a weight loss between 3 to 5%, which is what was proposed. And this is probably the most important thing. It is showing that the NHS Diabetes Prevention Program is working in all ages, probably in younger people much more, in all ethnicities, including the South Asian populations. The other program that was launched around the same time was the NHS low calorie diet program. This was basically looking at type 2 diabetes remission. I'm not going to go into details of this. You all know the direct study from Roy Taylor's group that showed that by going on a total diet replacement, which is a 600 to 800 calorie liquid diet for 3 months, followed by reintroduction to the diet, it was possible to reverse diabetes. So these were the people who were diagnosed as type 2 diabetes within 5 years of duration, and they were not on insulin. All diabetes medication were stopped and they were put on total diet replacement. And it showed if you lost 15 kilograms of body weight, in 86% of people there was remission of diabetes. I don't like the word remission. I would probably want to use the word diabetes-free state or a cure of diabetes. I think as diabetologists we need to be a bit bold and use the word cure. That will get more people involved in this program. And this was the just a case study that was published from the direct study, and it actually shows beautifully how with a 15 kg weight loss there is a normalized beta cell function with both liver and pancreatic fat almost disappearing completely. And there was an extension of the direct study which has been presented at this year's Diabetes UK meeting, and it actually again it shows that even if after 5 years the percentage of people in remission is nearly double when you compare to the control group, again suggesting that diabetes remission is working and works even at 5 years. And it's just not the direct study, it's the droplet trial again from the UK, which was more a primary care based initiative, very similar to direct, in which the patients were identified by the general practitioners of primary care who were able to start them on this program, again achieving total diet replacement with a liquid diet, achieving the same results, showing that for diabetes remission you don't need endocrinologists or diabetes experts. This can be even done in the primary care. This is again a piece of data that perhaps interested me a lot. Again showing that the diabetes remission program works in all groups, probably the highest in the middle ages group, works in females perhaps more than the males. In terms of the ethnicity, the most of the population we currently have in the NHS diabetes remission program is white, but the uptake in the Asian community is also very high, which is quite encouraging. And if you look at the type 2 diabetes remission rates in the NHS diabetes prevention program, at the end of the 12 months, nearly half of the patients, very similar to what you saw in the direct study, are in remission. And the mean percentage of weight loss is about 10%, or which is again achieving the kind of the results which are very, very, very good. So what are the challenges? These are my last few slides. What are the challenges to have these programs as a public health initiative, not as private or individual based initiative, but as government initiative? So one of the biggest population we have is we need to define what is the ideal weight for a South Asian population. What is an ideal weight for them to go into total diet replacement? We had a lot of discussions with our South Asian Health Foundation, with Professor Kunti, with the Roy Taylor and Mike Lean, about doing a similar kind of a direct study in a UK South Asian populations, but those things did not materialize. There was a cohort of direct study that was done in normal weight individuals or normal BMI people with type 2 diabetes. Again, it had encouraging results, but we need more studies. And the reason for that is we know this is from our group, which actually showed that if you're a South Asian living in the UK, when it comes to diabetes, your ideal BMI should be 22.5. And again, this is some of the data showing much lower BMIs for South Asian when compared to the other populations. So in the end, the chairpersons, what I would like to say in summary is, it is possible to prevent diabetes in all ethnicities across the globe through effective public health programs. Early intervention through promoting well-being and health through government policy in early childhood is probably most effective. Diabetes remission has not been studied well in a South Asian population. Ideal weight for an Indian population and reduced beta cell mass is an issue and needs to be looked in. And finally, effective diabetes prevention and remission perhaps start at the fetal level. Thank you.
Thank you, sir, for a very wonderful lecture. Can you just join us out here? Questions, if any, from the floor?
So can I just start off with asking Dr. Hanif about what you showed, the NHS weight reduction study. What was the responder rate and what was the reason for the non-responders to not respond when you looked at the diabetes prevention?
Okay, thank you very much. That's a very good question. I think one of the main reasons, so there were a couple of issues. So first, we were looking at the number of people who were referred. So when it came to referrals across the populations, it was pretty much the same in all ethnicities, all age groups, all socioeconomic status. The second thing was we looked at the completion rates, which was the population that was completing it, that is following the whole direct study protocol for a year. And in that, what we found was that if you were upper middle class white female, you completed the whole program. But if you were, say, a Asian or black person from a low socioeconomic status, the chances was that you would not complete. Again, suggesting that one of the challenges of public health program is it is the motivation of the patient that actually drives them to complete. So the non-responders were generally the people who did not follow the direct protocol or completely followed it for 12 months.
Thank you, sir.
I'm Dr. M.L. Kalra, sir. Very nice lecture. In one of the slides for NHS program, there was a difference of effect of lifestyle management and metformin. So what is the additional benefit if you add on either of the two, NHS, the metformin to lifestyle and lifestyle to metformin? Is the addition also different? Is it both to start in one go, or lifestyle first, then metformin, or metformin, then lifestyle?
Thank you. Thank you very much. So I think in terms of the lifestyle, as I said to you, in a Western population, all the diabetes prevention programs that came from the West, from DPP, Finnish diabetes prevention, lifestyle was better than metformin. Using lifestyle and metformin together was examined in a part of the DPP, and did not show an additional benefit with metformin if you follow the lifestyle. But the Indian Diabetes Prevention Program from Dr. Ramchandran, that actually showed lifestyle and metformin to be almost the same. So perhaps that in an Indian population, perhaps lifestyle or metformin works as well as lifestyle. Dr. Mohan is here. He probably knows more about that program than I do, so he may be able to comment.
Yeah, Dr. Wasim, very eloquent talk. It was indeed a listener's delight. My question to you is that you said and talked about Indian diaspora staying in United Kingdom. But in Indian context, things are quite different. You know, the food, the body weight, and most of us are vegetarian. So I think that diet is an integral part of your program, what you say. Yeah. So I think for Indian context, we need to have Indian studies on such issues. Thank you.
Absolutely, I completely agree with you. But I think most of the Indian population in the UK is very similar in terms of their dietary need as here.
Great talks from everyone. Just to respond to your comment, in the DCLIP study, which followed the Indian DPP study, we actually did a sequential. So if the lifestyle didn't work, we added metformin on top of lifestyle, and that was one of the first studies to do that. The other thing which is different from DCLIP and all the other DPP studies earlier was that we included for the first time impaired fasting glucose, IFG. And in this paper, diabetes care paper, what we showed was that people with IGT respond, whereas IFG does not seem to respond. Soon after that, we had the Kerala DPP study where Dr. Thangappan, Jonathan Shaw and others showed the same thing. And then there was one more study from Japan which showed the same thing. In fact, just last issue of Diabetes Care, there's a systematic review which we wrote, combining all these studies. So for IFG, we really don't know what to do because lifestyle doesn't work, metformin doesn't work, combination doesn't work. So what do we do? I know that Ralph DeFrance is doing a study in different arms. He's using pioglitazone, he's using DPP-4 inhibitors, he's using SGLT2s, and we don't know. The results of the study is still not on, and we are planning such studies, but they progress relentlessly and much faster, and that is the thing which Venkat Narayan showed in that slide which you showed. So it somehow seems to be different that we have a lot of IFG. There was another review article published on pre-diabetes all over the world, and in Southeast Asia and South Asia, IFG is much more than IGT, and we saw the same thing in the INDIAB study as well. So we need some other solutions which we still don't know what to do. No, IGT is much simpler.
No, I think you're absolutely spot on there. So I think I've had a number of conversations with Venkat and other colleagues in the US. Now, one of the issues here is about how do we measure the beta cell function in these group of patients. So one of the other things in some of the works which Sarah Punaswamy is doing is basically we're trying to see whether these patients, for some reason or the other, whether it's epigenetics or anything, that they don't have enough beta cells to produce it. And perhaps the treatment are not GLP-1s or stuff like that, but perhaps some kind of an insulin mimetic or something that produces it. But some of your work, I think that is, and this will probably come out in the cluster studies that you're doing about this group of patients.
Thank you.
Dr. Mohan, can I ask you a question? I'm sorry. So in those studies where you're looking at IFG, have you seen the % weight loss and the correlation with the IFG? Because maybe we are not mobilizing enough hepatic fat or pancreatic fat.
So the mechanism seems to be very different. I'm sure Dr. Tripathi can answer that with his clamp studies. So in IFG, the defect seems to be more in the liver. And in IGT, it's more in the peripheral tissues. So we are addressing two different things. And if you use the same approach for both types of individuals, we don't seem to do that. The combined IGT and IFG group, by the way, did okay. As long as IGT is there, it does well. But if you have isolated IFG, which seems to be the most common pattern in South Asians, as compared to Europeans where there's more of IGT, because it's the obesity-related thing which comes out there. So we have these lean people with type 2 diabetes who have this defect. We don't even know what to do. Whether they will reverse is something which really needs to be studied.
So as a corollary, I'll ask Dr. Tripathi a question. Would a glucagon clamp or clamping it at that level help? Because we have done this study looking at impaired fasting glucose when I was his fellow. Yeah. So I'm just curious, it was a smaller cohort.
Yeah, I mean, we have looked at the, we looked at the pathogenesis of IFG and IGT, as Dr. Mohan already showed that IFG is characterized by something called hepatic insulin resistance. Yeah, and also there's early defect in it. So the first phase insulin secretion is also impaired in IFG. IGT is typically skeletal muscle insulin resistance and also second phase of insulin secretion. So ideally metformin should work better and theoretically on IFG because metformin caters to the hepatic insulin resistance, and for IGT, the GLP or the insulin mimetics. So, but in pioglitazone study that we did, the ACT-NOW study, we didn't show any difference between response IFG versus IGT. They are all showed similar response. So pioglitazone, although ideally should be more on IGT, but majority of them are IGT. So yeah, we don't know the exact answer, which one will be the best treatment for IFG versus IGT.
So, yeah, okay. Thank you very much for the wonderful questions, wonderful interaction, and the speakers will still be around all day. So if anyone has any other pressing questions, you can ask them. And can we give them mementos or? Yeah, thank you. Okay.
Thank you, everyone.
Thank you all the chairpersons and the speakers.
Dr. Mohan now I'll request Dr. Hanif.
Now I'll request our chairpersons to kindly hand over the memento to our
give a memento to Dr. Hanif, please. Yeah, Professor Hanif. And Dr. A.K. Das, I saw him in the audience. Sir, can I invite you to give a memento to Dr. Tripathi, please?
Now I'll request Dr. Mohan to present a memento to Dr. Sen Gupta also. Thank you everyone. So we come to the close to this session. Now we'll break for the inauguration ceremony. Dr. Shalini, continue with the inauguration ceremony and the lamp lighting. I'll request everybody to be seated for this inauguration ceremony. I'll request Dr. Kirti to please come on the dais and take over and start the inauguration ceremony.
Good afternoon, everyone.
Can I request everyone to settle down, please, for the inaugural to start?
We welcome you all to the inaugural ceremony of the 10th International Symposium in Diabetes organized by CMRE in association with AASD and DIPSI. I would like to invite Dr. Rajiv Chawla sir and Dr. Shalini Jaggi, directors of CMRE, on the stage. I would now like to invite the dignitaries to join on the stage and request the directors of CMRE to welcome them with a bouquet. May I now request Dr. Colin Dayan on the stage. May I request Dr. Rajiv Chawla to welcome sir with a bouquet. May I now request Dr. Inas on the stage. I would request Dr. Shalini. To welcome ma'am. I now request Dr. V. Mohan to join us on the stage. May I request Dr. Rajiv Chawla sir to welcome sir. May I request Dr. Professor A.K. Das sir on the stage. I would request Dr. Shalini to welcome sir. May I request Dr. Shashank Joshi sir on the stage. I request Dr. Devjit Tripathi sir on the stage. May I request Professor Dr. Wasim Hanif on the stage. May I now invite Director CMRE, Dr. Rajiv Chawla sir, to deliver the welcome address.
Good afternoon. As a co-director of CMRE with Dr. Shalini, it's my pleasant duty and proud privilege to welcome you all to the 10th International Symposium in Diabetes. It's a very emotional moment for us. We started our journey about 10 years ago. The seeds which were sown are sort of flowering now and we are getting the fruits and the results. It has been a tremendous effort, a significant learning and a wonderful experience working all across these 10 years. Earlier we had blessings from Cardiff University, Professor Colin, Professor Mohammad Hasnain, whom we are really missing, had to drop his program last week only for some family commitment. They have been part and strength of our entire program. Fortunately, last 5 years, we have partnered with Professor Inas Sheltout, currently serving as ASD President. And I must say with proud, it has been a wonderful partnership. Thanks, Professor Inas, for getting us here, for helping us going internationally to Middle East, Egypt, entire Southeast Asia. And I must share with you, yesterday we had registered about 5,500 delegates virtually and we had almost 2,000 logins throughout the day while 2 halls were being run and it was live streamed across Middle East, Southeast Asia, Egypt and UK, lot of part of UK also. In terms of scientific content, we have done reasonably well. Together a faculty, what we have amongst today, Professor Hanif, a man who has an Indian origin working in Birmingham, but who has really been identified with this ethnicity, a core consultant and an iconic figure there in UK. Professor Devjit Tripathi, my very close friend, almost 23 years ago, we were working together at Buffalo. He was also trained by Dr. Dandona, a very learned man I've seen, doing DM from AIMS, then finishing his PhD in 9 months' time, getting an International Pfizer Award, then went on to do his American board, and then internal medicine to practice there. Today is Antonio, director, entire diabetes endocrinology program. Then Professor Mohammed, of course, he couldn't make it. Professor Colin, I told you, has been entire, right from day one, has been our strength. Dr. Mohammed, that time was working at Cardiff, and he has been the key person, the connect between our entire program. He has always been part of our organizing committee, early days through Cardiff, then to Emirates Diabetes Society, and he is the one who handheld us and connected us to ASD President Dr. Inas Sheltout. So we are extremely thankful to them. Our own, not to forget, our own national but international figures, Professor V. Mohan. We started this program 10 years ago with him. One day I remember he said, Rajiv, I'm already running my Mohan's International Symposium. For me, it comes out to be a duality of interest, if I correctly remember the words. Why don't you take this banner and take it further? And I'm sure we have done reasonably well since then. Professor Das has been our key speaker every time. He is a fatherly figure in this part of the world, and he has been giving his blessings. Shashank is like my younger brother, much higher in stature, but has been a core strength. Professor Vinod Kumar, Dr. Makkar, Dr. Bansi Sabu, and my younger friend, just younger by 2 years, but he says that you are my elder brother, Sunil Gupta, has always been part of this program and contributing towards the success of this program. So this is a very emotional moment for all of us. We are in our 10th year, and hopefully from here on we will have a good teenage. And I can promise you this international program with 9 international lectures assigned today is going to be a wonderful experience. We are going to be enlightened, and day 1 onwards probably we'll be able to rationalize the learnings, the pearls of wisdom from these experts, those who have come all the way across the globe. We will be much wiser, and we'll be able to rationalize in our practice tomorrow onwards. Thank you very much, and I once again convey my gratitude to entire national and international faculty. I might have forgotten certain names, but all the delegates, those who have been with us since our early days, thanks a lot. Thank you.
Thank you so much, sir. May I now request Dr. Professor Colin to share his experience on a decade of his association with CMRE.
Thank you very much, and this is my first opportunity to thank all the organizers for inviting me again today, and it's a real pleasure to be here. I think when I first came, I didn't really know what I would find when I came here. I knew it was going to be big, I knew it was going to be well organized, but I've always, every year, been amazed by the quality of the speakers, the quality of the science that presented, and the level of discussion, and the number of people that have been involved in discussion. Many here have been involved in training with us through Cardiff University, and that's also been a great pleasure. But I think as things have evolved over time, it's just gone from strength to strength. And it's a great pleasure to have the opportunity to come and join with you again in the 10th anniversary as we go into the 2nd decade. A lot of people have been talking to me today about how India has grown, and the infrastructure has grown, and the strength has grown, and the wealth has grown. Of course, the diabetes problem has also grown alongside it as well. So there's an even bigger challenge, which we heard a lot about today. But I'm sure, the one thing I always realize is that if you throw enough resource at it and you work hard enough at it, you can solve almost every problem. And I'm sure this will happen here in this organization too. So I'm really looking forward to the 2nd decade as much as I've enjoyed the 1st decade. Thank you.
Thank you so much, sir. It is with great pleasure that I now request Dr. Inas, President of ASD, to share her vision on ASD and CMRE partnership.
On behalf of the Arabic Association for the Study of Diabetes and Metabolism, it's a great pleasure to be here in this great country with a great civilization. Thank you very much for involving us in this important event, and I wish you all success and a very fruitful scientific conference. Thank you very much.
Thanks a lot, ma'am, for your such kind words. Now it's my great pleasure to invite Dr. Professor V. Mohan sir to share some pearls of wisdom with us.
Dignitaries on the dais and off the dais, thank you for the opportunity to be part of this splendid inaugural function. Starting something is always easy, but maintaining it and continuing it with the same vigor and setting the bar higher every time is a great challenge. And not many people can do it, but I know that Dr. Rajiv Chawla and Dr. Shalini Jaggi and their whole team have done it not once but 10 times, and as they march towards the silver jubilee and golden jubilee, I'm sure the bar will only get raised higher and higher. I have enjoyed the presentations, your choice of speakers, the topics have been excellent. It's a great learning experience for us. The academic feast is something which everybody can enjoy. Your idea of having it both hybrid and face-to-face is an excellent one, because to people who cannot come to India for various reasons, you're able to reach out to them. And as you can see from the full hall here, that there is so much of enthusiasm and interest to learn. So I wish you continued success. And Rajiv, you have taken it to much higher heights than when we started in a very humble way, when we started collaborating with the Cardiff University in our initial days. And I'm sure the association with more and more scientific bodies will only grow in the years to come, and my very best wishes and blessings to both of you. Thank you.
Thanks a lot, sir. May I now invite Dr. A.K. Das sir to bestow us with his blessings.
The number 10 in all the scriptures is a special number. 10 commandments in Bible centers around the divine guidance. The number 10 in Indian scripture is a guidance directly from the seers and from the divine. So I congratulate on the 10th year of the function. Dear friends, to treat diabetes we need two things. We need knowledge, we need love. And that knowledge today becomes old in every 26 days. There is a relentless advance against a disease like diabetes, relentless. And this relentless advance to keep posted, this meeting is one of the best opportunity to keep ourselves posted with the latest. Dear friends, I must end my saying that 10th year back, it was a blessed day when it started. Well continuation, there is no end, endless progression. The programs that they have brought today is practical, clinical, centered around all the topics, starting from precision medicine to global guidelines. I cannot describe all the topics. I must tell you that it is absolutely fabulous, and I am delighted to be here. Thank you so much.
Thank you so much, sir. It's my pleasure to now invite Dr. Shashank Joshi, sir, to share his thoughts with us on the way forward for CMRE.
So, dignitaries on the dais and off the dais, I think we are all here to celebrate an occasion, and I have to congratulate Dr. Rajiv Chawla, Dr. Shalini Jaggi and their entire team for relentless academic pursuit. And I think please put your hands together and give them a standing ovation. I think they really deserve one. So we should all give them a standing ovation, do some physical activity, and you can sit down, both of you all. But I think you all have done a very good job of academic excellence. This hybrid meeting was great. I echo with whatever everyone else has said. We are here to celebrate, congratulate, and I wish you many more successes in this wonderful pursuit of excellence. I think, Rajiv, one thing you are very passionate about is the pursuit for academic excellence, and I think you have maintained that, and keep doing well and keep growing. And I'm certain that the knowledge sharing which you get from these meetings are all centered around patient care, and we are here committed for patient care. So congratulations once again for a wonderful 10-year journey and many more to come. Thank you.
Thank you so much, sir. Now it's my honor to invite Dr. Professor Devjit Tripathi, sir, to share his words of encouragement with us.
Okay, I would like to congratulate Dr. Chawla again on the 10th anniversary of his the symposium. I met Dr. Chawla about almost like 20 years back when I was moved just to US and was with President Nona. And then he was talking about doing something in this consumer, but definitely it happened a few years later. And this is my, I think, 4th or 5th year that I've been coming to a symposium. It is a wonderful event. It's again, this is really successful with the hybrid format. And I went over all the different topics today. It was excellent. Again, I would wish you, Dr. Chawla and Dr. Jaggi, for the success and coming future. I wish you continue. I expect you to continue the same vigor. And thank you. Thank you.
Thank you so much, sir. I now invite Professor Dr. Wasim Hanif to please share some words of inspiration and motivation with us for the CMRE.
Thank you very much. I would like to take this opportunity. I have always believed great institutions are built by great individuals. So I think Shashank has already said, Dr. Rajiv Chawla and Dr. Shalini Jaggi, I think this is a great job. If you've been able to have a high quality scientific meeting for 10 years, I think it's a great achievement, and you both should be really proud along with the rest of the team. This is my first time here, but I have had interactions in the virtual meetings which we did at the time of COVID, and the response I get, because a lot of my juniors, fellows, I ask them to attend these virtual meetings because they're free, they can do it, and they have all appreciated it. So thank you very much for allowing the people across the globe to be a part of this meeting, and we'll all wish you all the success, and hopefully we should all be here celebrating your silver jubilee. Thank you.
Thanks a lot, sir. So thank you, respected dignitaries, for those kind words. You have always motivated us to do more, and we thank you for being our mentors and partners in the decade of our journey at CMRE. May I now request all of you to kindly join us for the lamp lighting ceremony.
Please join us for lamp lighting. I'll request Dr. Makkar, Professor Vinod Kumar, Dr. Sunil, please join us for lamp lighting. Dr. Makkar we have been working together for close to 35 years. Only one person where we never had any envy or any issues. Day one we started working in the field of diabetology, and since then it has been a wonderful journey. Today he is serving as President RSSDI, so it's an honor to have Dr. Makkar also. Dr. Vinod Kumar is our patron RSSDI.
आयोजन आपको सफलता हो और खूब खुशियां हों। इस कामयाबी के लिए आप सब मुबारकबाद हो।
It's a very emotional and proud moment for me. I must share you My father today happens to be 85 years, and I remember, Dr. Mohan will remember, 75 years when he became 75, it was our first conference, and we had him as a chief guest and got his blessings. Today, well, there is mobility issue, so I couldn't manage getting him here. Every day he performs Havan at home, and today morning also I talked to him. So he has sent his blessings for this conference. Please.
आयोजन आपको सफलता हो और खूब खुशियां हो। इस कामयाबी के लिए आप सब मुबारकबाद हो। सब डॉक्टर सुखी रहो, निरोग रहो, स्वस्थ रहो, सलामत रहो। ऐसे आयोजन करते रहो, सफलता पाते रहो, सफलता आपके कदम चूमे, आपका नाम मशहूर हो, रोशन हो। आप अपनी इन प्रयासों में, मानव सेवा में अपना लगन लगा करके कामयाबी हासिल करो, उन्नति के शिखर पर पहुंचो। मेरी ये दुआएं हैं, मेरी ये प्रार्थना है भगवान से, आपको हर कदम पर सफलता मिले। मानव सेवा
मानव सेवा का ये बहुत ऊंचा काम है और ये सब डॉक्टर बहुत अच्छी तरीके से अपना फर्ज निभा रहे हैं, कर्तव्य कर रहे हैं। भगवान इनको सफलता दे, कामयाबी दे, आगे ये श्रेष्ठ काम करते रहें, क्योंकि डॉक्टर ही एक ऐसा नोबल प्रोफेशन हम जीवन हमें देने वाले हैं। ईश्वर इनको कामयाबी देना, ऐसे शुभ कर्म करते रहें, ऐसे ऊंचे ऊंचे काम करते रहें, ऐसे सेवा से वाले काम करते रहें, और आगे के लिए भी परमात्मा इनको प्रेरणा भी देना, इनके मन में उत्साह भी भरना, इनको सफलता भी देना। खूब ऐसे काम करते रहें। हम सबका आशीर्वाद इन डॉक्टरों पर, सब पर, खाली अपने बेटे पर नहीं, सब पर आशीर्वाद है। हमारे सब बच्चे हैं, भगवान इनको सबको सुखी रखे, खुशहाली दे, हरियाली दे।
I think when you have the blessings of elders, we started 10 years back with Uncle's birthday, and when we are 10-year-old, Uncle's birthday again. So I'm sure once we celebrate our 25th anniversary, we'll try and have Uncle and Auntie in person to bless us once again.
So after the invocation of Goddess Saraswati and blessings from elders, I would now like to invite Dr. Shalini Jaggi, Director CMRE, to deliver her vote of thanks before we proceed.
It's my proud privilege and honor to deliver this vote of thanks. 10 years journey has been a great journey. The small baby that we actually planned at that time has actually grown and is 10 years old. The support of each of our faculties and dignitaries is very, very important. I would like to thank everyone for making this a great success. First and foremost, my thanks to our partnering bodies, AASD and DIPSI. President AASD, Professor Dr. Inas Shaltout, who has kindly taken out time to be our partner here. Physically, she's present today, and we've been associated with her for the last 5 years. Thank you, ma'am, for your support and association, and we look forward to many more such associations in the future. A word of thanks definitely is due for Professor Colin Dyan, who's been with us for the last 10 years. We have grown with you, and sir has never missed even a single event that we've done. This would be incomplete without thanking the Sutradhar of our program, Dr. Mohammad Hasnain. Sadly, he could not make it due to some family commitment. He has been our link to the Middle East, to all the collaborations, and he's been our backbone and part of the team. So many thanks to Dr. Hasnain, sir. Thanks are due to our senior dignitaries, Dr. Mohan sir, Dr. Shashank Joshi sir, Dr. A.K. Das sir. They have been our mentors, our guides, and our partners for the last 10 years, and I'm sure as the journey continues, we'll keep learning more and more from them. So thank you so much, sir, for all your blessings and mentorship. Word of thanks for Dr. Devjit Tripathi, sir, and Dr. Hanif, sir, our eminent faculties who traveled all the way from US and from UK to be with us. They were with us during the virtual times, COVID times, when we did the virtual conferences, and they are here today in person. And I hope this association continues. Your association, your expertise has been the USP of our program. Word of gratitude to all our faculties, both Indian and international. Their knowledge sharing, their scientific deliberations are the backbone of any scientific conference, and I'm sure that the expertise, the knowledge sharing, the deliberations speak for the scientific content of the program and help it make successful. So a word of thanks to all our honorary faculties. Also, a word of thanks to our industry partners who have actually lent unconditional support to organize an event of this magnitude. There are a lot of them: Sanofi, Novo, USV, Eris, Lupin, Biocon, so on and so forth. I cannot take all the names, but many thanks to all of you for all the support that you've extended to us in organizing this conference. Special word of thanks to USV. I think Farida ma'am has been instrumental and a partner right from day one when we conceived the program, and she has been a big support to all of us. In this journey, right from the beginning, any event cannot be successful unless until you have a good event management team. So Hardik, Neelam, and RX Events, thank you so much for your help in extended when we have the virtual as well as the physical program. You have been very, very instrumental in helping us conduct the program. Word of thanks also to the hotel management and staff for all the help in making this a very smooth event. Many thanks for your cooperation. Most important, a word of thanks to our delegates, because a good audience, an interactive audience, is the backbone and is the main reason of making an event successful and making it grow. So from day one when we started 10 years back to today, these 10 years, the audience, our delegates have been the backbone of our event. You are our strength, your inputs, your suggestions in making this further successful. What more we can do? You have been our motivators, you have been our guides, and we thank all of you for being with us in this journey and continuing with us as we move forward. So with that, I would like to end this vote of thanks. And okay, so Dr. Chawla wants to say something.
I wanted to place on record, my family is here. My daughter, Dr. Astha Chawla, she is a co-director with us in our CMRE program, and my wife, Dr. Rachna. She has been an immense strength, probably lady behind my entire journey. She has made it possible in unconditional love, never asks how long you will take, when are you going to come back, and whether you are going to come back home today or no. So it has been an immense strength from her side. And my daughter, she's again now partner in our new center, running her dermatology center. Thanks a lot everyone, and thanks a lot to entire delegates and all the faculty members, all national, international dignitaries on dais and dignitaries off dais. We might have forgotten certain names, but I think we'll stand excused. Please run the national anthem, and after that we can run. Yeah.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We'll just have a small 1-minute gap and then we can start with the awards and orations. So I'll request everyone to stay seated, please. We have some very important awards and orations coming up, and I'm sure you will enjoy them.
So post-inaugural session, we'll move to the keynote address. I would now like to invite Professor Devjit Tripathi sir and Dr. Wasif Hanif to chair the session.
It is a keynote oration. It is a keynote oration to be delivered by Professor Inas Sheltout.
It is a keynote oration to be delivered by Professor Inas Sheltout.
Put some autobiography of
Yeah, we will be sharing with you.
You will be sharing.
I will request Dr. Ahuja and Dr. Shalini to felicitate Inas.
I will now like to invite Dr. Rajiv Chawla sir and Dr. Shalini Jaggi to felicitate Inas ma'am.
So this is a citation for Professor Dr. Inas Sheltout. She's the CMRE Keynote Lecturer for the year 2023. Professor Inas Sheltout is a Professor of Internal Medicine and Diabetes at the Faculty of Medicine, Cairo University, Egypt. She is currently the President of the Arabic Association of Diabetes and Metabolism. She is also a consultant at As-Salam International Hospital and New Qasr Al-Aini Teaching Hospital. She has worked as the Chairman of Internal Medicine Department, Faculty of Medicine, Cairo University, Unit 4 from 2017 to 2019. Professor Sheltout's research interests include the treatment of type 2 diabetes and the management of fasting during Ramadan for people with diabetes. She has supervised more than 30 postgraduate MSc and MD theses at Egypt between 1995 and 2020. Professor Inas has worked as an honorary lecturer, Diabetes Diploma, Cardiff University, United Kingdom for over 5 years. She has been a peer reviewer for many medical journals, including Diabetes Research and Clinical Practice, International Journal of Clinical Practice. She is also on the International Editorial Board of International Journal of Diabetes in Developing Country. She is the founder of the Arabic Association of Study of Diabetes and Metabolism and also the founder of the Professional Diabetes Diploma by AASD in collaboration with the New Giza University. Professor Inas has been the president of the annual conference of AASD between 2016 until 2020 and has organized many international conferences in collaboration with many other Arabic societies. She has organized numerous educational activities for doctors, diabetes nurses, as well as patients. It is a most profound honor to present you, Inas Sheltout, with the CMRE Keynote Lecture for the year 2023.
Thank you very much. I'm really honored and overwhelmed. Thank you very much. I don't deserve it. I'm talking about women and obesity, and obesity is a rapidly unfolding healthcare crisis. In 2017, we had 800 million persons living with obesity, and expected by 2025 to have 1 billion persons living with obesity. And in my region, in the Arabic countries, these are the countries with high prevalence of obesity. More than 30% of people are obese. These countries are Egypt, Libya, Saudi Arabia, and Gulf countries. From 1986 to 2000, the prevalence of BMI of 30 was doubled, and BMI more than 40 was quadrupled, and extreme obesity with BMI more than 50 increased 5 times. In morbidly obese population, the average life expectancy of females is reduced by 9 years compared to 12 years in males. We are living in an obesogenic environment for females due to urbanization, sedentary lifestyle, less physical activity, high caloric and fat intake, and cultural norms and perceptions of an obese female. Let me speak about lifestyle of Egyptians. The percentage of Egyptians who eat 5 or more combined servings of fruits and vegetables per day, 20% only in females and 21% in males. And physical activity, 57% of females do not do any known physical activity, and thus we are having increased body mass index more than 25 in 72% of females, and obese females with BMI more than 30 in 39% of females. Obesity is recognized as a disease and a health issue and a chronic disease needing assistance and needing urgent function by most international organizations like World Obesity Federation, American Medical Association, Royal College of Physicians, Obesity Canada, European Association for the Study of Obesity, and Asian Association for the Study of Obesity. These are the complications of obesity, and you all know them. Obesity is associated with multiple comorbidities, metabolic comorbidities, cancers, complications like asthma, NAFLD, gallstones, infertility, subfertility, polycystic ovary syndrome, pregnancy complications, and many types of cancers, cardiovascular disease and cardiovascular risk factors, stroke, dyslipidemia, hypertension, coronary artery disease, coronary heart failure, and pulmonary embolism, type 2 diabetes and pre-diabetes, thrombosis and DVT, and gout. And also some mechanical complications like osteoarthritis and sleep apnea, chronic back pain, and mental complications in the form of depression and anxiety. And let me explain some complications and comorbidities, the clear and present danger. There may be increased incidence of arrhythmia and sudden death, and hypertension. For every 10% increase in body weight will lead to 6 millimeter mercury of high blood pressure, and decreased body weight will lead to decreased blood pressure, and sleep apnea, impaired respiratory function, and Pickwickian syndrome. And this is a picture of a character in the novel written by Charles Dickens, Mr. Pickwickian, who is sleeping while sitting with obesity and abdominal obesity. And this is a picture of a female suffering from sleep apnea. Some other complications, arthritis, especially weight-bearing joints, and 80% of diabetics are obese, and hyperlipidemia, especially hypertriglyceridemia. And this is the relation between BMI and chronic diseases among men and women. In both, we can have high prevalence of diabetes followed by hypertension, cholecystitis, and coronary heart failure. This is the relationship between BMI and the risk of type 2 diabetes. And in those with BMI more than 35, we have 93 times increased risk of type 2 diabetes when compared to those with BMI less than 22. This is more prevalent in females, while in males it's 42 times increased in those with BMI more than 35 compared to those with BMI less than 22. These are other groups of complications, physical complications. Obese persons usually come to our clinics complaining of tiredness, breathlessness, headache, edema, cellulitis, sweating, impetigo, and stress incontinence, and some other social complications like isolation, feeling of isolation, unemployment, family or marital stresses, financial stresses, and depression. Life expectancy decreases when BMI increase, and life expectancy is reduced by around 3 years when BMI is between 30 and 35, and decreased by 8 to 10 years when BMI is between 40 and 50. And for each 5 kilogram higher BMI, we are having 40% increased mortality rate for ischemic heart disease, stroke, and other vascular diseases. We're going to talk about abdominal obesity and cardiometabolic risk. And abdominal obesity in the HOPE study showed increased risk of cardiovascular events, and abdominal obesity increases the risk of developing type 2 diabetes. Abdominal obesity predicts adverse outcomes such as sudden death in the Paris prospective study, and abdominal obesity increased the risk of coronary heart disease. Women and obesity, it's more than an issue of size. We need to change the priority physicians give to obese women. It's more than an issue of size. There are greater health consequences, greater psychological consequences, and some female-specific issues like fertility problems, polycystic ovary syndrome, pregnancy complications, influence on the offspring, and complications related to menopause and some female cancers. Female obesity, there is a transgenerational issues, and we're going to talk about them. And women are at greater risk for obesity, and especially severe obesity when compared to males. Female obesity, a lifestyle of medical risk from early childhood to adolescence, to early adulthood, to childbearing period, to grown-up female, then to geriatric female. And for adolescents, they may suffer from psychological consequences of obesity, and we're going to discuss the reproductive health during childbearing period. This is the fertility with assisted reproduction, and fertility with assisted reproduction, the rates of pregnancy were halved for obese women. And body mass index also predicts infertility in women with or without polycystic ovary syndrome. Miscarriage rate increases after IVF and BMI more than 30 versus normal BMI, and live birth rate decreased after IVF and BMI more than 30 versus normal BMI. During pregnancy, these are the many frequent complications in obese persons during pregnancy, starting from miscarriage, gestational diabetes, preeclampsia, antepartum complications, macrosomia, large for date, stillbirth, congenital heart disease in the offspring, spina bifida, preterm birth, failure of labor to complete, cesarean delivery, postpartum birth complications, and postpartum infection and depression. And these are the pregnancy complications with each trimester. In early pregnancy, there may be miscarriage or increased incidence of twinning, and technical complications in the form of difficult ultrasound. Antenatal, pregnancy-induced hypertension, preeclampsia, gestational diabetes, and venous thromboembolism. And intrapartum, higher rates for induction of labor, planned and acute cesarean section, assisted delivery, vaginal tears, and operative complications in the form of higher rates of cesarean section infection, bleeding, and thrombosis anesthesia. The postpartum include hemorrhage, infection, and venous thromboembolism, and fetal complications in the form of macrosomia, congenital anomalies, fetal distress syndrome, perinatal morbidity and mortality, and the technical complications include birth injury. Gestational diabetes, the incidence of gestational diabetes overall is 4% of pregnancies, but in overweight women, they have 17% risk of developing gestational diabetes. From some metabolic effects during pregnancy to effects on the offspring, and the offspring of a pregnant obese lady is more susceptible to be obese in the future or having diabetes in the future. These are the implications for mature and aging women. Increased risk of obesity has many related comorbidities with aging, like type 2 diabetes, hypertension, and cardiovascular disease, and increase all types of cancers, especially those cancers. We can find increased incidence of uterine cancer, ovarian cancer, cervical cancer, pancreatic cancer, gallbladder, breast, and those are more prevalent in obese females. The uterine cancer, cervical cancer, breast cancer, followed by ovarian cancer. In the elderly women, we may have increased risk of cognitive dysfunction and dementia, and negative implication on life expectancy, and this study showed increased risk of Alzheimer's disease in elderly female with metabolic syndrome versus those without metabolic syndrome, and this association was not shown in males with or without metabolic syndrome. Obesity is an independent risk factor for Alzheimer's disease, and longitudinal study showed that overweight and obesity was associated with temporal lobe brain atrophy in CT scan. Then it's a lifelong complication of obesity with comorbidities, starting from early childhood to adolescence to early adulthood to childbearing period to geriatric females. This beautiful Egyptian lady could reduce her weight, and she's now a lovely celebrity. And this Arabic singer also, she could reduce weight, And let me finish with the benefits of body weight reduction in females. Many benefits, starting from improvement of osteoarthritis, of sleep apnea, of NAFLD, of insulin sensitivity, prevention of remission of type 2 diabetes, lower level of glycated hemoglobin, lower blood pressure, improved blood lipid profile, lower cardiovascular mortality risk, and lower androgenic level, lower risk of breast cancer, improved health-related quality of life, prevention of polycystic ovary syndrome, many benefits, including improvement in fertility, ovulation, stress incontinence, and low risk of dysmenorrhea, and lower risk of certain gynecological cancers. Let me thank you very much.
Thank you, Ines, for a very informative and high-quality lecture on women in obesity. Before I ask Devashish to ask you any questions, my kind of thing about women in obesity is one of these, I wouldn't call it a kind of a cultural thing, is that as you're a woman and as you grow older, especially because there's a lot of topic in discussion around menopause, that women are going to put on weight. So there's almost an acceptance that as you grow older, once you have a child or menopause, you're going to put on weight. So how do you think we should be, how do you think we can tackle that kind of a belief system?
Education and national programs. And you were talking about the prevention, and it's a very important topic.
Yeah, so as Dr. Hanif already asked, so what kind of interventions are you planning or you just have done in Arabic women, like lifestyle modification, including diet and exercise, or what works actually in your country?
In Arabic, in my country, many people like to eat carbohydrates, more carbohydrates, and less physical activity. And for our Arabic countries, it's an obesogenic environment with marketing for soft drinks, for junk food. So we are having obesity, and we need to tackle this important problem.
Very nice lecture, ma'am. So we can say that the obesity is mother of all, most of all comorbidities. And the effect of obesity is different in men and women. So it was interesting to know that the life expectancy is reduced by 9 years in women versus 12 years in men. But the risk of diabetes in morbid obesity was 93 versus 40. Women were having more risk compared to 22 BMI with morbid in one of your slide. So is that women are more tolerant to obesity, that their life expectancy is less reduced, and the diabetes risk is almost double, 40 versus 93. It was interesting to know. Any explanation for that?
Women are tolerant to many things, not only to obesity.
Great answer, sir. I'll just have a second. Sir, fabulous lecture. Great
Thank
lecture.
You
I
very
just
much.
wanted to congratulate you and just make a small comment. This obesity from the obese mothers is also transmitted to the fetus. It has been said they metabolically inherit the low metabolic function and also get into obesity, getting it from the mother. Do you agree with that?
Yes, sure.
Thank you.
Thank you.
I just very brief comment. Normally, worldwide, women live about 6 to 7 years more than men. But I have a comment for the men to clap. The comment is that every year, man is catching up with the woman by 0.1 year. And by 2054, this gap will disappear. So we should clap.
Okay. we'd like to thank Professor Salgor again for an excellent lecture. And with that, we would like to conclude the session. Thank you.
Thank you, my pleasure. Thank you. Thank you.
Thank you so much, ma'am. There's a request from Professor Ilyas that she would like to felicitate the directors of CMRE. So may I request Dr. Rajiv Chawla sir and Dr. Shalini Jaggi to be on the stage. So moving to the next session, it's the gold medal oration. I would like to invite Dr. V. Mohan sir, Dr. Rajiv Chawla sir, and Dr. Shalini Jaggi to chair the session. I don't think they need any introduction. Over to the chairpersons for the further proceedings. So this is a gold medal oration for Dr. Colin. May I now request Dr. Colin Diane to join on the stage?
On behalf of CMRE entire organizing committee, it's a great pleasure to have conferred upon this prestigious CMRE Gold Medal oration on Professor Dr. Colin Diane. Professor Diane is a professor of clinical medicine, diabetes and metabolism, Cardiff University School of Medicine, UK. He is trained in medicine at University College, Oxford and Guy's and Charing Cross Hospitals in London, UK before obtaining a PhD in immunology of Graves' disease in laboratory of Mark Feldman. He then spent a year as an endocrine fellow at the Massachusetts General Hospital in Boston before completing his specialist training in diabetes and endocrinology as lecturer in Bristol. He became a consultant senior lecturer in medicine, diabetes and endocrinology at University of Bristol in 1995 and later head of clinical research at Henry Wellcome Laboratories for Integrative Neurosciences and Endocrinology, Bristol in 2002. In 2010, he was appointed as Chair of Clinical Diabetes and Metabolism and Head of Section at Cardiff University School of Medicine. He served as Director of Institute of Molecular and Experimental Medicine since 2011 to 2015. He has a long established interest in translational research in immunopathology of type 2 diabetes and is currently conducting early phase clinical trials in development of antigenic specific immunotherapy. His clinical interests in diabetes include management of poor compliance in type 1 diabetes, public health measures in prevention of type 2 diabetes, and models of community care in diabetes. He is the lead for Diabetes in Cardiff whole pancreas transplantation program with his colleagues at All Wales data linkage program for monitoring childhood type 1 diabetes. Professor Colin currently leads the clinical engagement and training core of Diabetes UK funded type 1 UK immunotherapy consortium, which aims to coordinate and support combined efforts to bring immunotherapy for type 1 into clinical practice, and is a chair of type 1 diabetes National Prevention and Therapies Clinical Studies Group. He has research interest in thyroid diseases, which include thyroid autoimmunity, thyroid hormone replacement, and bioavailability, generic epidemiology as applied to population variation in thyroid hormone, bioavailability, and thyroid eye care disease. He became Secretary of European Thyroid Association in 2013 and chairs UK Thyroid Eye Disease Amsterdam Implementation Group also. So it is our most profound honor to present Professor Diane with CMRE Gold Medal Oration, and I'll request him to give his deliberation. Thank you, sir.
Thank you, Rajiv. Well, I didn't realize I'd done all of those things. Thank you very much. Okay, so now I think for something a little different, and I want to take you on a journey which you might not think you can go on, but I hope by the end you'll be convinced that this journey has begun. So the journey towards insulin-free type 1 diabetes. So these are my disclosures. It's actually a very exciting time for type 1 diabetes now, and here's three major things that have just really happened in the last year. We now have a lot more artificial pancreas closed-loop provision. ViaCyte announced the first stem cell-derived beta cells that actually function and control glycemic control. And I'm going to be saying a little bit more about the first drug for the immunotherapy of type 1 diabetes being licensed in the United States. So some people might say, we're doing so well. Do we really need this? Do we need anything new and different? We've got these very fancy pumps now coming along with the hybrid closed loop. Do we need anything more? I'm going to take a couple of minutes to try and convince you of that. So this is data from the National Pediatric Diabetes Audit, which covers all children in the UK. And it's data up to 2002 and 22. And you can see the lines are going down. This is the median HbA1c, which is great news. But you can see that it's also got 5 different lines, with the top line being the most deprived and the lowest line being the least deprived. So as things improve, we still have a lot of people who are left behind. And then in terms of where we're going with the target, this is showing you different treatments, again from the National Pediatric Diabetes Audit. The best at the moment on the right-hand side is closed loop. This is all for type 1 diabetes. But you can see that the median value for HbA1c there is 56.8, which means around 7.5%. So bear that in mind as we come to think about the longer-term complications of diabetes. Because we do know that although getting low HbA1cs, particularly around 53 or 7%, reduces microvascular complications, it's not so clear that it reduces macrovascular complications. And the death rate is due to macrovascular complications. So this data has been referred to before from Sweden, but showing you that if you are diagnosed under the age of 10, you have a 16-year reduction in lifespan. So it's still a huge burden that it's not clear it's going to be overcome by reaching an HbA1c of 56. And then I mentioned people who are left behind. Again, I'm showing you the data from the National Pediatric Diabetes Audit, and you can see from the bottom to the top, we're improving in glycemic control. More children are in the blue, which is HbA1cs, in this case less than 58. But there are still children and young people in the gray zone on the right, and these are HbA1cs above 10% or above 80. These are people at very high risk, and they're going to develop retinopathy, and many of them are going to develop nephropathy as well. Furthermore, we have a problem with young people. And what this is showing you, perhaps look at the dotted line rather than the dashed line. The dotted line here, and this is a study we just published this year on all of the young people in the UK with type 1 diabetes, in England and Wales, I think particularly. And it's showing that the HbA1c rises from about the age of 10, and it's still higher up to the age of 25 to 30. In other words, in those young years between around 15 and 25, people have HbA1cs that are substantially higher. This is largely a compliance issue, although there might be biological reasons as well. This is not good because early high blood glucose sets you up for longer term complications. So we have a problem here that we're not overcoming. And finally, I just want to highlight that with all this extra support and new pumps, new monitors and so on, type 1 diabetes is still a tough disease. And this, again, once more from the National Pediatric Diabetes Audit, is the need for psychological support. And you can see on the y-axis here that even 10 years and 15 years after diagnosis, still 30% of young people and families are needing psychological support. This is a huge burden for them to take on. So we do need something else. But what else can we do? Well, let's get back to physiology. Type 1 diabetes is an autoimmune process. On the left, you can see an intact islet with brown for insulin, red for glucagon. Then you have the insulitis process with infiltration. And then on the right, you have a shot islet, which has no insulin, but it still has glucagon. So just to remind you that type 1 diabetes is not primarily a metabolic disease. It's actually an autoimmune disease which targets the insulin-making beta cells, as you know. But that means that if we can slow or halt the autoimmune process, we can delay or avoid the need for insulin therapy. So let's think about it from now on as an autoimmune disease. So I want to remind you, if you haven't seen, that we've reclassified type 1 diabetes since 2022. This is the American Diabetes Association classifications into 3 stages. Stage 1, Stage 2, and Stage 3 is the stage you think of as type 1 diabetes, which is when you need insulin. But there are 2 stages before that, and we can illustrate it perhaps on this graph. And it's showing you the functional beta cell mass up the y-axis. And in the first stage, you have an autoimmune process, you have autoantibodies present, but you have normoglycemia. And that's because you have enough beta cell function, probably more than about 50 or 60% beta cell function, to control your glucoses perfectly. Then you progress to a stage 2 in which you now have dysglycemia. We've heard a lot about impaired glucose tolerance. You can have impaired glucose tolerance in type 1 diabetes also. So this is when you've lost perhaps between 50 and 80% of your beta cell function. You still have the autoimmunity, but you now have dysglycemia, but these patients don't present. They don't know that they have type 1 diabetes yet. And finally, you enter stage 3 when you become insulin requiring because you've lost even more of your beta cell function. I'll be referring back to these stages as we go through. So, I've said it's an autoimmune process, so there's the immune system. And you all remember your immunology, of course, here, illustrating some of the complexities of the immune system. But what I want to point out is the gray circles. Each one of these gray circles is not the immune system. These are new therapies that have been introduced over the last 10 to 15 years. Each one of them here is a monoclonal antibody or another agent that can pick off very small amounts of the immune system. So we now have the ability to detect over 50 or 60, to interact with over 50 or 60 aspects of the immune system. We just have to know which one to go for and to do it very selectively. So I want to emphasize that when I'm going to be talking now about immunotherapy, I don't mean cyclosporin. I don't mean the drugs we use for organ transplantation, which carry a high risk of side effects and we're all worried about. I mean the second group, which is selective immunosuppression, now routinely used for diseases of the skin, for arthritis, for bowel disease, and so on. Every other specialty, in fact, is using these routinely, except us. The last category I will talk about to you perhaps in 5 to 10 years' time. We don't really know how to do it yet, but that's to do what you might call an unvaccine, which is to remove the response to the beta cells. So I want to illustrate how we've been left behind by psoriasis, which is a disease I love to hate. And I hate it because they have 11 biologics licensed for psoriasis when we have only 1, and that's only in the USA at the moment. So I'm illustrating all the pathways that are picked out by the immunobiologics in psoriasis, for example. And of course, rheumatoid arthritis has had this running for a long time. I hope you can all remember all of the monoclonal antibodies we see here. Some of these are going to be coming to you fairly soon. So there are therapies with evidence for beta cell preservation in stage 3. Remember, that's from the new onset stage, which is where we've generally tested them out because that's when we identify the patients. So I'm showing you a list here on the left-hand side of 8 therapies, and there's another 4 that will be reported on over the next year. To give you a context for this, I want you to look at the risk of hospitalization with infection, which is a hard endpoint. So that's sepsis. And people worry about immunosuppression impacting your ability to deal with sepsis. Now look at this line here. You have the rate of hospitalization with infection around 0.6% per year in the control group. And over to the right-hand side, you can see this has increased tenfold in the drugs we use for renal transplantation. But don't forget that diabetes also increases your risk of infection, and type 1 diabetes increases the risk threefold, and poorly controlled diabetes increases the risk sevenfold. Now let me introduce the drugs here, and you can see that many of the drugs, such as anti-TNF and a drug we've been working on, ustekinumab, have effects on infection that are very, very small compared to the effects of diabetes itself. In fact, with ustekinumab, we can't actually see any difference between this and the background population. You need very big studies to show the effect. I've shown you one more there, which is rituximab, but in fact, this only refers to rituximab given chronically, as they do in multiple sclerosis. That's not the way we're going to do it in diabetes. So what I'm trying to emphasize here is that the risk here is very, very small compared to the disease itself. So just quickly to show you some of the data to convince you that this does work. So in all these graphs, I'm going to be showing you C-peptide up the y-axis, so that's a measure of endogenous beta cell function, and time over the x-axis here. And what we're showing you is from new onset of stage 3 type 1 diabetes. So this is teplizumab, a drug I'm going to come back to. This is an anti-T cell immunotherapy. Again, red line showing you relative preservation with the drug compared to the control. This is an anti-TNF therapy called golimumab. This therapy has been licensed in 2009 and is actually licensed down to the age of 2 in juvenile idiopathic arthritis, showing you the safety of the therapy here. It's given subcutaneously every 2 weeks. And again, here's data, actually, just the 2-year data has just been published, showing you the preservation of beta cell function. And then a surprise, if you notice it at the bottom of the list, you're going to, wait a minute, Colin, verapamil isn't an immunotherapy. Why are you listing it here? And you're correct, it isn't. And in fact, Aneth Shalav's group introduced this in 2018. It acts on the beta cell more directly to reduce its response to inflammatory milieu, and particularly to cytokines such as IL-1 and TNF-alpha. And when she introduced this idea, many people thought this is not going to work, it won't happen. And she did the first study here, a relatively small study showing you verapamil as a tablet, the one you know for hypertension and angina. Again, C-peptide on the left-hand side, but for the first time, you actually see a rise in C-peptide initially. And for those who stay on it in red, they maintain that rise out to 2 years, whereas for those who stopped in blue or who never took it in black, there's the decline that we always see in type 1 diabetes. And on the right, it's showing you the effect of that on metabolic function, that there wasn't an increase in insulin usage for those who were on the verapamil. This is actually quite an important agent in this context because it's not very expensive, so it's potentially quite transformational in how we can approach this. In fact, this data has now been reproduced earlier on this year by the JABE group, and this is in children now. The first one was in adults, in children aged 7 to 17, and they got the same result, which was a big surprise. Probably easiest to see on the right-hand side. You can see the C-peptide levels at baseline at 0 weeks, and then at 52 weeks in the verapamil-treated group versus the placebo group. So it was actually stable over 1 year versus the decline that we expect to see in the placebo group. So we are now trying to reproduce that as a third time in adults. This is just our recruitment graph. We're working hard on this here. We have got to get to the blue line to recruit 130 patients to go into this as a UK-European study, and we'll report out in 2025. And then we'll have a lot more confidence about whether this finding is actually true. So on the basis of that, one of the things you might have seen if you look carefully, the early studies that I showed you, is that they all showed beta cell preservation, but it declined. It was beginning to fall off. And we need to keep that beta cell function up for as long as possible to get all the benefit. So now we're beginning to think about combinations, but combinations that don't increase risk. So here's a platform trial that we're going to begin at the beginning of next year, in which everybody gets something. Everyone's going to get verapamil in the red line. Some will get it with the anti-TNF golimumab, some with that drug teplizumab, some with another drug that I didn't show you, anti-thymocyte globulin or thymoglobulin. So this is called a platform trial because you share the controls, which makes it much more efficient, and you can use many different combinations. We can add them in. I just want to show you here in some data we just published, actually, when we combined all the last 21 studies in stage 3 type 1 diabetes. 8 of them have shown benefit, and the rest did not. So on the left-hand side, you can see the C-peptide graphs that you've been looking at here. In the negative studies, it declines. In the positive studies, the red line is improved, so you get the benefit of preservation of C-peptide. But as I emphasized, in general, they improve, but gradually decline again. Now, on the right-hand side is HbA1c. And you may be familiar with this, that when you're diagnosed with type 1 diabetes, nowadays it's quite high. As you reintroduce insulin, it drops dramatically, and then it rises again. So you get this J shape. And what's shown on the far right-hand side is in those where C-peptide was preserved, you get the same J shape, but it stays flatter. So you end up with a benefit in terms of HbA1c. But we need to keep that very flat, and to do that, we need to keep the C-peptide levels up for as long as possible to get the best benefit in terms of HbA1c. But this is just emphasizing that you can get a glycemic benefit from this intervention. So can we do even more than this? And this is my title about insulin-free T1D. In all the studies I've been showing you, the patients are still on insulin. So how do we do this? Well, the answer is you have to go upstream. And so you go, instead of stage 3, you go to stage 2. And that's when they're dysglycemic. They've only got a few years now before they're going to need insulin. Can you intervene at this stage? And that was the seminal work of Kevin Herold and colleagues, published in 2019. And this is back to this drug, teplizumab. It's been around for around 20 years, but he made the brave step of now treating asymptomatic patients. So they don't have any symptoms at this stage, but we knew because of the antibodies in their blood and because they're dysglycemic that over 90% of them are going to progress on to type 1 diabetes, so it's justified to intervene, and that's what he did. And here's some of the data from that study. So in the black line, you're showing the progression to type 1 diabetes, stage 3 that is, in the placebo group. And in the red line, after a 14-day treatment with teplizumab, it's really only one dose, but they have to separate it into 14 different stages, different doses, in order to tolerate the drug. And what you can see is it resulted in around a 32.5 months, so a 2.5-year delay in the time to needing insulin. So the beta cell preservation resulted in them delaying the onset of the need for insulin. People worry about infection and the effects on the immune system. Teplizumab, as I mentioned, is given as a single course, and this is the effect on T cells. You see a dip. Yes, you do, because actually it hits a wide selection of T cells. But by about 28 days, so within about 4 to 6 weeks, the level of T cells is back to normal. As a result of that, the 4- and 7-year follow-up in people given this kind of treatment shows no long-term effects, no long-term increase in infections. So this resulted in breakthrough designation by the FDA and resulted in this panel meeting for the FDA in 2021, which I had the privilege to be present at. And they raised a critical question. Does the information presented about this new drug, this immune therapy, that the applicant and the FDA show, that the benefits of that drug, teplizumab, outweigh the risks in support of approval to delay clinical type 1 diabetes mellitus? So this is the first time when the question of, is an immunotherapy better than just waiting for insulin, was raised. And in the red box, you can see that it was a narrow vote. It was 10-7. And one of the people who voted against was actually David Nathan, as you can see on the left-hand side there, as one of the fathers of the DCCT trial. So this is a tipping point at when immunotherapy becomes better than metabolic therapy. But this was the moment, May 2021, when that decision, if you like, was first made. It then had to go to the FDA internal panel to make a final decision. And in fact, on November the 17th, 2022, finally approval was given for teplizumab, now called Tzield, as the first immunotherapy and the only immunotherapy licensed currently. And it's licensed to delay the onset of stage 3. So it's licensed only in stage 2. So people with prediabetes who haven't developed a need for insulin yet. So what about, could we go even further upstream and then we'll have a longer fuse? So here's the arrow now is in stage 1, and just this year there was a study published in stage 1, which was a bit disappointing. They didn't quite hit their primary endpoint. This is another drug called abatacept. Again, a drug that's been used in rheumatoid arthritis for nearly 2 decades. Was used in type 1 diabetes, but they lost their nerve. They only treated for 1 year and then they stopped treatment. And you can see on the left-hand side, this is the patients progressing from stage 1 to stage 2, and it did delay it, but it wasn't significant. If they carried on treatment, I think they would have gone on for longer. So we still haven't got a treatment in stage 1 yet. Now, a lot of people say, okay, you've delayed it by 2.5 years, but come on, what difference is that going to make? Well, during this period of 2.5 years, you have no hypoglycemic risk. If you don't need insulin, you can't have hypoglycemia. You have no lifestyle limitation. I know my patients who have had a pancreas transplant, when I say to them, what's great about a pancreas transplant? They say, I can eat what I like. I can eat what I like. And it's hugely powerful for people. That kids can do the exercise, they can go to school without any of these limitations. They don't even have to monitor, right? There's nothing you need to do over this time. And during this time, you have 2.5 years when you are not accruing a risk of long-term metabolic complications. Remember that peak that you're seeing through childhood? Well, you can flatten that out where you're not accruing a glycemic burden. And of course, there's improved quality of life behind that for those 2.5 years. So people who will most benefit from this kind of intervention, I mentioned the teenagers and young adults, if we can push the age of diagnosis out. I mentioned the lower socioeconomic classes, and people with mental health problems who really struggle with engagement with insulin. There is, of course, a but here. How do you find these patients to treat at stage 2? You have to screen the population. And you do that with autoantibody screening, which can be done on a finger prick. But only 10% of cases come from families with type 1 diabetes. So you can't just go around to the relatives. You won't find all the cases. You'll find a lot. 1 in 30 will be positive. But you have to eventually screen the general population. That's another lecture that I can give you at a different time. But there are some benefits in just doing the screening. So, for example, you can see here on the right-hand side, in a screened population, they're not admitted to hospital when they're diagnosed because people see it coming. They get the HbA1c, the glucose at a much lower level. And on the left-hand side, all the 3 studies that have done this kind of screening show a dramatic reduction in the rate of ketoacidosis at presentation. And certainly in Wales, the country I live in, every 2 or 3 years a child dies at diagnosis from ketoacidosis. So we can get rid of all of that. So in summary, I'm going to do an analogy with flight because I like aerospace. So this was the initial attempt at flying. It didn't work at all. It was never going to work. But maybe the equivalent of cyclosporin was this. This is the Wright brothers in 1903. And they managed to fly for 120 feet at a rate of 6.8 miles an hour. And you can run faster than that. So you could say that doesn't really get us very much further forward. However, the principle was there that if you have an engine and you have wings, you just have to make the engine better and the wings better, and you can do better. So just 24 years after that, maybe this is teplizumab if you like, then Charles Lindbergh crossed the Atlantic in a plane. That was an amazing step forward, and we are on an amazing journey. But I would say now we've got so many other drugs, and maybe combinations with verapamil can sustain the beta cell preservation for much longer periods. It's more like the 2nd of March 1969, which is the launch of Concorde, which could actually travel faster than the world turns. So it's just the principle is there. You just have to do it better and better. Because, of course, what you can do is sequential preservation. You can use one drug, and then you can use another drug, and then another drug. And that's the way they do it in rheumatoid arthritis, in multiple sclerosis, and in all the other autoimmune diseases. And there I'm illustrating how you can remain insulin independent for many years, 10, maybe more years than that. So in summary, less than 30% of children and adults achieve optimal control with insulin currently. And it imposes a huge burden, both on the patients and on you, on the healthcare professionals. But it is now possible to slow the autoimmune process and preserve beta cell function. Preserving beta cell function soon after diagnosis, so in stage 3, does in fact improve glycemic control. and may be particularly helpful for those who struggle to engage with healthcare. But it is possible now to identify up to 90% of people in the pre-hypoglycemic phase, and surveillance of that reduces ketoacidosis at diagnosis, but immunointervention can provide several years of insulin-free normoglycemia with short and long-term benefits. And so delay and prevention via immunotherapy has the potential to improve outcomes and quality of life. So, what I'm saying to you today, the journey has begun. The first step is always the hardest step, but we've taken that harder step. And so if the discovery of insulin was in 1921, if we can push it out and the diagnosis time out further and further and further, it's conceivable that we'll eventually eradicate childhood diabetes by 2041 and make things last a lot longer. Thank you very much.
Colin, that was simply marvelous. It's rare that we hear about eradication of the disease, and that last slide of yours, I think, has raised the expectations of everyone living with type 1 diabetes. And if that becomes a reality, I'm sure you will be the happiest person, and all of us too. Being an oration, I think we will not have any questions. That is tradition. But we would like to thank Colin for presenting the real cutting edge of research on type 1 diabetes. And thank you very much, Colin. That is a brilliant oration. Thank you very much.
Thank you so much, sir, for an excellent session. Now it's the time for Lifetime Achievement Award and oration. Dr. V. Mohan, sir. I would like to invite Dr. Shashank Joshi, sir, to be on the stage, along with Dr. Chawla and Dr. Shalini Jaggi.
So, Professor V. Mohan we all know, and this is the Consortium for Medical Research and Education, CMRE, is privileged to award the Lifetime Achievement Award and Oration for the year 2023 to Professor V. Mohan, who we all know is a living legend in diabetes across planet Earth. Dr. V. Mohan is the chairman of Dr. Mohan Specialty Center in Chennai in South India, which is an IDF Center of Excellence in Diabetes Care. He oversees a chain of 50 diabetic clinics across 8 states in India with more than 6 lakh registered diabetic patients in his electronic records. He is also the chairman of Madras Diabetes Research Foundation, which is the ICMR Center for Advanced Research in Diabetes and Asia's largest standalone diabetes research center. His main research interests include epidemiology of diabetes and its complications, genomics in diabetes, including monogenic diabetes, precision diabetes, and nutrition in diabetes. He is deeply interested in research since his medical undergraduate days. He has published more than 1,605 papers in peer-reviewed journals, which include 1,035 original articles. His research has attracted more than 1,88,000 citations with an H-index, which is probably highest in the medical field from India at a H-index of 151. Dr. Mohan has trained a large number of physicians and diabetologists in addition to dietitian, educator and nurses. And he has received more than 200 awards, including Dr. Harold Rifkin Award by the American Diabetic Association, the Fellow of the Royal College of Society from Edinburgh, and his extensive contribution from the field of diabetes in 2012, Dr. Mohan was awarded Padma Shri, the 4th highest civilian award by Government of India. In his autobiography, Making Excellence a Habit, The Secret of Building World-Class Healthcare System was published by Penguin, and his latest book, Banting, Bose and Beyond was published by Notion Press. Both are bestsellers on Amazon. It's the most profound honor to present you this Lifetime Achievement Award and Oration 2023. Put your hands together for Professor V. Mohan.
Ladies and gentlemen, I am deeply humbled and honored by this Lifetime Achievement Award and Oration from my very good friends, Dr. Rajiv Chawla, and my student, Dr. Shalini Jaggi, and my younger brother, Dr. Shashank Joshi, to read the citation. I'm not sure whether I deserve this, but in all humility, I accept this as a token of their love and appreciation. This meeting, I've already talked about this, and these two people, Dr. Rajiv Chawla and Dr. Shalini Jaggi, the family of Dr. Rajiv Chawla, and all the other organizers have done a marvelous job, and I've been privileged to attend all of them, all the 10 of them, and I look forward, God willing, to continue to be there till the Silver Jubilee. So we've heard about type 1 diabetes, a brilliant lecture by Professor Colin Diane. Let me now switch gears and talk about type 2 diabetes. Partial mention of this was made in earlier talks when Professor Wasim talked about this. So type 2 diabetes in India is a little different from the classical diabetes that we see in Western populations. We have known this now for 30, 40 years, but we are beginning to understand more about this as we go along and as we study this. I have no conflict of interest to declare. Most of the funding comes from ICMR, but also by the NIHR in the UK, which has funded some of these studies. Let me start off by thanking my colleagues, especially my genetics colleagues, headed by Dr. Radha Venkateshan, the lady in the middle. They're wearing a sari. I'm not sure they can see. Oh, there she is. So that's Dr. Radha Venkateshan and her team of genomics. We are very privileged that for the last 20 odd years, ICMR has supported the genomics work at our center, and we have Dr. A.K. Das, who is the chairman of the ICMR committee, which funds this project. And to their credit, 150 publications just on the genomics of diabetes alone from this one department, and 16 PhDs have already been completed on this topic, and I think 3 or 4 more are in the process. So it's quite a contribution from their group. So the topic is precision diabetes as we apply it to type 2 diabetes. So the question I would like to ask is personalization and precision, and I'll come back to that. In life, we know that one size doesn't fit all. So this child, if you give it glasses which is so big, or this boy, if you give a shirt that's so big, obviously inappropriate. So in life, we always tailor make things to the individual. So the question then is, and how can the same treatment be given to everyone with diabetes? We have already heard type 1 and type 2, and these are not the only forms of diabetes. We have so many forms of diabetes that after 50 years in the field, I think I know very little about diabetes, and I wish I had another 50 years to study it. I might know a little bit more about diabetes. I feel I know less now than when I started, because the field is so confusing and there's so much to learn about diabetes. But a word about precision diabetes and personalized diabetes, often confused, and we don't have a strict definition for these two, so I've tried to put this in this concept. Precision medicine or precision diabetes, how do you do it? You use all the scientific tools that you have, whether it's genomics or epigenetics or metabolomics or whatever, phenotype or whatever you do, and then you say that for the treatment of this particular person, this particular treatment seems to be the best. That's what the computer is telling you, that's what artificial intelligence is telling you, that's what deep learning is telling you, that's what your own knowledge is telling you. But then, that's not the end of medicine. Now you tell this to a person with diabetes sitting in front of you, and that person refuses the treatment, says, I don't want this, I don't like this. So now what do you do with your precision diabetes when the person doesn't even accept it? Or, as we heard about teplizumab, we have battled with this in India. We know it's very good, but who do we give it to? It costs 1 crore of rupees to get 2 years of insulin-free life for a child. We don't even have insulin to give everyone. So where do we put our priorities? Obviously something as path-breaking as that should be available, and I wish it was equitably distributed to the whole population. But when you have 1.4 billion people, it's not easy to do that. So you have to take the patient's social context, preferences into account, and that's where the personalization of medicine comes in. Doesn't mean that you forget precision medicine, but if you can marry the two, then you're really giving precision personalized medicine to people, and we're not there yet. The field has moved on, and in 2020, the American Diabetes Association and the EASD came together, and they said that precision diabetes now includes precision diagnosis, precision therapeutics, precision prevention, precision treatment, precision prognostics, and precision monitoring. So even if you wear a CGM, a simple CGM, you're doing precision treatment as compared to just doing 3 times a day an SMBG. So that itself is precision monitoring. They extended this a couple of years later, and they said, well, we're leaving two important countries out, the 2 biggest countries in the world, India and China, and it's not enough if you just have the United States and UK and Europe in this, so let's include 2 people. So they included Lenong Ji, my good friend from China, and they included me from India. So we were not just included in namesake, we had to work very hard. Now, about 200 scientists got together to study precision medicine in diabetes. And precision medicine in diabetes then became, as I said, precision diagnosis, prevention, treatment, prognosis, monitoring, 167 scientists working almost full-time on this for a couple of years. And that's what we have tried to do. For those of you who are attending the EASD in Hamburg, on the 5th of October at 9 a.m., this paper will be published in Nature Medicine with all the 167 people who have contributed to this. This is going to be a landmark thing. And there, we are planning to have something like 20 papers published, but about 8 of them, I think, is it 8, Colin? 8 of them, I think, are going to be published on the same day at the same time. And we have been divided into different groups. Obviously, we can't work on this because each of these you can get in type 1, type 2, GDM, and monogenic. So you can have type 1 precision diagnosis, precision prevention, treatment, prognosis, monitoring, and then for type 2 for GDM and for monogenic diabetes. So it's just too much for one group because you have to study, do a systematic review of every article published in the world on that particular topic. So I was allotted to the type 2 diabetes prevention project, and happy to say that our paper has now been accepted for publication. We first put it in the Medrix review, but now it's been accepted in Nature Communications Medicine, and that will also be published on October 5th at that time. This will be one of the 8 papers which will be published on that day. It will all be released and presented at a special session on 5th morning, October 5th morning. And this is our group which worked together. I'm happy to say that Bodhini, who works with me and whose picture we just saw standing next to Radha, is actually the first author of this paper on precision prevention of type 2 diabetes. So I'm just going to talk about only type 2 diabetes here. Yesterday in the meeting at the American College of Physicians India meeting, I spoke about monogenic diabetes and what we have done recently. But let me just focus on type 2 diabetes for purpose of this particular talk. We know that type 2 diabetes is heterogeneous in respect to prediction of development of diabetes. You can have somebody who has no family history of diabetes and then gets type 2 diabetes when they're 30 years old. And you can have somebody who has both parents having diabetes until 50, 60, they don't get diabetes. Why? We don't know. Honestly, we still don't know. Responsive therapy. I don't have to tell this audience that each person responds differently. And with respect to complications, I have seen adolescents with type 2 diabetes get type 2 diabetes when they're 12 or 13 years old, And by the time they're 18, they're already blind due to proliferative diabetic retinopathy. 5 years, and they're blind. And then you may say, well, maybe they had it earlier. How much earlier? Before they were born? They're only 18 years old. And yet, we have people who have finished 60, 70 years of type 2 diabetes and don't have a single microaneurysm. And if you look at their control, it's not all that great. HbA1c of 9, 10. So we really don't know much about this condition. So if you ask the question, are all type 2 diabetes the same? The obvious answer is, of course not. And we have known this for decades. But it took a group from Belgium, and we also know that there's variability with respect to BMI. I'll show you that in a minute, with the age at onset of the type 2 diabetes, response medications, and susceptibility to complications. Let's take BMI. Now, we talked about this morning, that the BMI, for example, in India, we don't need BMI of 30 to be called obese. This is the WHO definition for Asians, South Asians, Indians. If you have a BMI of 25 or more, you're classified as obese. Overweight is about 23, normal is 18.5 to 22.9, and lean is less than 18.5. Now, classically, we think that everybody with type 2 diabetes has to be obese. Well, if you have obesity, you have more type 2 diabetes. But the corollary or the converse is not true, that every person with type 2 diabetes has to have obesity. That's not true at all. In fact, we knew this years ago. This was 1997 in a DRCP paper. We reported on the clinical profile, it wasn't even called type 2 diabetes then, it was called NIDDM. So the clinical profile of lean NIDDM in South India. We had done GAD antibodies, this is Paul Zimmet and so on, are co-authors in this. So we had done GAD antibodies and everything, and they did not have, they had C-peptide, but they were lean. They were below the body weight, they were underweight, and yet they had type 2 diabetes. We really don't know even today why we get lean people who get type 2 diabetes. It's probably genetic, but if you study the genes, you'll find a long list of genes. They're not causal like monogenic, so you're not able to say that it's due to that. And my good friend Dr. Siddharth Das from Cuttack had done, from Orissa, had done a lot of work on this around that time. Let's take age at onset. We typically think that type 2 diabetes comes above 50, above 60 years of age. Well, that's true, but it keeps coming down. Then we started seeing it in the 40s, 30s, 20s, teenagers, and believe it or not, I had 4 cases below 10 years of age. Now you would say this is type 1. No, it's not. It's type 2. They have obesity. They have family history of diabetes. They have acanthosis nigricans. They respond to tablets, and they have not developed ketosis. It's type 2. The youngest patient I've had is 7 years old and has type 2 diabetes. Is it monogenic diabetes? No. We have done the entire panel for monogenic diabetes, ruled out MODY and other forms. So there is type 2 diabetes. The fact that there are only 4 shows that it's rare, but it shows that it can occur. It's not one case. One swallow doesn't make a summer, but it's 4 cases, and subsequently I've had a few more. So it can occur at very young age, even pre-pubertal. It can also occur at very old age. So you have people who are 90 years plus, and they have type 2 diabetes. They didn't get it after 90, although some do. My grandmother did. She got it when she was 90 years old. But these are people who got it in the 60, 70, and then they live up to 90, 100 years of age. And here is a picture. I hope you can identify the 2 people who are not 90 years old in this picture. One is in the middle. There are 2 people there, my daughter and myself. We have not reached 90 yet. But everyone else there has type 2 diabetes, minimum 30, 40 years duration. Couple of them, this gentleman and this gentleman, crossed their 101st birthday. And they've celebrated the 100th. I attended both their 100th birthday, and quite famous. This man is a vice chancellor of several universities. This man, the extreme left here to my left, was the secretary to 3 prime ministers of India and to 3 chief ministers of Tamil Nadu. He wrote a book when he was 97 years old, and he came for this function after that. So they're very active. They've had 40, 50 years diabetes. They have no complications. Why? I don't think it's just good diabetes control. So there are many things we don't know about type 2 diabetes. Response to medications. I'm sure all of you would have seen people who take 500 milligrams of metformin and they're having diarrhea, they just can't tolerate it. There are others who can take 2 grams of metformin, nothing happens. They're safe. You say, oh, give me a little more. You can take it, you know. So why? We know there's pharmacogenomics. We know that the SLC gene and many other genes are related to that. So that's pharmacogenomics. Susceptibility to complication, they already talked about. So with all this, we know that there are subtypes of type 2 diabetes, and therefore, this paper from Leaf Group and colleagues was really a path-breaking one, because for the first time, they said, let's subclassify type 2 diabetes. Now, there's a big debate whether you should really subclassify or whether it helps you and so on. It's a debate. There's some people who say you treat each person individually, you don't need to put them into different buckets. But this is what was an attempt made in 2018, which became a very famous paper with Emma Alquist as the first author. So what they showed was that there are 5 different subtypes of adult onset diabetes, of which the first one you can dismiss straight away, because severe autoimmune diabetes, when autoimmunity is present, it's not classical type 2 diabetes. It's a variant of type 1. You can call it LADA, you can call it whatever you like, adult onset type 1. So the first one if you leave off. Now you look at the second, third, and the fourth, fifth. The second one is where there is severe insulin deficiency. We know that type 2 diabetes has 2 defects, unlike type 1, which is severe absolute deficiency of insulin. Here in type 2, you have people who have 2 defects, either insulin resistance or insulin deficiency. One group, the SID variety, has severe insulin deficiency, not so much resistance. The opposite is third, where there's severe insulin resistance, obesity, high BMI, but they don't have much of insulin deficiency. Then they had a third variety called MOD, mild obesity-related diabetes, where there's no insulin resistance. This is the healthy obesity. They have obesity, they have diabetes, but there's no insulin resistance. We are not seeing much of that in India. And finally, they had the MARD variety, the mild age-related diabetes, which their mean age in that paper was 68 years. Our lifespan in India is 70 today, for 69 for males and 70 for females. So we always knew that type 2 diabetes occurs much earlier in Indians. We've known this for the last 30, 40 years. Studies from the UK and Paul McKee's work first, and then several others. So the question then came, can this be applied to Indians? Not because we want to do Me Too research, they did it, so we also do it, but because we believe that the type 2 diabetes is different, and therefore will the same things work in our population? If it did, it's great. Now, this Asian Indian phenotype, which has been talked about earlier also, Professor Asim Hanif also mentioned this. I can list at least 13 differences between type 2 diabetes as seen in the West and seen in India. Starting with the lower age at onset of type 2 diabetes, lower threshold for BMI. High insulin levels was one of my early papers when I worked in the UK at the Hammersmith Hospital. We showed that Indians had higher insulin levels. We followed it up with clamp studies and showed that they were more insulin resistant. Even if you match them for waist and BMI, they're still more insulin resistant. But more recently, Venkat Narayan's group and we together have shown a rapid decline in beta cell function occurring in our population, such that from pre-diabetes to diabetes, the progression to diabetes occurs much faster in South Asia. This has been shown by Naveed Sattar and Gill in their Lancet Diabetes paper. We have also shown it in our Cures paper. But the most characteristic of all, which for many, many years has continued to baffle us, is why we have such low HDL cholesterol. So we have the lowest HDL cholesterol in the whole world. No other ethnic group has low HDL. In fact, if you put all the HDLs in a basket, you can probably just by the HDL say South Asian, European, South Asian, European, with about 80%, 90% accuracy, just based on the HDL cholesterol. Why that is so, we still don't know. Is it genomics? We study a lot of genes, some of them LPL genes, others did help. It's probably the high carbohydrate diet, which increases your triglycerides and reduces your HDL. Why I'm mentioning this point is, when we tried to reproduce what Leaf Group and others had done, we could not do so successfully. Now that was this collaboration with Colin Palmer and group, and Ian Pearson and group from Dundee. This is funded by the NIHR, and this is part of the INSPIRED study. INSPIRED stands for India Scotland Partnership for Precision Medicine in Diabetes. So that's the INSPIRED study. So when we did this, we started looking at our population and first used the same clinical variables which Leaf Group and colleagues had used, and we could not, it's all there in this paper, when we used the Scandinavian ones, what we got, and we could not reproduce it. So what we found was that 2 of those subtypes were similar in our population, the other 2 were different. Where did the study population come from? We had first a cohort in which we defined it, and then we validated another cohort. So the first, the cohort that we used came from our own clinic population from across the country. We included patients who had recent onset diabetes, about 20,000, much larger than the Scandinavian one. They had about 8,000. And we tried to classify them using the same clinical cut points. To cut a long story short, we could not. And therefore, what we did was we tried several iterations. And finally, when we added the HDL cholesterol and the triglyceride, everything fell into place. Because that was a missing link. Because we have this low HDL, which defines our population. So once you put that into the equation, everything fell into place. Now, we had the HOMA beta and the HOMA IR, which the Scandinavian group used. But then in our clinic population, one of the routine tests that we do is C-peptide. I'm very interested to hear Colin's next talk on when to use C-peptide. We kind of use it mostly everyone because in a young patient helps to classify. In a type 2, it tells us how much of insulin secretion, particularly with reference to the clustering now, it helps us. So it's a kind of a routine assay at our center. So when we did that, after that what we did was, so we got 4 subgroups. After getting those 4 subgroups, we said, well, this is a clinic-based population, so it can be subject to bias. So we went back to INDIAB. INDIAB, as you know, is a study recently published in Lancet Diabetes, which is making a lot of headlines for the numbers of people with diabetes in India is now 101 million, as you may know. So we have the whole of India covered, and we have a very large sample size from each of these states. So now what we did was, after getting the, we put in those variables, now we said, if we want to extend this to the rest of the country, can we leave C-peptide also out? Because these variables, age at diagnosis, BMI, waist, A1C, HDL, and triglyceride are available in every clinic. So any clinic, anywhere in India should be able to do that. So we did that, and we were happy to find that we are able to reproduce it even without the C-peptide. So we got 4 subtypes now. The severe insulin deficient variety is similar to what Scandinavian group had shown, except that they are much more severely insulin resistant, and they're much younger, much thinner than the Scandinavian, of course much younger. And then the second one, insulin resistant obese diabetes, is again little similar to their population, but again the type of obesity was very different. Funnily enough, we had a third variety, which is called as the combined insulin resistant and deficient variety, 12% of our patients. Now these guys had the lowest HDL and the highest triglyceride in the whole group. We know that everyone, all these groups have much lower HDL and higher triglycerides than the white Caucasians, but this group stood out because they had the lowest HDL and the highest triglyceride. Now we had the MARD variety, the mild age-related variety, but the difference was that our mean age was 50 years. Their mean age was 68 years. For them, all the groups were above 50 years of age. For us, all the groups were below 50 years of age, and our older patients were just 50 years of age. So you can see what a difference there is between what was reported in Scandinavia and what we did. Just to show you the characteristics of the, I won't go into the details, but obviously the SID variety is the leanest, they have the leanest BMI, they have the lowest waist, and if you look at the IROD variety, they have the highest BMI and the highest waist, and the best C-peptide, of course. And then the CIRDD variety came in between because they have insulin resistance as well as insulin deficiency. But look at the triglycerides. Look at the HDL. The mean HDL is 40, 38, and 42. In a Western population, it would be about 50 or 60. Nobody will have below 50 HDL. So here, whereas in the third variety, it is 36. That's the lowest HDL that we could find. Look at the triglycerides, 149, 155, and 136. 351 in this group. So they stand out as having the highest dyslipidemia. Now, this clustering, I'm happy to say, has now been replicated in the South Asian, the UK. This group included Pakistanis and Bangladeshis and not Indians. This is published in PLOS Medicine. And the authors say that this combined variety of CIRDD, which we had reported, is now confirmed. It's also been confirmed in the Chinese population, by the way. So we are able to reproduce previously described diabetes subtypes. I'm happy that the South Asians seem to have a common variety. Now you may ask, what is the clinical significance of doing all this? We were happy treating diabetes earlier. Now you come and confuse us with all these clusters. And does it make any sense at all? Well, it does make some sense. The Scandinavian group had again said that the insulin deficient group is more prone to retinopathy, whereas the insulin resistant group is more prone to kidney disease and heart disease. So that's what they'd shown. Now we found the same thing. The SID variety more prone to retinopathy, whereas the insulin resistant variety more prone to kidney disease. What about those
access and affordability, ensuring that complementary medications address pathophysiology, we overcome inertia, we look at social and psychosocial factors, education and language. And therefore this was the approach, and as I told you that the cardiovascular risk factor approach, which was blood pressure, lipid, antithrombotic agents, smoking cessation, was also as important. The cardiorenal approach was equally important with the advent of SGLT2 inhibitors and GLP-1 receptor agents. They really went up on the pecking order, and therefore we had a very, very complex holistic graph which came up, and this is how the final guidance was looking at. Where if you see, the goal was cardiovascular risk reduction. On the left hand side, atherosclerotic cardiovascular disease, heart failure, CKD, and in these the SGLT2 inhibitors and GLP-1 receptor agents were right up the pecking order. And on the right hand side you can see if affordability is a challenge, then of course SUs were there, but otherwise excluding them, when weight was the issue and glucose was the issue, it is all GLP-1 receptor agents where semaglutide, tirzepatide, dulaglutide and liraglutide were right up the order. Another important thing in the guidance was the importance of integrated care. And in integrated care it was all about lifelong nature of type 2 diabetes, identifying and having a team approach, using the local resources, and language matters in diabetes care. That was the key. Also it's important to understand that each individual person living with diabetes has different risks and different preferences, including cultures and food habits. Every healthcare system should address and monitor the inequity of delivery of evidence-based interventions. We need to look at social determinants of health, and we need to incorporate multimorbidities or comorbidities in the management plan. Clearly diabetes self-management and support is the key. Education makes a difference, and facilitating healthy behaviors and weight management is equally important when we look at different features. When it comes to choice of glucose lowering medications, we definitely need to know the pharmacotherapeutic approach, the comorbidities of obesity, CVD, heart failure, CKD and MFLD. Look at the profile of each individual, younger age, frailty, limited life expectancy, cognitive impairment, and then look at adverse events like hypoglycemia, volume depletion, genital infection, history of pancreatitis, and then prioritize organ protective medications like GLP-1 receptor agents, SGLT2 inhibitors, glitazones in those who have either a cardiorenal disease or NASH or at high risk. Insulin still has a place in type 2 diabetes, but probably GLP-1 receptor agents should be considered prior to initiation of insulin in type 2 diabetes. And if you are initiating insulin, the basal insulin is the standard of care, and of course you need to titrate it to individual care, and then of course insulin can be continued with other glucose lowering medications, and education is the key. So clearly in the new algorithms, place of insulin is very much there, but the bottom line, and this is probably the best slide of that whole AD-ASD consensus, is make it work. We are all committed to getting goals for people living with diabetes and making it work. Simultaneously after AD-ASD came out the guideline. So as the AD-ASD was a consensus report, the ACE came out with the guideline, and their guidelines looked at glucose lowering, hypoglycemia avoidance, weight gain, cardiorenal risk, and again individualization was the key. And in their guidance again metformin was very much there, but atherosclerotic cardiovascular disease, heart failure, CKD, obesity and fatty liver were independent of glucose lowering effect. So, and therefore right up on their pecking order as a first line or as an add-on to metformin, SGLT2 inhibitors and GLP-1 receptor agents came in the picture because of cardiorenal and metabolic risk of comorbidities. And therefore clearly you can see their algorithm, all people with type 2 diabetes control cardiovascular risk factors, and then based on the risk of atherosclerotic vascular disease or heart failure or stroke or CKD, either a GLP-1 receptor agent or SGLT2 receptor or a glitazone came up on the pecking order, and these three categories of agents got a higher pecking order in the ACE guideline. And clearly you can see that if the A1C was more than 7.5, then dual therapy was recommended, and I think in India we have been using dual therapy for a reasonable period of time. And again, agents which don't cause hypoglycemia like a GLP-1 receptor agent or a SGLT2 inhibitor or a gliptin had a grade A and a level 1 evidence which was there. And if the A1C entry was more than 9% or more than 1.5% of the target, it was a dual or a triple drug therapy which was recommended, including basal insulin. So if there was a symptomatic patient, catabolic patient with weight loss, A1C about 10%, a glucose about 300, level A1 evidence, the ACE guidance said start with basal insulin and a dual and a triple therapy which can be there. So obviously you can see that matching glucose monitoring option in complexity of drug regimen was so seen there. Dyslipidemia also had its own guidance in type 2 diabetes. Triglycerides were looked at, and diabetic peripheral neuropathy has a detailed guideline. Is the pain due to diabetic peripheral neuropathy? If it is not, then refer it to a pain or a neurological clinic. If it is there, then you have different choices of agents. They looked at right from exercise to a capsaicin patch, to the old tricyclics, to the SNRIs like duloxetine, to the conventional agents like pregabalin or gabapentin. And if there are persistence of symptoms, again, the big bottom line in diabetic peripheral neuropathy was avoid opioids, switch to another agent, and try to max out the best of both agents or refer it to a plain clinic. So if you look at summary of all the global recommendations, the glucocentric approach has moved to a weight-centric, cardio-centric approach. So glucocentric approach forms a very small part of it. It is weight, cardio-centric, and it is the cluster of type 2 diabetes, obesity and cardiovascular diseases where it matters. And therefore, if you look at the IDF guidance, the RSSD or ESI wheel, and Bansi is here and he was a part of that wheel process with Rajiv Chawla was there as a president, and then of course Dr. Das is here, and clearly we can recognize that this RSSD wheel incorporated all these factors and they tried to integrate it. So obviously when we are treating diabetes, we need to do lifestyle, look at complications and progression, look at therapy cross and comorbidities and pill burden, and we need to simplify regimen. Glucose, hypoglycemia, weight, comorbidities and adherence is the key, and we see a full spectrum of people in diabetic clinics: malnourished, lean, thin built with central obesity, normal weight, normal build, overweight, obese and morbidly obese. And therefore when we look at the lean population, the global guidelines don't apply. If you look at a lean non-obese population, and almost 20 to 30% of the people we have less than 25 BMI, and 10 to 20% have body fat in the non-obese range. And there are 5% of our population below BMI 19, especially in rural and hilly areas. So remember, BMI below 25, they still have intra-abdominal fat. They still have insulin resistance. And metformin still may be apt if the BMI is above 19 or 20 up to 25 in the Indian population. But if it is below that, obviously that's not standard of care. The second challenge where global guidelines are not suitable for India is when people present with ketosis, and often type 2 diabetic patients present in ketosis with severe infection, surgery, trauma, steroids, interruption of therapy, sweetened beverages and so on and so forth. And therefore we need to recognize that subtype of ketosis proneness. So when we look at our phenotype, and Dr. Mishra had got out an article with Bansi there and many of us in that author and paper, we need to look at the BMI, presence of ketosis, infections and major morbidities, and the A1C. And probably what is not there in the global guidelines are alpha glucosidase inhibitors. While we are a carbohydrate country, we still eat a lot of carbohydrates, and probably AGIs are the only thing which have been additionally added to. So with brevity of time, with the time allocated to me, I can see my clock is ticking. One size doesn't fit all. When clinicians need to adapt to global recommendations, we need good glycemic control. We need to hit hard, hit early. We need to ensure that glucose control is important, but with glucose control, we need weight, cardiorenal protection and cardiovascular risk profiling. We need to achieve these strategies of glucose targets with patient safety, which means no hypoglycemia, no weight gain, and treatment has to be individualized. Finally, of course, we need to look at happiness of the patient. It's as important as health. Health outcomes are important, but keeping a happy patient is equally important. And we definitely are in a digitally intoxicated world, so probably we need to do a digital detox. Thank you for a patient hearing.
Thank you, Dr. Shashank, for a wonderful talk and making it very, very simple for a clinician, using prudence to how how to go in the best interest of the patient. We are being guided by so many guidelines, but I think ultimately it's clinician prudence which should be par excellent, and it should be largely in the interest of the patient. Fixing the hierarchy of the drugs, maybe many times metformin as a first line option, and maybe GLP-1, or tomorrow maybe dual agonist and GLP and GIP. So I think you have to leave. So if there are any questions, I think you will not be able to stay back now till the end.
Sir, sir, patient unable to tolerate the drug GLP receptor antagonist because of the GI symptoms. Is there any option, or we have to change other drug?
So usually if it is a mild nausea, you can continue the drug if it is tolerable, but if the nausea is unbearable, then you need to discontinue the drug. And you need to look at other options.
No other medication can be
you can change the GLP-1 receptor agent. For example, if you are using a dulaglutide and you want to try a once a day, Victoza, that's another option which you can look at. Oral semaglutide sometimes is very intolerable for some people. Again, the tolerance threshold varies for individual to individual, but usually it is self-limiting. And if the person can survive beyond a week or two, it's quite reasonable. But sometimes some people just can't tolerate it, just like metformin. Metformin also has intolerance, and GLP-1 receptor agents also have intolerance. So if there's an intolerance, you need to switch.
Any role of prokinetics before?
Sorry?
Prokinetics
No, but we can use a PPI with domperidone or something. There is some role for that, for initial phase of it. But it's not going to really keep you in the long run. But I completely agree with you that we have many patients, but 1 in 10 people who will get an intolerance which is pretty severe, which merits discontinuation of the drug.
Thank you, Dr. Shashank, and I'll request Professor Colin to present you a memento as a matter of respect.
Okay, now it's a great pleasure to invite Professor Wasim Hanif to the podium. And this time he's going to be talking about an update on diabetic kidney disease. He's already had an introduction, so we don't need to go through that again. Wasim.
Cheers, thanks, Colin. So I'll probably, because this is going to be slightly long, so I'll just stuck into my talk immediately. Now this is a very interesting picture. I actually picked it up a few years ago. Now what I'm told is the chap who's sitting below the picture is a chap called Gale. The only Gale I knew was Chris Gale from cricket, but he was a physician during the time of the pharaohs in the Egyptian times. And I was told again, I can't read the hieroglyphics. This is the hieroglyphics from the kidney, from the pyramids, in which there is a description of a disease like diabetes. And Gale actually described this disease as a disease of the kidneys, where people actually urinate sweet urine and that kind of stuff. And I think he was absolutely spot on, because I definitely think that diabetes is a disease of the kidneys, and in the next 15-20 minutes I will try to explain to you the importance of the role of the kidney and what we can do, especially in the light of the new medications coming up. Now this is a quite depressing graph that basically looks at one single heart point, that is the number of people receiving renal replacement therapy. And this is mostly either dialysis or renal transplant. What it actually shows is that it is going to rise, and it's going to rise globally, and majority of these people have got diabetes. But the biggest rise of people requiring renal replacement therapy is going to happen in Asia. There could be a number of factors, we could look into it. If you look at all the diabetes complications, be it the data coming from the United States, the United Kingdom, be it amputations, DKA, retinopathy is going down, but renal replacement therapy is going up. Now, this is a thing that I use whenever I talk to the medical students and to the policy makers, that the dialysis survival, once the person goes on dialysis, the survival is actually worse than some of the common cancers. So you can see people with breast, prostate and colorectal actually do better than people with dialysis. The only two cancers that patients do worse than dialysis are pancreatic and lung cancers. Now we are talking about obesity decreasing your lifespan by 6 years. With diabetes, your lifespan decreases by nearly 16 years, and that's a big number. And this is with patients on dialysis. But the moment you start developing early CKD, the lifespan starts decreasing by about 6 years. So you could see that it's the whole health of the kidney that actually decides how long are we going to live. Now we looked at some of the epidemiological data. Now let's look at what can be done. So if you look at the natural history of diabetic nephropathy or diabetic kidney disease, as we call it, it's pretty long. You need to have diabetes, be it type 1 or type 2, for nearly 20 to 25 years before your kidneys pack up. That means your chances of intervention are actually pretty big, both in terms of managing and preventing end-stage renal disease. Now, one of the big confusions, especially if you've got an elderly population as we have in the UK, is correlating EGFR with the renal function. EGFR is very good if there is established kidney disease, but if somebody does not have established kidney disease, and measuring an EGFR of somebody in 80s or 90, who's 80 or 90 years old, then you can get it wrong. So this is a risk equation which we use in our clinics, because we've got one of the largest diabetes renal clinic in the country, which we run with our renal colleagues, and we have got one of the biggest renal replacement units in Europe. So this is quite easy. I would probably encourage all of you who manage patients with diabetes to actually look into it. It's called Kidney Failure Risk Score. It's the UK one. If you Google it, you get it. And it's pretty easy. You put in the age of the patient, you put in their gender, you put in the EGFR, and you put the albumin-creatinine ratio. Once you've done it, so here we look at a 56-year-old man who's a male, his EGFR is 32 and ACR is 135. And what it gives you is two things. It gives you the risk, which is a validated risk score of his developing end-stage renal disease requiring dialysis or renal replacement. So at 2 years, his risk is 6.9%, and at 5 years, the risk is 22.5%, which is quite huge. So the current NICE referral criteria in the UK is if the kidney failure risk equation is greater than 5%, then they need to be under the care of the specialist service, be it nephrologist or endocrinologist who have got expert in managing renal disease. Now let's start looking at the options of what has changed or is going to change in the management of diabetes kidney disease. So about in the 90s, we had two important clinical trials, basically looking at type 2 diabetes and the role of ACE inhibitors and ARBs. These were the renal study and the IDNT study. Both these studies showed that using an ACE inhibitor or an angiotensin receptor blockers reduces the relative risk reduction of progression to kidney disease by nearly 16 to 20%. And you could see from the Kaplan-Meier curves, the curve starts separating at about a year or a year and a half, which means the patient had to be on an ACE inhibitor or an ARB for nearly 12 to 18 months before they started getting the effect. And since then, we have been involved in a number of clinical trials, basically trying to find another agent that is going to be protected towards the kidneys. So you can look at some of these names, and we've been involved in nearly most of these clinical trials, and all these clinical trials fail. So basically what they showed was that these medications don't work in terms of protecting kidneys from damage, especially in people with diabetes. Now I'm going to switch gears and just try and explain, and I would request you just to concentrate about what the challenges are in the management of diabetes kidney disease and how the new therapies are going to help. So this is a normal glomerulus. We have got the efferent arteriole and the efferent arteriole. The blood comes in through the efferent arteriole over here, and it goes into the Bowman's capsule, and it comes out through the efferent arterioles. Now if you start developing diabetes, the first thing that happens in diabetes is a stage of hyperfiltration, which means more blood is delivered to the efferent arteriole, and because of that the efferent arteriole dilates, allowing more blood to go into the glomerulus. Once more blood goes into the glomerulus, if you remember from physiology days, the renin, angiotensin, aldosterone mechanism comes into the place, and because of it the efferent arterioles gets constricted. So you have got a dilated afferent arteriole and a constricted efferent arteriole, which means the pressure on the glomerulus starts increasing, and that starts damaging the basement membrane, leading to the early changes of diabetic nephropathy, leading to proteinuria, and finally the glomerulus damage and the loss of the nephron. So this is the essential mechanism. Now when we started using ACE inhibitors and angiotensin receptor blockers in treating the kidney disease, these tend to act on the efferent arteriole. So the efferent arteriole, which is constricted, the RAS inhibitors, be it ACE inhibitors or angiotensin receptor blockers, reverse the constriction, causing dilatation of the efferent arteriole, so the blood can keep going. But the afferent arteriole still remains dilated. Now what we have got with the SGLT2 inhibitors is they act on the efferent arterioles and they actually constrict it. So what we are having, if you use ACE and ARB with an SGLT2 inhibitors, you're almost reversing the effects of diabetes in the kidneys. But the important thing to remember is that you need to use the ACE and ARB along with the SGLT2, because one will work but will not work that effectively without the other. So this was the theory. Always it's good to do the theory, but you need to do it in practice. So this was one of the number of clinical trials. So there was the Credence, now we have got the EMPA kidney and the DAPA CKD. All these clinical trials were pretty much the same. They had people or patients with albuminuria with a low EGFR, and these patients were treated with either dapagliflozin or other SGLT2 inhibitors along with placebo. The primary endpoint, because these were kidney trials and not cardiovascular trials, the primary endpoint was protection of the kidney. So what these trials showed in the primary outcome was greater than 50% EGFR decline. ESRD, renal or CV was the primary outcome with a number of secondary outcomes. And what did it show? Now I showed you earlier the graph of the ACE and ARB, which was 16% reduction after 18 months. With the SGLT2 inhibitors, it's the Kaplan-Meier curve started separating at about 8 months, and the relative risk reductions was 39%. But the thing that impressed most me about this clinical trial with SGLT2s is numbers needed to treat. So you just need to treat 19 patients to prevent one renal failure, which I think is very good. And we get similar numbers from the Credence, which was canagliflozin. Primary outcome you need to see 22, ESKD 43, and ESKD doubling of serum or renal death 28. So very, very low numbers showing very, very effective in the clinical trials. Now let's switch gear and look at the role of the RAS. So this is the effect of aldosterone on brain and heart. So once the angiotensinogen is converted in angiotensin 1, 2, it releases the aldosterone, as I said, which plays a role in the kidney damage, because aldosterone not only acts on the kidneys, it acts on the heart and strokes, causing renin to increasing the blood pressure. Now we have got a new agent that has been launched and we have started using in the UK, and I'm sure it's going to be available, if not already available, in India and other countries. It is called finerenone. Finerenone is a novel non-steroidal selective antagonist of mineralocorticoid receptor, and it blocks the MR-mediated sodium reabsorption. So it's shown to reduce cardiac and renal hypertrophy along with the reduction of BNP. The only kind of side effect that you have to look for when you use finerenone is hyperkalemia. So what is the evidence? So the evidence of finerenone in the protection of the diabetes kidney disease was tested in the FIDELO study. The FIDELO is again, the primary endpoint here is the kidneys. Huge number of patients admitted, nearly 14,000, 5,000 randomized. It's a hierarchical endpoint. The first is kidney composite, followed by cardiovascular composite, along with a number of other composites. And there was the Figaro DKD, which is again a very similar trial with similar numbers, with the numbers now increasing to nearly 33,000. Important thing to understand, the baseline characters was typically of patients with diabetic kidney disease, long duration of diabetes, suboptimal diabetes control. What is very important is to look at the baseline therapy. Again, nearly most of the patients were on ACE inhibitors or ARBs, very small patients on SGLT2 inhibitors, but varying therapies. And this was the primary renal composite. Again, Kaplan-Meier curve started separating about a year, 18% risk reductions, numbers needed to treat, again very low at 29. And you could see that all the primary endpoint in this forest plot showing a positive effect towards using finerenone. And if you look at the subgroup analysis, which is very interesting, it works in patients less than 65, more than 65, both the genders and across all regions. This was one of a good clinical trial that had patients from all regions. It was shown to be slightly more effective in Asians, but that, as I said to you, is a subgroup analysis, but it works, and it works in all ethnicities. This is again is very interesting. The baseline, so even if the patient was on SGLT2 inhibitor or not, the number of patients are very small, so it shows a slightly
understand how they work and what they're going to do on the kidney and what they're going to do on the heart in the longer term. So we've got another 10 years of this to come, haven't we, up to the Silver Jubilee and beyond, when we can explore a new chapter in type 2 diabetes management. So thank you both, and thank you to Wasim as well. Thank you. Yeah, nothing there.
Thank you, chairpersons. Thank you, speaker. So moving to the next session, I would like to invite Dr. B.M. Makkar sir and Dr. Vijay Arora sir to chair the session. Dr. B.M. Makkar sir is Director, Dr. Makkar's Diabetes and Obesity Center, and Dr. Vijay Arora sir, Senior Director and Head, Department of Internal Medicine, Max Super Speciality Hospital, Patparganj, Delhi. So over to you, sir, for the session.
Good afternoon, friends. Once again, welcome to this post-lunch session of CMRE. We have two talks in this session currently. One is on cardiometabolic disease in young diabetic, and second is the multimorbidities, and we have two very eminent speakers to do the job. So I would request Professor Inas to please come and start with her session on cardiometabolic disease in young. She has already been introduced in the morning, so I'm sure you have heard her wonderful session on diabetes in women in the morning. Over to you.
Thank you very much for the kind introduction. And I'm going to talk about the cardiometabolic disease in the young diabetic. Moving. It's not moving. This is the global prevalence of overweight and obesity in the young. We were having 41 million child less than 5 years living with overweight or obesity in 2016, and more than 340 adolescents and child between 5 and 19 years old living with overweight or obesity. These are the causes of childhood obesity. They are complex and multifactorial. We have the genetic predisposition, endocrinal causes, psychological causes, neurological and hypothalamic causes, environmental causes, which are very important, and drug-induced causes. According to different associations and health organizations, childhood obesity is a disease and a health issue that needs to be targeted as a priority. European Association for the Study of Obesity and World Health Organization and Endocrine Society consider obesity and overweight in childhood is a priority and need to be addressed. The pediatric overweight and obesity is accompanied with multiple comorbidities and complications. These are some complications: pseudotumor cerebri, sleep apnea, early subclinical atherosclerosis, cardiovascular morbidity, and premature mortality in childhood, in adulthood, later in adulthood, dyslipidemia, NAFLD, pre-diabetes and type 2 diabetes, prehypertension and hypertension, hyperandrogenism, and polycystic ovary syndrome, proteinuria, and focal segmental glomerulonephritis, slipped capital femoral epiphysis. These are many complications and comorbidities, and those are some other problems in obese children in other references. Diabetes, high blood pressure, heart disease, stroke, sleep problems, liver disease, early puberty, early menarche, eating disorders such as anorexia or bulimia, skin infections, bronchial asthma, other respiratory problems, gallstones, sleep apnea, again, increased intracranial pressure, Overweight children are more likely to be overweight adults. And there is increased mortality rates during adulthood and several types of cancers and osteoarthritis. Many complications for obese and overweight children in the future. These are some psychological disorders, either emotional or psychological problems happen to children at young age, and they usually experience harassment or discrimination against even by their own families. Low self-esteem and depression sometimes. The role of adipocytokines in childhood and early adulthood obesity. The secretory role of visceral fat derived pro-inflammatory cytokines, interleukin-6 and tumor necrosis factor, and adipocytokines like adiponectin and leptin. They appear to be directly associated with obesity and insulin resistance. Tumor necrosis factor and interleukin-6, they are related to adiposity, triglycerides, and total cholesterol, and negatively related to HDL cholesterol in healthy adults. Adipocytes and macrophages embedded in adipose tissue overproduce interleukin-6. Expression of tumor necrosis factor and messenger ribonucleic acid is increased in the visceral fat of obese subjects, positively correlating to the degree of obesity and the level of plasma insulin. Interleukin-6 and tumor necrosis factor mediate lipolysis indirectly and augment hepatic synthesis of fatty acids, leading to increased serum level of fatty acids and triglycerides. The inflammatory cascade triggered by these cytokines in turn favor enhanced hyperinsulinemia. Interleukin-6 and tumor necrosis factor act directly at the insulin receptor to produce insulin resistance. 1 in 3 children born in US after the year 2000 will become diabetic in the future, according to Center for Disease Control. This is the relationship between type 2 diabetes and obese youth. Before 1990, only 5% of cases of diabetes diagnosed in children and adolescents were classified as type 2. But now they account for 30 to 50% of new cases of diabetes in the youth. They parallel the national data estimating tripling in the rate of overweight in adolescents in the past 20 years. And type 2 diabetes in the young is considered #1 consequence of the epidemic of obesity. Children are becoming more sedentary with less physical education in school, more screen times. Only 50% of them get regular physical education or physical activity, and 14% of teenage report no physical activity at all. These are the risk factors for childhood type 2 diabetes according to Diabetes Canada. The type 2 diabetes as in the first or second degree relative, high risk ethnic or racial group, obesity, impaired glucose tolerance, polycystic ovary syndrome in girls, exposure to diabetes in utero by gestational diabetes of the mother, acanthosis nigricans as a sign of insulin resistance, and some new risk factors newly considered like hypertension and dyslipidemia, non-alcoholic fatty liver disease, and the use of atypical antipsychotic medications in childhood. These are the clinical features at diagnosis of type 2 diabetes in the young. They may be asymptomatic or having sign of insulin resistance like acanthosis nigricans in 73%,
but almost all of them, 95%, are obese. 12% are having polycystic ovary syndrome, 45% are having dyslipidemia, 28% are having hypertension, ALT elevated or NAFLD in 22%, and microalbuminuria in 14%. This is an important question: when and how to screen for type 2 diabetes in the young. This is according to AGA. In overweight or obese child or teenage, we screen for diabetes or pre-diabetes, especially with maternal history of diabetes or gestational diabetes during that child generation, family history of type 2 diabetes in the first or second degree relative, certain race, and signs of insulin resistance like acanthosis nigricans, dyslipidemia, hypertension, polycystic ovary syndrome, or gestational for birth weight. And Diabetes Canada added some other risk factors, like certain races and ethnic groups: African, Arab, Asian, Hispanic, Latino, or South Asian descent, and those with NAFLD, with ALT more than 3 times upper normal, or fatty liver with ultrasound, and those with impaired fasting glucose or impaired glucose tolerance, and the use of atypical antipsychotic medications. How to screen? The recommended screening is hemoglobin A1C plus fasting or random plasma glucose. And if there is discrepancy between the two results, then we do oral glucose tolerance test. Another important question: what are the associated complications and comorbidities in youth with type 2 diabetes? And there are short-term complications in the form of diabetic ketoacidosis and hyperosmolar hyperglycemic state, and long-term complications. Evidence suggests that early onset of type 2 diabetes in adolescence is associated with severe and early onset of microvascular complications in the form of retinopathy, neuropathy, and nephropathy. Therefore, we should consider screening at diagnosis and then yearly after. This is a comorbid condition, dyslipidemia. We should do screening at diagnosis, then every 1 to 3 years, and to start statin if there is failure of lifestyle modification for 3 to 6 months. Hypertension, to screen for high blood pressure at the onset, then in frequent visits, and if present, we screen to detect conditions associated with insulin resistance, like polycystic ovary syndrome and non-alcoholic fatty liver disease. This is the screening schedule according to Diabetes Canada. We screen for neuropathy and retinopathy at diagnosis, then every year later on. And we screen for nephropathy at diagnosis and then yearly. And we screen with albumin creatinine ratio or first morning random test. Dyslipidemia screening should be done at diagnosis and then yearly. We screen with fasting total cholesterol, HDL, triglycerides, and LGL. For hypertension at diagnosis, then at every visit, and to use the appropriate size cuff. NAFLD, yearly screening after screening at diagnosis with ALT and fatty liver on ultrasound. Polycystic ovary syndrome, to screen at diagnosis, then yearly, and to clinically assess the young female on history and physical examination for oligomenorrhea, amenorrhea, acne, or hirsutism. Obstructive sleep apnea, to screen at baseline and then yearly screening. Depression, screening at diagnosis, then every year. Binge eating, to screen at diagnosis, then yearly thereafter. And young adults with diabetes have higher rates of cardiometabolic risk factors. It can lead to increased disease prevalence and mortality among these individuals at a younger age. The presence of diabetes in young adults increases the exposure to chronic hyperglycemia and accompanying cardiometabolic risk factors early in life, leading to reduction of lifespan, cardiometabolic disease, cardiovascular disease, kidney disease, lifetime diabetes complications in middle age. These are the estimated morbidity and mortality in adolescents and young adults diagnosed with type 2 diabetes, and for causes of mortality we can find end-stage renal disease and coronary heart disease and stroke. And for diabetes complications, the most prevalent is microalbuminuria, followed by nephropathy, coronary heart disease, stroke, peripheral neuropathy, and end-stage renal disease. Let me finish with this important question: how can we stop the cardiometabolic epidemic? These are the recommendations for healthy diet of the International Diabetes Federation for the general population, which should be adopted for young adults and children. To choose which beverage, to avoid soda, to avoid juice, fruit juice, and to eat servings of vegetables and fruits, 3 servings of vegetables and 3 servings of fresh fruit every day, and how to use unsaturated fats like olive oil, canola oil, corn oil, or sunflower oil instead of saturated fats, to choose lean cuts of white meat instead of processed meat. Also, these are the WHO recommendations for physical activity for different age groups, and for children between 5 and 17 years old, they should do at least 60 minutes of moderate to vigorous intensity physical activity daily. How to prevent? By active play, by less TV and video games, more exercise and physical activity, healthy eating habits, weight loss, and medications if there is high blood glucose level. There should be a team approach for prevention of type 2 diabetes, endocrinologists, physicians, general practitioners, diabetes educators, dietitians, students, family, school, and media. How do we initiate the change? Schools can provide quality physical education classes, nutrition awareness campaign, parent education and awareness campaign, psychological education and intervention, and school nutritional policy. Parents are an important influence on their children eating habits. The main message: change will take time, begin with just a few small steps. Thank you.
We can have questions at the end, so you can join us here, please. Next session is on multimorbidities in diabetes, challenges and solutions, and speaker is none other than Professor A.K. Das. I am sure nobody here needs introduction for Dr. Das. Sir knows everyone by name and everyone knows him.
Thank you, thank you. Esteemed chairpersons and my dear friends, we are going to discuss something very different. We are going to discuss the type 2 diabetes and its multimorbidity. This has become the most important contemporary topic to discuss. WHO has asked us to discuss this topic everywhere. Government of India is going to organize a series of programs to make people aware what it is exactly. What is in this presentation? Now, this is a new emerging concept. It involves around the concept that diabetes is not a single disease, it is a multimorbid condition, and it is clustering of complications. I'll describe in a minute, and one has to be awake that it is a multimorbid condition. Now, the emerging evidence says that simple practices has great impacts and changes destiny of this person with diabetes mellitus. Now we have specialists are needed, but this particular WHO movement calls for the fact the specialist has to de-encapsulate. There is encapsulation when you become a specialist. There is a de-encapsulation to be expert generalist. That is the call. You become expert generalist in addition to your own specialty to take multiple condition. So I have a small agenda. We'll finish in time. It's about what is comorbidity and what is multimorbidity. Are they same or they're different? What is the epidemiology of this multimorbidity, and how does it go with the epidemiology of type 2 diabetes mellitus as a whole? And what is the association of this multimorbidity on the diabetes outcome? Something we'll discuss about the COVID-19, the management issues. Dear friends, to make a long story short, any distinct additional entity that has existed or may occur because of the parent disease, we call it comorbidity. I'll give the example a little later. But multimorbidity is the co-occurrence of multiple chronic diseases or medical conditions within one person without a reference to the index case. A diabetic getting cancer is a multimorbidity. A diabetic getting pathies, 3 pathies, is a comorbidity. Diabetes getting Alzheimer's, depression is a multimorbidity. Whereas diabetic getting the complications, metabolic complications, comorbidity. Dear friends, now one must also remember that the comorbidities interact with each other and they can include physical or mental health. But it must be remembered that people, or the comorbidity, multimorbidity sometimes can be used exchangeably with each other. But people who have these morbidities, they have 4 things. They have poor functional status, they have poor quality of life, they have poor health outcomes, and they use more often inpatient care or ambulatory care than the people who do not have these conditions. Sorry. Now, when these comorbidities are taken into account, now many of these people take a suboptimal care. If somebody does not have multimorbidity, the care is optimal, but with multiple comorbidity, the care can be suboptimal. Now, this cartoon is very important. This shows that it's called a wider system approach and a developmental anomalies in the comorbidity. Now, they call it distal factors or proximal factors. This is a new concept. Distal factors means which are little different in the process of getting the complications, like social factors, like attitude, social stigmas, the culture. They produce, they call it distal factors. The proximal factors like genetic predisposition, your habits, a person's habit like smoking, alcohol, lack of exercise, we just now heard, diet deficiencies, they are called proximal factors. There are psychological factors like smoking, like stress, there is a lot of anxiety, there is self-esteem which becomes low. There can be cultural factors and the clinical factors like lack of screening, the quality of care being less, there may not be timely intervention. These are called proximal factors. Now, I have just told you that the multimorbidity can occur in clusters, that means they occur in together. Now, many of the comorbidity can be traditional that we see every day, like they can have neuropathy, retinopathy and cardiopathy. But they can be non-traditional, like they can have liver disease, they can have dementia, they can have cancer, they can have depression, they can have Alzheimer's. They are non-traditional. But some of the complications, we call them as emerging complications, like diabetics develop a lot of joint disease, the comorbidities. They can develop COPD, obstructive lung disease. They are called emerging complications. Dear friends, now if you look at the traditional complications and the emerging complications, In the emerging complications, we have much more morbidity, like they have functional disability, cognitive dysfunction, they have affective disorders, they can have liver diseases, and many other things. Dear friends, this is a slide which we published on the June 7th of this year in the Lancet. All of you have seen this. This says that diabetes as a disease has multiple conditions associated with this. Hypertension, look at this, 40.7%. Dyslipidemia, 83%. Hypercholesterolemia itself alone, 27%. Hypertriglyceridemia, 36%. Low HDL cholesterol, which Mohan emphasized, 70%. High LDL, 24%. And obesity, almost 40% in urban area, 23% rural areas, and I have given the male and female 25 and 31. So diabetes per se today has great degree of morbidity and a lot of conditions. Now, does this multimorbidity matter? Now, living with multiple morbidity along with diabetes is becoming today a norm rather than the exception. And this gives rise to poor quality of life, more hospital admissions, and higher mortality. And therefore, we will discuss why this occurs, how we can take care of it, and I have got another 13 minutes, I will finish within that. This cartoon shows that if a diabetic lives longer, which is norm today, then the number of multimorbidity that he has increases, starting with 0 in the top to the dark blue, where it becomes almost 8 comorbidities. Therefore, one lives longer, one gets more comorbidities. Now, this is a slide I have borrowed from whom Dr. Wasim quoted from Kamlesh. And you know, it is from the UK Biobank data, there are 36 chronic conditions from about 500,000 patients between 40 and 69 years of age. From the UK Biobank, you see what are the diseases there. You can read for yourself, but I'll just tell you that there are diseases we never thought of, like multiple sclerosis. Of course, we have less in India. We have a lot of Parkinsonism diabetics. We have a lot of Sjogren's syndrome. So there are diseases which occurs in diabetics which are not related to diabetes complication per se. Like they can have arthritis, they can have subacute hepatic conditions, and can hepatitis B, etc., etc. Therefore, they found in the study of 5 lakh patients, 500,000 patients, that 19% type 2 diabetic had more than 2 conditions, and the 2 conditions were most important, MI and angina. But the second cluster had 26 conditions, and diabetes was centered at this cluster. They had heart failure, they have chronic kidney disease, which we just now discussed, they had liver failure, they had stroke, and third cluster was 8 highly prevalent conditions like cancer, hypertension, asthma, depression, Alzheimer's, etc. So, dear friends, you can follow the reason why this is presented here. This is a concept which came about few months back. WHO wants to popularize it in many countries, including India, and we have a nodal official in the ministry who drives it. Therefore, we have decided together that we want to talk about this multimorbidity. The whole issue is that this cannot be managed alone by the expert of experts. We need what we call empowered and well-informed generalists. We need a lot of generalists who can deliver this type of care in the population. Now, in the second cluster of 26 diseases, you can observe diabetes was the center, with strong association with diseases I described. Now, how does it occur? There is a cartoon. It occurs because of aging. You know, diabetes makes one aging faster. Stiffness of cells, there is a direct damage, there can be inflammation. So, these are the mechanisms, known mechanisms, which drive these conditions. At the same time, there is also obesity, which just now Inas described, which is associated with 21 non-overlapping cardiometabolic, digestive, respiratory, neurological and musculoskeletal disorders and infections in a diabetic. Therefore, it is the diverse diseases which becomes associated with diabetes as a multimorbidity, and you know diabetes, obesity are quite intertwined, we call it diabesity. Dear friends, if you look at the various BMI categories, starting from less than 20 to more than 35, you can see the various types of odds ratio of having multiple morbidity. Now, I have shown the relationship with the mental health, with the number of physical conditions that people suffer from, and long-term trends of multimorbidity associated with physical activity. This is very important. I think this is the great message that I got from those studies and WHO workshops, that if you want to reduce don't take it lightly because it's a very simple message. If you want to reduce the multimorbidity, the physical activity is a very important means. And in the older English population, this physical activity has shown to be greatly beneficial. Now, this cartoon shows that the 10 diseases that diabetes can have: CAD, hypertension, heart failure, stroke, ischemic heart disease, AF, diabetes chronic, obstructive lung disease, painful neuropathy, depression, dementia, Alzheimer's. So it just shows the various prevalence of these conditions. Now, if you look at the association I have already described, there is a great impact on the quality of life. And what is most important, that the complexity of care also increases. That means you cannot deliver all the care in a simple diabetic clinic. Therefore, today WHO says that you must take care of multimorbidity. Therefore, you must have a clinic which can take care of this multimorbidity. So there is a consultation time is more, rates are more, costs are more, and the cardiometabolic morbidity by this multimorbidity is quite high. You know, diabetes itself takes away 6 years, diabetes plus heart disease 12 years. You have comorbidity, many years are minus from the life. In contradistinction, if one has a diabetic has physical activity, he adds many life years to diabetes, and whether he has multimorbidity or without multimorbidity, that helps. And physical activity shown in this cartoon is very beneficial for the multimorbid conditions. It has been also shown that multimorbidity in diabetes also leads to therapeutic inertia, because a doctor may not be able to address all the multimorbidity. Therefore, there can be a lot of inertia. A diabetologist may not address the cardiovascular complications. There can be multiple inertia, and the mortality also might increase. Coming to the management, now the September 2022 ADA EASD guideline has said, you know all about it, but it has given a lot of importance to the first sentence written in small bold letters, like healthy lifestyle, diabetes self-management, diabetes education, and regular physical activity. So whether you give SGLT2, you give metformin, you give sulfonylurea. The bottom line is what RSDA guideline also has put it, the number one is the lifestyle changes. Now, it has been shown two types of physical activity, leisure time activity and exercise for exercise sake. You will find that we found in DICE-1 in-depth study that the physical activity was much less, and being active increases life expectancy. I told you this is a very important concept from this presentation. Polypharmacy is very common when somebody has multiple diseases, and the medication errors are more when somebody takes more than 4 medications. Now, it has been also shown people with multimorbidity experience polypharmacy, more of medical errors, and increased risk of falls. Therefore, one has to be taken care of that. So there is a complexity of treatment depending upon how many drugs one is taking, 1, 2 or 3. This is a cartoon which shows here that how the treatment becomes more complex by taking more and more drugs. Therefore, there is a new term today that in many of the diabetics, you look whether you can de-intensify treatment. It has been done by many investigators that they have found by a systematic review approach, looking at the rates, the outcomes can be improved sometime by de-intensification. We do that in geriatric practice. So they are also saying that in the diabetes practice, sometimes you have to de-intensify the treatment. Now, it has been also shown that if you want to improve the mortality rates to survival rates, it again lies in the good lifestyle and proper treatment. This is the last few slides that we have at the center of diabetes care a person with diabetes with multiple long-term morbidities. We have so many nephrologists, psychologists, podiatrists, cardiologists, but probably we need also the GPs, diabetes specialist nurse, pharmacist, healthcare assistants, diabetic specialists with remote access, and practicing staff nearby. So the concept is that you must have an integrated multidisciplinary model of care, If not, you must have a good generalist who is well informed. So a good generalist can deliver many of this multimorbid care. Now, what is needed, the key to management, usual thing like patient engagement, education, new ways of working. Therefore, dear friends, to summarize in the last, I have got 4 minutes left. So the action plan that the Government of India has suggested to strengthen the workforce capacity and capacity to improve the safety of the patients, and to take a wider system approach that in the diabetic training program, diabetic teaching program for the nurses and for the diabetic educators, we have been asked to include the topics of the multimorbidity. So take a wider system approach to improve the patient care and the safety. And we have to have the communication regarding this multimorbidities in the primary care, and also build a culture centered around primary care and safety. And also, as far as possible, use electronic tools. The family members and the patients must be involved in your discussion, in your organizing patient care, and also put focus who are at a higher level of getting more multimorbidity, more medication error. For them, we need safety practice. Therefore, dear friends, in the last 2 slides have summarized what I wanted to say. Multimorbidity is a term used when a diabetic has diseases not directly related to the diabetic complication, not the traditional complications. It has become the norm for people with long-term conditions, including diabetes. It contributes very significantly to the health outcomes. We in India need to be aware of this and understand how to support people with the multimorbidity. Diabetes has to be managed holistically rather than as a single disease entity. It's very important. You have to manage it holistically. Type 2 diabetes today occurring very early age. In India, in DIAB study, we saw the starts at 29 years of age, very, very young India. So type 2 diabetes in the young, which just now we heard from Dr. Inas, is also increasing, and they are expected to have lot of multimorbidity, and they are also have to have lot of diseases while they are quite young. So it has been said the parents cannot see or can light the funeral of their own children, because the type 2 diabetes in the young is sometimes, we call it, Dr. Inas, malignant type 2 diabetes, because by 18 years they have lot of complications. So it is malignant unless taken care of. A more integrative, multidisciplinary approach focusing on better management and prevention of these conditions is probably the need of the hour. Now, there is strong association between the unhealthy lifestyle, multimorbidity. I am repeating it again. So what is important is a good lifestyle. There is inverse relationship between the physical activity and the multimorbidity. You can see it in your own practice. The more the physical activity, less the multimorbidity. There is a need to explore the causal association between physical activity and multimorbidity to impact as a primary prevention strategy. Conditions such as diabetes, hypertension, asthma are the epicenters for the clusters of this multimorbidity. A more integrative, multidisciplinary approach is focusing on the better management and prevention of these conditions may help to prevent other conditions in the clusters. Now, type 2 diabetes occurring in the young age, the pattern of multimorbidity may be changing. We have to be careful about it. Thank you very much for a patient hearing.
Thank you, Professor A.K. Das. We are short of time and will defer the question answer session for the later time. I'll request to sit with us.
Okay.
May I request Dr. Bansi Sabu, he is a global diabetic citizen, he is the past president of RSDI, and to deliver his lecture on type 1 diabetes challenges and solutions.
Thank you, Chairperson, for kind words of introduction. Thank you, Dr. Makkar sir, Dr. Rajiv and Dr. Shalini for giving me this opportunity. What I am going to talk on a very interesting and a very important topic, type 1 diabetes in India, the challenges and solution. And one of the biggest challenges, to finish this talk in 20 minutes itself is a big challenge, because in 20 minutes is really very difficult. But there are many challenges in type 1 diabetes. And then the biggest challenge, which I always say, in our meeting, it is primarily a meeting which is around type 2 diabetes. We need more to talk on type 1 diabetes, and that's again a big challenge to get a space in a type 2 diabetes, a symposium on type 1 diabetes. But I will try to finish it. To start with my talk, this particular picture which has been posted by a mother of this child in social media, just to tell everyone that for a type 1 to survive, she has to take 1460 shots in a year. And that's how she can survive. And at the same time, number of times she has to also check her sugar too. Probably she may not be taking the injection through because she is on the pump. On the left side you can see on the hump, and there is she is also on continuous glucose monitoring. But just to create a awareness in the society, she had put this picture on a social media. My conflict of interest is none except a patient for this topic, and I don't have any financial disclosure to make for this particular talk. We have a disproportionate medical burden of type 1 diabetes, and this is what International Diabetic Federation data, and you will be surprised that in India at present we have highest number of type 1 diabetes cases, particularly in young adolescents or in children, which is more than 229,000 people. It is more than US and Brazil. So we are highest as far as type 1 is concerned in young population in compared to US and Brazil as far as IDF 2021 data is concerned. Now very interesting, if you see the middle, the table, every year we get 24,000 new children which are added in this list. So I mean, one side we have already highest number of people with the below the age of 20, but 24,000 young children are added in this list also. But the third slide, which is also very important table, even we are not the country where having highest incidence rate. So incidence rate wise, we are nowhere, not even in the first 50 country of the world. The incidence is not very high. We have still, the rate is between 3 to 5 per 100,000 children, which is much less in compared to the western part of the world or the North Europe. But in that, because the large size of the country, we have very high number of people with type 1 diabetes. Where are these children disappearing? We don't find so many young adults or even adults, or someone we were talking today, Mohan was talking that we have 50 years of type 2 diabetes who is surviving and up to the age of 90. But do we have someone who is at the age of 90 and telling that I am type 1 diabetes, who was diagnosed at the age of 5 and is 85 years, I am the type 1 diabetes. I mean, we have like in a steno clinic, a geriatric type 1 clinic, but we don't have. We have found that many of them are actually dying before or soon after the diagnosis, maybe because of prevalence is after the age of 20, whatever the prevalence data which had shown is actually decreasing in our country. The reason is they are dying very young. If we exactly calculate the way the expatriate Indians in UK, it is 0.54 per thousand population. Probably we should have 9 lakh children in 140 crore people of type 1 diabetes who are diagnosed, and if they all survive. Mostly they don't live long enough to get counted due to the heavy burden imposed by type 2 diabetes epidemic in our country. A type 1 diabetes has been overlooked with terrible consequences for children. And type 1 diabetes incidence is also increasing in our country. May not be the way it is increasing in our type 2 diabetes, but type 1 is also increasing. This is a paper of type 1 diabetes index. And this paper is talking that how many people we should have now. Actually, it was calculated as per them is 8,57,770 population living with type 1. They should be there in our country. But we lost them because they are either diagnosed incorrectly, they were not treated properly, and they have developed the complication. A type 1 diabetes in India at present, if he develops type 1 diabetes below the age of 10 years, this is a type 1 index data, he will not have a normal life. He will lose his life by 45 years of healthy life. So it means he will probably survive only up to healthy life of 28 years, then another 5 to 10 years with a complication, and then he will not survive. So this is the data from India for type 1 diabetes. They will not have a normal healthy life. This is what 44.8 years of his total healthy life year will be lost because of type 1 diabetes, because of the complication which he is going to have. We know there are multiple challenges in type 1 diabetes management, and these challenges are universal. Nothing is specific to India which I am talking, because the complications they are going to have, stress-induced hyperglycemia they are going to have, traveling, exercise, all these issues are there. Across the world they are. But there are some unique challenges in India also. One is, I already talked about the disproportionate medical burden of type 1 diabetes. There is a more years of diabetes, so there is more lifestyle changes. It's very complicated for a type 1 and family. As it occurs very young, so it depends on parents to take care. It is not occurring a type 2 diabetic person who is developing diabetes is himself responsible and he can take care of himself. But while a type 1 diabetes, now he is dependent on the parents, and parents is to be educated also. So here one more education of caregiver you have to do. You are doing education for the type 1 and you have to do the education for caregiver. There is a largely out of pocket expenses, and that put disproportionate burden for healthcare on a poor household. There is a poor infrastructure facility to treat type 1 diabetes, poor public health system we don't have in our private setup as well as in public system, very demanding in terms of medical attention. If you treat type 1 diabetes, you will find that it's really very demanding, because the children, the parents, they keep on talking, they keep on calling you, they will send the messages multiple times. It's really difficult for family to cope, and we don't have so many trained healthcare professionals which are not available. And this problem which I am talking of, challenges, are not only unique to India. I will say that are all in developing countries. So whether it is talking of India, Bangladesh, Pakistan, Indonesia, or even Egypt, I am sure the similar problem is there. Number is so high, but awareness is very, very less. 24,000 children every year added, but pediatricians are not trained because they see one child in a year. So they don't want to listen also. I have done multiple talks with Indian Association of Pediatrics, and they don't want to listen. They say that, doctors, I see only one child in a year. He comes with the diabetic ketoacidosis. I treat diabetic ketoacidosis, and then I send the patient to diabetologist. I don't want to learn more about type 1 diabetes. The incidence of type 2 diabetes is so high, so awareness about type 1 diabetes even at a public health system is also very poor. We met the government, we met the health minister, even we had to explain him what exactly type 1 diabetes, that's sort of a problem. Huge burden of other medical conditions. A physician, a primary care physician is busy with so many medical problems, so he has a really difficult time to talk about the type 1 because he has to teach the person. No long-term survival, data of survival, and we don't have a registry of complication. Even minimal care and a basic care in some parts of the country is really suboptimal in our country. It's more years of diabetes, so more lifestyle changes, more complicated, resign, walking on like a tightrope. One side you have a risk of hypoglycemia, other side always a risk of hyperglycemia, which leads to complications. Most of our type 1 diabetes in India having HbA1c of 9. I am not talking of around 8 or 7 or 7.5, it is 9 A1c, which is the best of the best centers we have collected the data. Lifestyle, particularly change in diet, it's so difficult to caregivers to tell that child will not able to eat any sweet in his lifetime. Carb count is a real challenge for them. Multiple daily insulin injection, that's 4 shots, that's the minimum. But we need to tell the patient sometimes 5, 6, 7. Insulin in school, taking insulin in a public place is a taboo. I mean, I had never seen someone in the so many medical conferences which we do, either we don't have any type 1 who is surviving enough to become a doctor and then he has to take insulin in front of everyone. We have not seen anyone, even a doctor also taking insulin anywhere, checking sugar multiple times in a day, and still sugar is not getting control and getting fluctuation. Even some child to whom you educate and you try to tell him that 5 or 6 shots in a day, 5 times you check the sugar, but still they find there are a lot of fluctuation, and then they get depression that I don't want to do all these things. We all know from the DCCT trial, and this has been done almost 35 years back, we all know that type 1 diabetes, tight glycemic control definitely leads to less complication. That sort of confidence you will not find in type 2 diabetes. If type 2 diabetes, even you aggressively treat, still person may develop cardiovascular disease. For type 1, even we have enough data to show that a tight glycemic control, but it's real difficult, and one of the major difficulties, 60% of your patients will develop severe hypoglycemia. As I told you, the parents are main important person who is to take care. It's a denial. They have always a feeling of acceptance will be real difficulty for them, and they have a diabetes denial and depression also. Just to tell you, in 2011, one of the paper data had shown about that one incident when parent of a sick child refused to treat her. This is not from India, but it is from somewhere else. It was in Diabetes Voice, and they had talked that they have refused to take the child to take the insulin, and ultimately they died. With the prayer, they wanted the child to get healed. There is a cost is a major challenge. Whenever we talk about the type 1 diabetes, whatever the new thing, everybody will start talking about the cost. But I just tell you, we have a 1.4 billion and 20% of our population is affording. It means you combine the UK, Germany and France, 3 important developed countries of the Western Europe, combining their population is equivalent to our population which is affording in our country. So it means we have affording class of people and who can afford everything. I think it is mindset which we have to change, but still the cost is very high for our 80% of the patient, and sometimes they can't afford and we have to give them free insulin too. There is no dedicated department, insulin, no consistent supply in a private as well as in public hospital, both. I mean, it's not just the private hospital. We don't find even private hospital running a dedicated type 1 department. It's very difficult. You have some pediatric endocrine sitting in some department, but there is no dedicated department only for type 1 diabetes. And in public health system also we could not get the same system. It's very demanding because awareness for patient for diabetes and caregivers both is very poor and no social support is there. Now this is very important because many of physicians and primary care physicians, they feel that when patient come with a 9.5 HbA1c, when HbA1c is higher, they just try to increase the dose of insulin. So intensive diabetes treatment in a type 1 diabetes is just not just more insulin. So just by increasing the insulin, you are not going to improve the care for diabetic patient. Because the HbA1c is more and you increase the insulin here and there, it is not going to, it will require more of an education why the patient HbA1c is not good control. It's a management, is a 24/7 an issue. And this, for that we have written a paper along with Ashok Kumar Das and many more from India, the awareness, management and challenges and current scenario in India. We don't have trained healthcare professionals, and this really very, very true that poorly managed type 1 diabetes. And the worst part is the pre-mixed insulin is still written by the experts. The problem is those who are primary care physicians, they don't know. Even if they write the pre-mixed insulin, I never blame, but someone who has been trained for 5 years after MBBS, who has been trained in diabetes endocrine, and even they write the premix, they have to understand their responsibility. If you are writing for your one patient, you have to think that hundreds of people are following you. They feel that if you are writing, it means many or more you can treat these type 1 diabetes, and that's a big challenge for us because to teach them it's really very difficult. And I think we have to go to the department to teach them. That is the only way. Not ready to accept the newer technology. They always feel that we are poor and we can't take. While in India, we have highest iPhone. Now iPhone 15 is going to be there in India, and we will be the world #1 iPhone user, more than USA population. But still we feel that our patient can't afford the technology because they are poor. This is the data which I want to tell you from the German in 2016. More than 50% of the children are on pump. And today if I show the data of 2023, 95% of the patients are on the pump. They don't use the premix insulin. Premix insulin was the past, before 2000 only. Premix insulin not to be used for type 1, I will say it's a crime if someone is using for that. The demographic data of more you give the shots to the type 1, more the 6 shots, 7 shots, 8 shots, you will find better control. If somebody uses multiple daily insulin injection, only 4 shots is also not sufficient. They have to take more correction. They have to take with each and every meal of the day, and it may be 4 times, 5 times, 6 times in a day, and you will find the better control of diabetes. With the more the shots, better the control for these patients. Now a time had come, we are moving from self-monitoring of blood glucose, which is 7 points, to the continuous glucose monitoring, because that gives you the better graphical picture that how the sugar is moving in your day or 24 hours in a life, and you can better control for these patients too. Then someone asked that why you need the pump. If you have a continuous glucose monitoring, why can't you take all the multiple shots of the injection 4 times, 5 times, 6 times? There is an advantage of continuous subcutaneous insulin infusion pump because a type 1 will not need the basal insulin the way we are giving the 1 shot in a day. I mean, 1 shot of a basal is not sufficient because sometimes they require low dose, sometimes they require high dose of the basal. So in the afternoon they may low dose, they may be in middle of the night, their basal requirement may be low. And for that, you need insulin infusion pump. And now that insulin infusion pump has to be now advanced or a sensor augmented pump. Now these are some of the challenges which I have talked. Now, what the solution? Now each component of a challenge itself is a solution. Like you talk about the challenge and you find the solution. That's the only way with what are the challenges and what are the solution. The awareness about the early diagnosis. The problem is illiteracy, social myth, lack of dialogue, and GPs unaware. These are the problems which we know. The local problem, I mean, you can have a solution locally and you can have solution nationally. When it comes to the nationally, definitely organizations are responsible. Whether we are from RSSDA, Diabetes India, the IDF, we are responsible for the national solution along with the government. But there are some local solutions we can all do by increasing the advocacy program, involving the non-government organization, involving the type 1 leaders, involving the celebrities, and increasing the GP awareness in a basic manner. The problem is the access to quality care, not enough number, not updated to the current guidelines, and for that what RSSDA we started a tie-up program, we started a type 1 diabetes network, we started a lot of type 1 educational program across the country, doing a lot of continuous medical education program involving Indian Association of Physicians too. There is a stable and affordable insulin monitoring. Again, insulin is a challenge, but now India is providing all government, I mean all health, all state health department started providing insulin below the age of 18 years across the country. So the insulin is free, but the education is not free. And something more we can do by involving the RSSDA or national organization to increase the awareness and education at the state level also. The other is the educators are low. We have already from IDF has started a type 1 dedicated educator program. So we can have now dedicated educator who can be nutritionist, who can be educator, who can be psychologist, who can be social worker. Any one of them can be a educator, and they can be there for the local level as well as for the national level too. In RSSDI, we created a type 1 diabetes network, a mission to build a positive ecosystem for type 1 diabetes care plan India across the country. And we are trying for a continuously educating our healthcare providers. We are trying for providing them free insulin and glucose meter to needy patients. We have collaborated with CDIC, LFSC, RSSDI type 1 diabetes project, with Sanofi and many more across the country, and providing more than 10,000 children free of charge insulin, establishing type 1 diabetes network, young leaders from India, from Southeast Asia, from IDF, tie-up program which we have done with the UK physician, educating our Indian doctors for type 1 diabetes. We have created a modules for educating to caregivers and for the persons with diabetes. We have more than 100 foundations which are working in India, and now they all are under one umbrella. We have almost connected with all associations and all foundations just to support and educate these type 1 children. We are part of SPAD guidelines, not from now, almost since last 7-8 years. We could get the SPAD India, and now if you see the International Society of Pediatric and Adolescent Diabetes, their guideline with more than 10 Indian consultants are the part of these guidelines. I am part of this guideline since last 2014, so it means they also believe and they work with us very closely to put our word in their guideline too. Despite multiple advancements, there are many barriers for healthy life with type 1 diabetes, the lack of awareness, poverty, distance to clinics, poor understanding of pediatric diabetes, weak healthcare system, and a lack of awareness and cultural misunderstanding too. Type 1 diabetes management, I always say it's more than insulin. It's not just insulin. Insulin providing is not simple solution. It has to be much more than insulin. How does India compare? If I just say that same type 1 index paper which I had talked to you, we are actually comparable almost like a Sudan, which is East Europe, I mean East Africa. It means the child who is developing type 1 diabetes in the east part of Africa, he survives only for another 15 years or less than that. In India, it is not more than 18 or 19 years. And then after he develops the all complication, while if you see the Western world, it is almost like up to 67 or 69 years, they can have a normal, healthy life. And why it is so? One of the reasons is probably they are late diagnosed, but that's very minimal because now almost all type 1 diabetes are diagnosed. There is a still uses of pre-mixed insulin, and that's one of the biggest challenge, and the few tests they don't monitor. If we provide all children the insulin properly, the basal bolus, strips, and a self-management education, we can also have a normal life. That does not mean that we have to give each and every child a continuous glucose monitoring and insulin pump. We just need an insulin strips and a self-management. Definitely the pump and continuous glucose monitoring will give them a normal life as the Western world. A continuous glucose monitoring alone is not enough. That is what NHS has decided, that they will give all their type 1 diabetic patients a continuous glucose monitoring, but that's not enough because still 70% of the type 1 children in NHS is not having good control of the diabetes, because a continuous glucose monitoring will give you the idea that every 4th day you may have different sugar, and that cannot be corrected by just giving them a multiple daily injection. I'm just finishing in 1 minute that importance of continuous subcutaneous insulin infusion pump. You can see with the CCT trial, in 83 we had done it, 60% of them were developing severe hypoglycemia. In 2016, in a pivotal trial with a sensor augmented pump, the same patients who could be controlled with a less than 7 HbA1c, and the risk of hypoglycemia is 0. So I mean, you can see that a patient who can be put on a sensor augmented pump with an advanced hybrid closed loop system, they can be almost 0 hypoglycemia, and still you can achieve a tight glycemic control. It is beyond the limit of this particular talk. So I will not be talking about the pump therapy, but that's what we have written so many papers on the pump also. But our goal is for a type 1, a physically and psychosocially a healthy citizen of India with type 1 diabetes. That is what we want. We know that we can't change some things, that patient has to take multiple insulin injection and they have to measure the glucose, but our role began as a healthcare professionals, and it continues as a friend who supports children to have a healthy lifestyle. With this, I thank, once again, thank you Makkar Sahab and Rajiv and Shalini for giving me this opportunity. I am working with so many different projects, so that's what I thank you. Thank you very much.
Thank you, Dr. Bansi, for a wonderful, passionate talk. Can we have one more chair here? And can we have quick questions if there are any, because we don't have much time before we close this session. Anyone has any questions? Please, quick questions only.
Sir, can I have one?
Yes.
This one question from Professor Das.
You have to be loud.
Yes. How a frailty can be one of the multi-morbidity factors in treatment with type 2 diabetes?
I think this is a very, very important question. Now, yesterday we discussed in a meeting about sarcopenia. And I must tell you, the sarcopenia differentially occurs in the diabetics for 4 reasons. Number 1, because uncontrolled diabetes produces weight loss, sarcopenia. The drugs that we use today, like SGLT2 inhibitors and GLP-1 analogs, both oral, injectable, don't have it yet. They produce sarcopenia. Third, diabetes get very extreme weight loss when they get into complication. And third, there is a term called diabetic cachexia. They get sarcopenia. So when they get sarcopenia, that is a great thing when they have loss of muscle mass. You asked me a question, how it affects? So it affects inpatient care, because from the purpose of appearance to their physical activity, there is a negativity. And it has been also observed, people who are on insulin get less sarcopenia than the people who are on oral anti-diabetic drugs. And it accepts the quality of life and also leads to multiple falls. In fact, diabetes today has become a very important cause of multiple falls.
Thank you. Thank you.
I have a question to Madam. One question to Madam. Yes. Dr. Inas, I was just flabbergasted by your talk on the diabetes in the young, and of course, you described the wider perspective. Now, my simple question is that even though there is uncontrolled diabetes in the young, since they're already obese, we keep on managing them with orals, because I sit on a registry called DIY, diabetes in the young. And we have number 1 is Bansi Sabu's children, and number 2 is type 2 diabetes in the young. The second number of diabetes onset below 25 years of age. So there, when they do not respond to orals, we do not give insulin, because that will increase further weight. What's your opinion and what do you do?
For management?
For management. If they don't get control.
For management, according to the blood glucose level, if it's not high and hemoglobin A1c is less than 8, we start with metformin. We can now add empagliflozin, because it was approved recently in June by the FDA to be used in type 2 in the children and young adolescents, starts from 10 years old. If not adequately controlled, we add basal insulin. Then if the child is having high blood glucose levels, we should treat as if type 1.
Good. think SGLT2 has been approved in your country to be used for below 10 years of age.
Empagliflozin FDA approved.
Thank you. And with this, we come to the end of another good session. Let us have a big round of applause for all the speakers who have done such a wonderful job. And over to Dr. Shalini for, next session.
Thank you, sir. May I request Dr. Makkar to present mementos to our speakers and chairpersons, please?
सर का बेटा एक और नहीं लिया फटाफट
So thank you everyone. Now moving to the last session of the day, I would like to invite Dr. C.P. Ahuja sir to chair the session. Dr. C.P. Ahuja sir is Senior Consultant Emeritus, Department of Medicine, Maharaja Agrasen Hospital, Punjabi Bagh, New Delhi. Welcome, sir.
Well, thank you, organizers, for giving me the opportunity to chair this session. We had 3 lectures. One has already been delivered by Dr. Bansi Sagu. So we have 2 more lectures. The next one, which is coming up, is the measurement of C-peptide levels in the care of patients with diabetes. And this is being delivered by none other than Professor Colin Dayan, whom we heard during the oration ceremony. This topic is not very much discussed in diabetic conferences. Very rarely that we talk about C-peptide levels. So we have this opportunity again to listen to Professor Colin, and I invite him to deliver the talk on C-peptides in the care of patients with diabetes. Professor Colin, please.
Thank you. Thank you very much for this opportunity. Do we have the first slide? Okay. We'll try and catch up a little bit of time. This was touched on a little bit actually by my earlier talk and also by Dr. Mohan. So some disclosure. So a little reminder of the physiology of what is C-peptide. So I remind you that insulin is produced as proinsulin, and then it's cut in 2 places, as illustrated here, releasing the C-peptide and then the 2 chains which come together to produce insulin. So it's secreted 1-to-1. There's 1 molecule of C-peptide with every molecule of insulin. Unlike insulin, it's not processed by the liver, and it has a longer half-life, about 25 minutes versus 4 minutes for insulin. It's renally excreted, so it rises a little bit in people with renal impairment, and it's not, of course, present in synthetic insulin, so you can measure endogenous insulin production in people on insulin injections by measuring C-peptide. By contrast, the insulin assays cross-react with almost all of the injected insulin. So just to give you a feel for it, and I think actually Dr. Mohan shows us a few numbers here, but here's the kind of numbers you might expect to see. A fasting level would be 300 to 600 picomoles per liter, or some people use nanomoles per liter.
postprandially between about 1,000 and 3,000. Some people use nanograms per mil, and that's about 3 times the nanomoles per liter numbers that I've just shown you. It's fairly straight conversion. But the assays now can measure as little as 2 picomoles per liter. Note that we don't have standard assays for C-peptide, and between different manufacturers, the numbers can actually differ by quite a lot, by, for example, 200 picomoles per liter. So this little cartoon, I don't know if I can point to it. It's my pointer here. Just remind you of the biphasic secretion of insulin. So you have the pre-filled granules, which are released rapidly, and then you have new synthesis of insulin. And that results in 2 phases of insulin secretion. We mentioned, of course, the insulin, which is then cleared in the liver, and the C-peptide going through to the kidneys. And this results in, as you can see here, here's a healthy beta cell showing you the biphasic insulin secretion. And this is important because, of course, you have to decide when are you going to measure C-peptide. Are you going to measure it here? Are you going to measure it here, there, or late? What will it mean? Or are you going to integrate it over the whole period? I'm showing you above here is the glucose levels. These are C-peptides below. So a healthy beta cell means that there's little postprandial initial rise or late postprandial rise. As you progress through disease, this is the stages of type 1 diabetes. The first phase insulin is one of the first things that's released. So you get late release of insulin. So although the area under the curve, the amount released in the whole period might be the same, in fact it's delayed and it's a later time point. So there are different ways of testing for C-peptide, and I'm showing you a collection here. That's the stimulatory test, glucagon stimulation test, which is quick and takes 6 minutes, or mixed meal tolerance test. So that's not just glucose, that's amino acids as well. You can use an oral glucose tolerance. That's not usually used, except in prediabetes, and older tests such as tolbutamide, and of course you can measure the fasting C-peptide. Then the random C-peptide, and this is actually being preferred in the diagnostic categories that I'm going to be talking about, but of course it's not as accurate. You can measure it in the urine, so you can measure a urine C-peptide creatinine ratio, or just the urine C-peptide on its own, or you can collect it over 24 hours. I'm not going to say very much more about the UC-PCR. It can be a practical thing. People can send it through the post, and usually we use the spot urine UC-PCR. Okay, so why would we measure C-peptide? Here's some of the examples, and I'm going to focus particularly today on type 1 diabetes, on the diagnostic between type 1 and type 2 diabetes, and maybe type 1 diabetes and MODY. Of course, we do use it in people who develop hypoglycemia to understand whether it's endogenous or exogenous insulin that's been the origin of hypoglycemia. And Dr. Mohan touched on possibly being used to determine which therapies will be most helpful. I'm not going to talk much more about that today, or its use in beta cell replacement. Of course, this is going to become more apparent as we have more stem cell replacements and measuring the amount of C-peptide that's being released. So I'm going to focus on the diagnostic applications for the rest of the talk. And we produced some guidelines last year on the diagnosis of type 1 diabetes. And this is important because a mistake is very frequently made, as I'm about to show you. So here is our suggested approach for diagnosing type 1. If you take a patient that you think has type 1, what would make you think that a patient has type 1? These are the useful criteria: younger age, maybe under 30, somebody who rapidly progresses to insulin, so they run out of using tablets, the HbA1c remains high, and within 2 to 3 years has gone on to insulin. You might wonder, was that really type 2 or was it actually type 1? Lower BMI, perhaps there should be 23 in India. Ketoacidosis, of course. Rapid weight loss is very important. And presentations with very high HbA1c. So if you have at least 2 of these criteria, you should strongly suspect that this is actually type 1. And then, if available, test autoantibodies, ideally all 3, but certainly anti-GAD. If that's positive in the context of somebody who clinically has type 1, you should call this type 1. They should be on insulin for the rest of their life, and you can continue to manage them in that way. I'm going to emphasize that you should not test autoantibodies in all patients, because of course there's a very large number of people with type 2. And the problem with measuring autoantibodies in people with type 2 is there's such a large number that some will be borderline positive or slightly positive. And that causes a lot of confusion about calling them LADA or not LADA. It's not very helpful. So only test autoantibodies in people with a high suspicion that they have type 1 diabetes. Now you will miss some individuals, and there'll be some that are negative. About 10% are negative anyway, because remember that type 1 diabetes is a T-cell mediated, not an antibody mediated disease. So you can have true type 1 diabetes and be negative on antibodies. So there will be some who are negative, but those individuals, if you think they clinically have type 1, continue to manage them as type 1. Or you may want to consider assessment for MODY. Now, after 3 years from diagnosis, this is a time when you should measure C-peptide. Notice that I didn't suggest you measure C-peptide at diagnosis, because often the levels overlap with type 2 at that point in time. They are not diagnostic at the time of diagnosis. But when you come to 3 years after diagnosis, people in type 1 are losing their C-peptide very rapidly, and at this point it is low. So it's actually very useful 3 or more years after diagnosis. So we can look at it this way. Either you've waited 3 years and you assume that they have, even though they were antibody negative, you're going to retest them 3 years later, or you have people in your clinic who have long-standing diabetes and they never were diagnosed properly. They've been on insulin their whole lives, and people have assumed they have type 1. It's good to recheck, especially if they were never never tested, or they've been antibody negative. So at this point, C-peptide becomes helpful. And less than 200 picomoles per liter, generally people consider that as a very low level. It may just be detectable, but under this, and then treat as type 1, and they have a high ketoacidosis risk. More than 600, and I'm talking about a random non-fasting level here. You don't have to measure a fasting level or do a mixed meal tolerance test, and a random non-fasting level is helpful in just putting these people into categories. So more than 600, it's likely they have type 2 or certainly not type 1, and they have a low risk for ketoacidosis, so they can undergo a supervised insulin withdrawal. There is a gray area here, 200 to 600 picomoles per liter, and they certainly should undergo a MODY assessment, and you can use the MODY online calculator to do that. And you may want to monitor this group to see which way they go. Do they gradually over the years decline further, and you should keep them on insulin? Are they stable, in which case you might consider adding additional drugs to them that would be helpful in type 2 diabetes. So I'll show you a little bit about some audits that have been conducted, and the first one that was published was from Edinburgh here, from Mark Strachan's group. They looked at 859 patients who had been treated their whole lives as type 1 and had been on insulin for more than 3 years. They did a random non-fasting C-peptide test, and 114 of them, it was more than 200, and 58 individuals were reclassified with higher levels of C-peptide than this. 44 eventually were diagnosed as type 2 diabetes, and at least 13 at the time of writing had stopped insulin, and 16 had improved their control by adding additional agents, SGLT2, GLP-1s, that are usually used for type 2 diabetes. So it's around 6 to 8% benefit from having this screen done. You don't have to do it every year, but there are definitely going to be some people who are misclassified. And we were inspired to do this again. My colleague, Dr. Ashia Tabassum, and our laboratory scientist, Dr. Carol Evans, helped us with this. This is in Cardiff, and we looked at 275 individuals again who'd been classed as type 1 all their lives. 80% of them did indeed have a low level of C-peptide. This is more than 3 years after diagnosis. But 19%, similar to the Edinburgh experience, it was more than 200, and in 13% it was more than 600. So we were able to reclassify these individuals, and many of them are now coming off insulin. If I just show you on the next slide here. So we had 16 patients that we took off insulin altogether. And look at the range of age of different diagnoses. So some of them were diagnosed very late on and had gone straight onto insulin. And almost universally, they have an improvement in their HbA1c because it's easier to manage them on type 2 medications than it is on insulin. And here's some of the BMIs as an illustration. I'm going to come back to their quality of life improvement in a moment. And then there were the individuals where we've been able to down-titrate their insulin and introduce other drugs. And again, much improvement in their HbA1c, between 0.5 and sometimes 2 to 3% improvement in their HbA1c. So some of the people who actually been on insulin all their lives, showing you some illustrations here. people with learning difficulties, with epilepsy, heavy goods vehicle drivers, taxi drivers, teachers, driving instructors, window cleaners who have to go up high, people dependent on others for insulin injections. And it makes a huge difference to them to be able to say to them, you know, you don't have to be on insulin. We can manage you with a non-insulin-based therapy. So some of the benefits then of reclassification, you're able to do insulin cessation. There's a CV benefit. Of course, it reduces their risk of hypoglycemia. It affects their livelihood restrictions, such as driving, improved quality of life with less monitoring, and many of them, in fact, most of them achieve better glycemic control and sometimes better employment opportunities. And in fact, moving people from insulin to non-insulin-based treatment saves money. It's actually cost-effective. This is during assumption of people using insulin or insulin pumps or sensors, for example, versus even the most expensive medication you might want to use for type 2 diabetes. So it's a cost-effective intervention. It saves on hospital admissions, reducing waiting lists, better glycemic control. So the conclusion from that audit was that the service can provide a more precise diagnosis of diabetes if you use C-peptide in this context 3 or more years after diagnosis to recheck people with type 1. It's a patient-centered approach. It often allows effective and safe withdrawal of insulin. Dr. Tabassum runs an insulin withdrawal clinic. She says it's the most joyful clinic that she ever does. It's more fun than doing type 2 is the insulin withdrawal clinic. A better quality of service, and of course it's better use of service specialists. So in summary, C-peptide should not be measured in all patients with diabetes. It's often uninformative at diagnosis, but it is a useful screen in patients classed as type 1 diabetes and treated with insulin for more than 3 years, when around 7 to 10% may be reclassified with significant patient benefit. And I'll stop there. Thank you.
Thank you, Professor Colin, for highlighting the value of C-peptides and the diagnosis of diabetes. In the survey which was done, you mentioned out of 800 something patients, 100 turned out to be type 2 diabetics when their C-peptides were measured. So do we have any clinical assessment of patients with type 1 diabetes that they may not be type 1, they are really type 2? Or is just a random survey?
Yeah, so these were actually all the people in our clinic. So obviously you don't, the number with type 1 is smaller than the number with type 2. So we've worked our way through all the patients with type 1, and it seems it's about 10% wrong. Now it may be that going forward, if people do more antibodies at diagnosis, the number of people misclassified will get smaller over time. But these are people who've been diagnosed a long time, some of them 10, 20 years going back to them. So that's our estimate at the moment. It was very similar to the estimate in Edinburgh. It might be different in different places.
Thank you. Yeah, any question, please? Yeah, Professor Das.
Yes, so thank you very much. So 2 questions here. One is, what happened to that insulin? Did it regrow? Did it reappear? And the second was about the algorithm really is saying, how do you make the diagnosis? So I'll answer the second question first, and I'm sure you say the same thing to your students as I say to my students. There is no test that can tell you whether you have either type 1 or type 2. No definite test. is going to prove it. Not antibodies, because they could be negative, not a C-peptide at that point in time, not a genetic test, not a family test, not a clinical test. There is no way of being certain. It's the passage of time that actually tells you, and that's why the C-peptide 3 years later is probably a better test. But you have to do something at diagnosis. You can't just decide, you've got to treat the high glucose. To answer your second question, oh, maybe the first question, I don't think the glucose reappears, the insulin reappears. I think it was going all along. And the reason I say this is that we've had quite a few studies now with tight glycemic control from diagnosis with closed-loop pumps, and the C-peptide still disappears. It doesn't hold on to the insulin, and it doesn't seem to suppress the insulin. It doesn't seem that the glycemic management seems to make no difference to the autoimmune process. It continues as it happens. So I think it was that the autoimmune process was happening, people put the insulin on the top, and conversely, that the people with type 2 diabetes, I don't know that there's much evidence that treating them with insulin, if you like, preserves the insulin for longer. But we haven't really studied that more directly. So I think it was happening, it was a diagnostic error rather than a therapeutic effect.
Thank you. I think another indication for testing C-peptides may be from the talk of Dr. Professor V. Mohan in the morning, that clustering of different groups of diabetic patients. So the measurement of C-peptides may be of value in clustering different types of type 2 diabetes.
Yeah, we're hearing quite a lot of that now, aren't we? With them, I remember when GLP-1 agonists were first introduced, saying to the people, look, this is never going to work because type 2 diabetes is beta cell failure, so why would this drug actually work? You're trying to get more insulin out of people who can't make insulin. Of course, I was completely wrong, and some people can. So I think it is certainly worth exploring, maybe not just do they have much beta cell left, but what is their responsiveness? The trick is always going to be, well, try it and see. Maybe you can't always predict, but I think it will begin to come back now that C-peptide assays are more commonly available. I think people are going to be exploring this. The answer is, are we going to be able to do that on fasting? Is it going to be random? Will we have to do a stimulated test? There's lots to discover. Thank you.
Thank you. Thank you so much for your wonderful lecture. Thank you so much. So the last talk of the day is being delivered by none other than Dr. Shalini Jaggi, who is the co-organizer of this conference. Very young, dynamic diabetologist, needs no introduction. She is going to talk to us on a very practical aspect in the management of diabetes, that is continuous glucose monitoring, time in range in the management of diabetic patients. So, Dr. Shalini, please.
Thank you so much, sir. So I'm the last batsman in this test series, third day. I'm going to talk on time in range, the new metric in glucose management. I think we've all moved beyond the typical traditional glycemic triad where the focus was on just controlling the glucose numbers, which means the fasting, postprandial and the HbA1c. And now we know that there's something called glycemic variability, which is very, very important when it comes to glycemic control of a patient and the overall complication risk, and something that can contribute to quality of life of the patient. So more the glycemic variability versus the quality of life. So there's a quintessential need for a paradigm shift in how we incorporate glycemic variability and quality of life in the holistic diabetes management of our patients, and this is what I'm going to talk about, moving beyond HbA1c when it comes to glycemic parameters, glycemic control for your patient. So we all tell the patient, get an HbA1c down to 7, 7 is good, 7 is good, 7 is good. But is 7 really good? Does it show you the entire picture? On your screen you can see 4 different profiles of 4 different patients having an HbA1c very close to 7, 7.2, which we normally say is fine. You know, you just need a little more fine tuning, 0.2 less and you are on the golden number of 7. But look at the glucose profiles of these patients. Are they well controlled? Is this what you want with an HbA1c of 7 or 7.2 for your patients? Let me show you what a 7 can look like. This is somebody with an estimated A1c of 7. So is this what we want for our patients? We are very happy when a patient comes to you with an HbA1c of 7 and we pat his back and say, very good, you're doing very well. But once you do an AGP, sometimes your eyes can open and you can see this kind of a profile with all the glucose numbers going up and down all over. So we are definitely missing something when we look only at a glycated HbA1c as a standard of care and decide that all is well, because yes, HbA1c does give you a measure of glycemic control for the last 3 months, but it does not give you the true picture. It does not reflect the acute short-term glycemic excursions, both the hypoglycemia or the hyperglycemia that may be happening. It does not give you any information on glycemic variability. And further on, the interday and the intraday fluctuations you can never find out from an HbA1c. Plus, in many conditions, patient has anemias, patient has hemoglobinopathies, iron deficiency, pregnancy, HbA1c may not be right, it may be a false low or a false high HbA1c. Well, you may motivate your patient and say, do a glucose monitoring all the time. Your patient may be very well motivated. He may be doing 3 glucose readings in one day. Still, SMBG is one tool that definitely has its pros, but yes, there may be some drawbacks here as well. Number one, it needs a pinprick for your patient to actually measure his glucose levels. So a very high level of motivation is needed for this patient to actually do a regular SMBG. And then it provides just a single point in time measurement. My glucose level right now may be 100, but does that mean I will never get a 200? So if I wake up early morning and do a fasting which is 90, does that assure me that throughout the day my glucose levels are going to be good? No, I may have a 300 postprandial as well. So the gaps between the SMBG are still not filled. And again, like I said, hypoglycemia or hyperglycemia may completely be missed if you've not really bothered to check your glucose level at that time. Therefore, SMBG is actually needing a lot of motivation, correctness, and is dependent on the patient's decision to self-monitor. Look at this. This is a highly motivated patient who's done 4 glucose readings in a day. Can you judge what his glycemic control would be? Look at his continuous glucose monitoring profile. It completely gives you a different picture. So his glucose levels are all over the place, but those 4 times that the patient checked, they were not as bad. So this is the drawback of SMBG, even if your patient seems to be pretty motivated. So with that, let me elaborate on a parameter called glycemic variability that I have been talking of. In simple terms, it is fluctuations in glucose or other related parameters of glucose hemostasis over a given period of time. What are the consequences? If your patient goes into a hypoglycemia, we know cognitive dysfunction is a big issue here. Patient can have all the micro and macrovascular complications if there's hyperglycemia, neuropathy, retinopathy, nephropathy, cardiovascular events, and all these peaks and valleys can impact his quality of life. With this, let's move on to a metric called time in range that we all keep talking about. In simple terms, what is time in range? Time in range is a standard measurement that tracks the amount of time that the patient's glucose levels are in the defined target range, which is usually taken as 70 to 180, standard for most individuals with both type 1 as well as type 2 diabetes. Time in range basically has 3 metrics. The green, that is the time within range, which is where you want your patient to be in. And of course, the yellow and the red that you see is time above range, that means he's above the targets. And below range, that means he's getting hypoglycemias. So what actually we want for our patient is definitely as high time in range as possible, because you want your patient to be in good range most of the time in the day. And of course, you do not want him to go above range or below range, that means have hypoglycemias. So as you can see on this profile, what you see in the middle, in a AGP profile between 70 to 180, whatever glucose readings the patient has, that is the time in range. And the moment it goes beyond 180, that becomes above range, and the moment it dips less than 70, it becomes time below range. So this is the international consensus on time in range, which was published in June 2019, endorsed by most of the diabetes organizations globally, as you can see here on your screens. Dr. Banshi Saab, who also happens to be one of the key authors in this document, they standardized the CGM metrics for clinical care. This is the famous ATTD consensus, which talks about 10 metrics, most important being time in range, time above range, time below range, and glycemic variability. which measures the peaks and the valleys that I talked about. So of course you have time in range, which means glucose levels between 70 to 180, and then above range you have level 1 and level 2, that means between 180 to 250 and then more than 250. Similarly, for hypoglycemia or time below range, you have glucose levels between 54 to 69 as level 1 hypoglycemia or level 1 time below range, and a severe hypoglycemia, that means less than 54, shown by level 2. So this is the bars that I was talking about. For most patients with type 1 and type 2 diabetes, the parameter is more than 70% of the time your patient should be in range. Hyperglycemia, if at all, should be less than 25%, out of which severe hyperglycemia should be less than 5%. And like I said, hypoglycemia has to be minimized. So that has to be less than 4%, and if you talk of severe hypoglycemia, it should be as close to 0, so just less than 1%. Of course, for elderly people and people with comorbidities, you can relax the time in range to about more than 50% should be the time in range, less than 50% should be above range, and severe hypoglycemia or hypoglycemia has to be avoided. Forget a severe hypoglycemia, that should be 0. Even a hypoglycemia in elderly people should be avoided, so that has to be less than 1%. Pregnancy is a completely different ball game. We know that the glucose targets are much tighter when it comes to pregnancy, and therefore in type 1 diabetes, like I said, time in range, the parameters are between 63 to 140. So for pregnancy in type 1 diabetes, time in range should be more than 70%, hyperglycemia, that means more than 140, should be less than 25%, and hypoglycemia again, which means less than 63, should be less than 4%. And for GDM as well as type 2 diabetes, time in range has to be much better. So 63 to 140 should be more than 80% of the times, and then you should have very less hyperglycemia or hypoglycemia. So why are we talking of the magic number of 70% and above as a good time in range? Well, this is backed by a number of studies, as you can see, in type 1 and type 2 diabetes, where clearly a time in range of 70% corresponds almost to an HbA1c of 7% under standard measures, and as the time in range starts going up, you can clearly see the HbA1c gets better and better, and as the time in range declines, you can see the HbA1c starts climbing up. A suboptimal time in range can have a lot of impact on the lives of your people with diabetes. Every 10% drop in time in range means a worsening in glycemic control. And what does this translate into? 64% increased risk of retinopathy in patients with type 1 diabetes, 25% increased risk in peripheral neuropathy in your people with type 2 diabetes and CKD, more than 40% increased risk of microalbuminuria in people with type 1, and CV mortality. So 5% increased risk of CV mortality and 8% increased risk of all-cause mortality if the patient's time in range starts deteriorating less than 70%. Furthermore, like I said, time in range can be a surrogate marker for all-cause cardiovascular disease-related mortality. You can see here all-cause mortality as well as cardiovascular mortality, all increasing as the time in range starts coming down. So the moment glycemic control worsens, you can see an increase in both cardiovascular as well as all-cause mortality. And once you improve the time in range, what are the benefits? 10% improvement in time in range leads to a 0.8% reduction in HbA1c. Not only does it signify to a better glycemic control, but a 40% reduction in nocturnal hypoglycemia, 40% reduction in daytime hypoglycemia, and of course translating into an improved quality of life. Who is the right patient who should be assessing his time in range? Of course, anybody with diabetes, be it type 1 or type 2, where you need to make therapeutic decisions, somebody who is not controlled on OADs, somebody who's got gestational diabetes or pregnancy and diabetes, somebody who's getting hypoglycemia, so where you need to fine tune the dosages, where you actually need to see what is going wrong, where suppose the SMBG is not matching with the HbA1c, you can again do a time in range and find out what exactly is his glycemic profile, and like I said, pre and post hospitalization as well. So like I said, what does variability look like on an AGP? You can clearly see here all the glucose charts going up and down. So your patient can manifest with any different profile. Every patient's profile is completely different. So what do you want to do? You've done an AGP for your patient. You see this kind of a graph. Now what am I supposed to do? The therapy change or the lifestyle change or the MNT change, everything should focus on flattening this and fitting it in that right time in range graph that I have shown you. Now what you see here is a wide split So you see the interquartile, interdeciles are all splayed. You see the patient has a lot of variability. What should you do? You can see he's all over the place. First, your therapeutic change has to reduce the variability. So this wide curve has to be narrowed first. So you have to tell your patient to eat on time, implement lifestyle changes, and maybe do changes to his drug therapy, whatever, to make it narrow. Once you have made it narrow and reduced the variability, the curve starts getting a little better. Next step, what do you want to do? You need to make it stable. So instead of a curve which is going up and down, you need to flatten the curve. So your next change has to be to make it stable and make it flatter rather than it going all the way up and down. So what do? You do another therapeutic change and make the curve flatter. But still, it is still not fitting in range. So what is your final destination? What do you want to do? Once you have made it narrower and flatter, automatically what you will see is the curve starts shifting down and he falls well within range. So whenever you do a profiling of your patient, look at what exactly you need to do, make it narrow, flatten it out, and intensify his MNT and lifestyle and therapeutic change to bring the curve in range, and then you will have a successful use of this tool. Let me finish with this clinical case. This is a Mr. AG, a 47-year-old businessman with a BMI of 29.5 who presented with neuropathy symptoms of burning feet and pins and needles. His SMBG chart seemed pretty acceptable to me. As you can see here, his fastings were generally in the range of 100 to 120. His postprandials were 140 to 180 and his HbA1c seemed to be 7.1%. He had been diabetic for 7 years and had hypertension for 4 years. And of course, his meal timings were pretty irregular due to the nature of his work. And sometimes, you know, he did carry lunch from home, but then he was not very sure if he's going to have food on time or not. Ongoing treatment was glimepiride 2 milligrams twice a day and metformin 1000 milligrams twice a day. So if you look at the glucose numbers, things don't really seem to be as bad, but he's got burning feet, he's got pins and needles, he's got neuropathy. So this is where we wanted to do an AGP for him, and this is what his curve looked like. So maybe on certain days when he was doing his glucose monitoring, things seemed to be okay, but otherwise the graph was pretty splayed. So of course, we did some changes. We asked him to intensify on his diet and lifestyle, to start eating on time, and we made some therapeutic changes, reduced the sulfonylurea, added an SGLT along with a gliptin, and when we repeated his graph, this is what it looked like. So a therapeutic change from there to here. So we've not only narrowed it, we've flattened it, and we've brought it down in range. So this is an optimal use of the tool of time in range in a patient with type 2 diabetes. This is how his curves changed with the help of this tool. So it brings you a lot of information which you can miss out with the numbers. This is another case study, a GDM woman. Again, both of these are original cases. This is Mrs. Sonam Grover, 31-year-old homemaker, pregnant with her first child. Came to me at 28 weeks of gestation. She had undergone a routine GTT. Fasting was 90, 2-hour post-meal was 165. Of course, her OBG asked her to stop sweets and sugars and start walking and referred her to us. HbA1c, of course, was 5.2, which does happen in most of the true GDM cases. As you can see here, BMI is 23, BP is 106/70. When we went into a detailed history, she already had 2 miscarriages in the past 1.5 years, both in the first trimester, early pregnancy. Cause was not known, and she was very clear she had not had any diagnosed diabetes in the past. Pre-conception, her fasting and postprandials were pretty acceptable, and HbA1c you can see was 5. So what did we do? We counseled her on MNT physical exercise, asked her to do an SMBG and come back in 3 days, and as you can see the numbers here, her fasting, 2-hour post breakfast, lunch and dinner all seemed to be pretty alright, except for that 124 that you see in the post lunch, so slight variability was happening. Ultrasound at 28 weeks was normal with adequate Liker. This was a precious pregnancy and she was really very tight, and she wanted a tight glycemic control. So as an adjunct to SMBG, we did install a CGM Libre, the real-time sensor, to trace if there was any glycemic variability which could cause harm for this patient. So how did it help? When we put the graph, for the first week, clearly we were able to see a lot of glycemic variability. We could see morning and post-lunch spikes as were happening, as well as a few nocturnal dips. I will show that to you. So this is where we asked her to go on to a split meal strategy along with 5 small frequent meals to reduce the glycemic load of her meals. She was also encouraged to, maybe walk comfortably post meals to actually reduce the post meal spiking. And then we reviewed her again at the end of her second week. And after implementing those changes, we were able to actually see a good improvement in her time in range and a reduction in the time above range and time below range. So the glycemic variability was taken care of and all glucose levels started falling in range. So this is the real pictures that we took of her graphs. You can clearly see here the parameters. In the first week, you can see that time in target was only 80% for her. In the second week, after implementing those changes, you can see it improved to 92%. She was getting into hypoglycemias in the night. Below target was 20% in the first week. Once we were able to see that, we made all those changes and the time in range actually reduced to 8% and above range was also 0%. So you can clearly see an improvement. Again, like I said, the hypoglycemia metrics actually improved because earlier she was having a dinner at 8 and not eating anything till 12 in the morning. So obviously, in pregnancy she was going into hypoglycemias, especially the nocturnal hypoglycemias, and since they were asymptomatic, she was not aware of them. Once we were able to look at the graphs, we actually made all those changes and her hypoglycemic metrics also improved drastically. You can see from 26 total events came down to 7. And mark it, this was inclusive of the first week. Average glucose improved for her, and as you can see the change in her daily graphs. This is the pictures that she would take every day and send it to us. So you can see this is where we started, and as the days passed and she was able to implement, you can see the graph becoming flatter and flatter. So overall, it led to an improvement in the CGM metrics. As you can see, she was encouraged to continue on MNT and lifestyle measures and of course do frequent SMBG, and we are routinely following her up. So friends, what are the indications for continuous glucose monitoring? I feel any patient who's got type 1 or type 2 diabetes where you really need to look at the exact picture can do it. It is just the motivation that your patient needs and your own conviction. Of course, youth with type 1 diabetes, youth with type 2 diabetes, people who are able to understand and comprehend this, patients even who are on multiple daily injections or insulin pumps. Real-time CGM is a very good device that can help. In pregnancy, the indication is as an adjunct to SMBG, not as a replacement to SMBG. So be very careful because this is going to show you interstitial fluid glucose. This may not correspond exactly with the capillary glucose, so just don't put a sensor and tell the patient not to monitor, especially in pregnancy because she still needs to do the point-to-point monitoring. All this is going to show you is the patterns to rule out glycemic variability. So these are the different recommendations for CGM. As you can see, the Indian consensus clearly talking about type 1 adults where it should be used, type 1 pediatric patients, again it should be used, type 2 patients, especially the ones who are on insulin or oral hypoglycemic agents like sulfonylureas or glenides, it is recommended. Of course, gestational diabetes, like I said, as an adjunct. So friends, to summarize, time in range is a new metric that helps us in better diabetes management. A higher time in range is associated with a lower risk of complications, and there's sufficient data to talk about that. Use of continuous glucose monitoring allows us to assess outcomes of ongoing therapies and accordingly modify therapies as well as MNT and lifestyle to achieve an optimal time in range. CGM has now been shown to improve glucose control and reduce admissions in type 1 as well as type 2 diabetes. And just as an add-on, they are very soon going to launch the real-time tool, where you have the sensor syncing to your phone. So that platform is going to be launched very soon on 10th October. So your patient may not even need a reader anymore. So he just has to wear the sensor and sync it to the phone app. And that is where he will get all the reflections on the phone. So that's the new technology that is going to come very soon. And I would like to end with this quote from Steve Jobs, who says, I think the biggest innovations of the 21st century will be at an intersection of biology and technology, and a new era is beginning. The era is already here. We started with HbA1c, SMBG, we moved on to the Libre Pro, and then we had the real-time CGMS, and now we have the next tool coming in very soon. So a lot of things to look on for when it comes to glycemic monitoring in your patients in aiding therapeutic decisions. Thank you.
Thank you, Dr. Shalini, for a wonderful talk on time in range. And I will just like to ask you, with so many fallacies in the measurement of HbA1c, Is time in range going to be a new revolution in the management of type 2 diabetes? I mean, is it going to replace HbA1c measurements in future?
Absolutely, sir, because HbA1c, like I said, number one, does not give you the true picture. It is just an average, an overview of 3 months. So like the common example I quote to my patients is, suppose your child has 1 year academic year. So you know, in 3 tests, your child is scoring 10 on 10. 3 tests, your child is absent and she's got a 0. Remaining tests, she's performed 6 and 7 out of 10. So the average is still about 75% and you're happy that my child has 75%. But you've completely missed the zeros and you've completely missed the 10s. Similarly, if your patient has a good HbA1c, it could just be a mean value of the highs and lows that your patient is having. So HbA1c may not give you a true picture. And again, like I said, anemia, pregnancy, so many other conditions, hemoglobinopathies, completely you cannot even rely on HbA1c. Somebody with chronic iron deficiency, anemia, long-term anemia, HbA1c can be false low. Short-term anemia, it can be false high. So you cannot really depend on an HbA1c, and that is where time in range seems to be something which is going to open your eyes wide, because it is going to give you a real-time idea of the glucose levels. So very much, yes, new technology as it comes, it helps us in replacing the older technologies.
Thank you. Another thing I want to ask, especially in type 2 patients, which we see frequently, most 90% of the patients, they are type 2. Most of them are on oral hypoglycemic agents, and many of them on basal insulin also. So in this category of patients who are on OHAs plus basal insulin, how frequently we should do this monitoring? I mean, they cannot have the monitor throughout 24/7.
It depends on the motivation level of the patient, and of course the affordability as well, and the need for CGM for these patients. Suppose everything is falling in place and the patient just needs to, you know, kind of get an idea whether everything is fine, he can do it maybe once in a while. But suppose you have a patient where you are seeing that his fasting is continuously high. Bedtime sugar levels are normal. So this is a patient where you need to, you do not know whether it is the glucose levels are going up in the night and morning fasting is high, or whether he is having a nocturnal hypo, maybe an asymptomatic while he is asleep, and that is driving his glucose levels up. Dawn phenomena, Somogyi effect. So all those things, if you are doing a time in range, that is where you can actually find out where is the problem, and you can actually plug that problem and address that problem. So definitely in these kind of patients also,
I mean, instead of doing HbA1c every 3 months, if we do time in range, we put the monitor CGM for 2 or 3 times in a year. That is
actually, if your patient is motivated enough and he can afford it, why not? I mean, we have a lot of patients who are so addicted to it, they'll come and every time they'll say, Doc Saab, it's been 2 months, I put the sensor, can I do it again? I just want to see if my glucose levels are fine. So you have that kind of patients also. So I think it's basically anybody's choice. I mean, we need to offer the best that is available to our patients and let them decide. Of course, if there's an indication, then we should motivate the patient to do it.
Yeah, any questions?
Yes, that is one drawback, especially. Yes, agreed sir. There are 2 things in this. One is maintaining a cold chain is also very important. This is something that I have been informed, and this is something we do in our clinic. We store all the sensors in the fridge only, because there is data which shows that sometimes when there is extremely high temperature, especially in the heat in Delhi, the sensors may not give you a very accurate reading. Number 2, especially in the Libre Pro, hypoglycemia was a challenge there. It was showing a lot of false hypoglycemia. That is why I said you need to document it with a SMBG also. And third thing is obviously this hypoglycemia problem has been addressed in the newer generation Libres, the real-time ones. But yes, hypoglycemia is something that is a little exaggerated. It shows a little more hypoglycemia, especially in the Libre Pro sensors. No, there's no study. Basically what happens is there's too much of glycemic variability, since this is interstitial glucose. So there is a lag. There can be a lag of about 15 to 20 minutes between the capillary glucose and the interstitial glucose. So actually the patient may not be having a hypoglycemia, but there you see it happening. Similarly, it goes for hyperglycemia. So if your patient has a stable glucose profile, then usually what you see in an AGP corresponds to the capillary glucose, almost to the tune of a difference of 10%. But if your patient has a lot of instability or glycemic variability, that means, you know, he's between 300 and 60. That is where the variability will lead to a lag. So that is where the SMBG will not correspond with the CGM values.
I think we need a lot of, because there will be so much of data, so many blood sugar levels in CGM and all this and the graphs. So we need to have a lot of understanding, the doctors and the patients as well.
Absolutely.
A lot of education is to be imparted.
Yes, I think we just need to update ourselves with whatever new technology comes in and adapt it to delivering the best standard of care to our patients. Thank you, sir.
I think with this we come to the end of the session. Thank you so much, Dr. Shalini, for a wonderful talk. Thank you.
So, thank you, Chairperson. Thank you, speakers. Now, I would request Dr. Ahuja. I'll call upon Dr. Rajiv Chawla, sir, and Dr. A.K. Das, sir, on the stage. And please hand over the memento to Dr. Ahuja, sir. I'll request Dr. Shalini, yours also. Okay. So now I'll request Dr. Rajiv Chawla, sir.
Good evening, everyone. So every good thing comes to an end. So has CMRE 10th International Symposium in Diabetes. And I think it has been a very, very satisfying conference. 2 earlier days, Friday and Saturday, we had a virtual international program where we had a lot of logins internationally from Middle East, Southeast Asia, Egypt and UK also. And we had a very long program since 1:30 to 9 o'clock both days, and we finished .9. And since morning it has been almost an exercise of close to 9 hours now. And of course, except the last session, we had a good gathering and we had a wonderful interaction. So I'm extremely thankful, express my gratitude to entire international faculty. Professor Colin is here, Professor Inat Sheltout, Professor Mohammed, Professor Devjit has just left, and our Indian faculty, Professor Das is here, Dr. Mohan was there, Dr. Shashank Joshi, Bansi. So it was, I think, a wonderful scientific feast which most of you must have realized, appreciated, and I'm hopeful that we'll be able to rationalize our practice and use these clinical tips which we have got from our colleagues and senior fellows in our clinical practice in best interest of the patient. So may I request Professor Das to please come on the dais and say a few words, and Professor Colin also for his concluding remarks.
Dear friends, at the outset, a big thank you to Rajiv and Dr. Shalini for a wonderful meeting, for having invited us. It has been a great learning, you know. I mean, I was flabbergasted by the question the audience asked. Rajiv, somebody asked the differential between IFG and IGT management. You heard that. Somebody asked, I mean, very intelligent questions. So it has been a learning for us, and it has been a great learning. So I must say that it is a meeting with a difference. Difference is you had a hybrid model. So the meeting has reached globally and locally and nationally. Third point is that the topics that we have discussed had a lot of interaction, even today, you know, Professor Ahuja was so interested, you know, even Shalini had about volleys of questions, and you know, it is something, I always believe you can only improve what you measure. The quality cycle measure goes around a circle, measure, act, improve. So that's why these measurements have become the order of the day. The question you asked about the type 2 diabetes on orals, whether it's important or not, I think it, as Shalini said, it is customized. Depends on the patient you are seeing. It is not for everybody you need. but some people having some bizarre fasting and all that, you need it. I have a patient, Arun Patel, he's a close friend of mine, whose H1C is always low. But you do a TIR, you'll find hayward blood glucose. So we found out it's a hemoglobinopathy. So things like that in type 2 also it is very beneficial. And all the topics have been very well discussed and had touched the heart of the people. And you know, you go back, you know, it is possibly important that what we have learned, great learning from Dr. Doyle. I mean, no, he started, sir, from the Cardiff. When you came for the first time, I was here. And you know, your presence is different. And you electrify. And I again repeat that our practice in India is closer to British practice. Therefore, we learnt a lot from your deliberations and all the talks. Type 1 was superb. And we are getting the molecule in India, and we don't know how to use it, and it will be coming next year. So the meeting had the recent advances, the clinical things. Only thing that people have gone back from here and will apply it in the clinical practice for the benefit of the patients. Again, it's very sincere thanks to all the people involved in the CMRE, to the Dr. Inas, superb. I mean, your talks were beyond description, both the talks in women and also the OB children. And I think it is a great meeting. And I pray and wish and I'm sure that this meeting will make a dent in the country's diabetes healthcare and innovation, and will be moving forwards. Thank you, sir. Over to Professor Dayan.
Thank you, sir, for your blessings, Professor Colin. And I'll also request Professor Inas to say few words toward that.
Thank you. Thank you very much for this opportunity. Every time I look at the program, I think, oh, now, what is that going to add? And every talk that I've listened to today, I thought, that's what it's going to add. There's a little bit more. And I've been taking notes and I've been adding things. I hope you have as well. I do feel that every year there is a new window opens in diabetes management. We've heard about some incredible new drugs today, a whole new chapter, weight loss that you couldn't even begin to imagine, monitoring of glucose that you couldn't even begin to imagine. And we had, I think it was Dr. Hassanain who showed the graph of new drug discoveries. For many people here today, we were stuck with metformin and glibenclamide and insulin for years, and there was really nothing else. And now every year things change. So I'm really grateful to Rajiv and to Shalini for making this happen so that people can be reflective, because our practice has to change every day, and this provides a great opportunity for us to do that. So very great thanks to you for this opportunity.
Thank you. Thank you, sir. I think your contribution towards our growth over 10 years has been immense, and you have been part of this program as a core strength since day one, sir. Thanks a lot. Professor Inas, please.
It was my pleasure and honor to be part of this important program. Thank you very much for the invitation, and thank you for the cooperation for many years now, and it was very fruitful, and Egyptian doctors kept asking me how to log in and how to use the link. So I know we had many audience from Egypt. Thank you very much, and towards more future cooperation.
Thanks a lot, madam, for partnering with us in this initiative and in this journey towards excellence. All of you have been part of it, and probably you made it possible. And then I'll extend my gratitude again to all domestic faculty, all chairpersons. Dr. Ahuja is there, Dr. Goel, Dr. Vijay, and the audience and the delegates, those who made it a real success. Thanks a lot, and I'll invite all the faculty members to please come on the dais for a final photograph. Sir.